Good morning, everyone. Welcome to the day 2 of our second Advanced Endoscopy Conference, organized by Sai Institute of Gastroenterology and Liver Sciences. So I'm sorry we're 25 minutes late today, but we'll start with our first session. So I would like to invite our speaker for the first session, Dr. Asutosh Mohapatra. His talk is on how to detect early gastric cancer, tools and techniques. And for this, I would like to invite all the chairpersons on stage, Dr. Noria Oido, Dr. Umang Arora, Dr. Jyoti Ranjan Swai, and Dr. Kunal Nandi, Dr. Amir Ranjan. Please, on stage.
Good morning, everyone. Before I start, I think I must introduce our guest speakers first, because you must know who are our speakers. You must have heard about Professor Noria Yodo, who is a internationally recognized ESD specialist, and his focus is on early gastric cancer. He is now very popular in India, and sitting in my front is Dr. Rahul Panala, who is from Mayo Clinic, USA, and who taught Dr. Sanmun Mohapatra all the intricacy of endoscopy. And Dr. Radhika, the beautiful woman sitting here, she is the US Queen of India now. Next to is Professor Jimil Shah from PGI. So no jokes, because I mean that they are now national figures. Jimil Shah from PGI, Chandigarh. Srihari from Gangaram. I'm not old. I'm not confusing Srihari with Sundaram. He is Srihari from Gangaram. I think I'm correct. Srihari from Gangaram, whose passion is not restricted to one, motility. Now he has started searching for early gastric cancer. I do not wish him success in early gastric cancer. Next is Sridhar Sundaram, who is from Tata Cancer Center. Now you can find him in the conference. Outside the conference, you can't get even 1 minute. Next comes the very young gastroenterologist, Sukrit Sud, who has made a name for himself in a very short span of, I think I came to know about him within last 3 years. And other gastroenterologists are there. And I always say about, don't point your finger, I know Nijavan sir. I have told about him 100 times, that Nijavan sir is the innovator of all foreign body retrieval basket. I don't know how much innovation he must have done for the poor patients. And always tell the most important, passionate, if you say, tell me about 3 passionate people of India, one will be Dr. Malay Sharma. One will be Dr. Malay Sharma, who sleeps with US, who eats US, who chews US. Now I'm starting. Someone told just, I will take 5 minutes to finish. So my job is how to detect early gastric cancer. Yesterday, Dr. Noria also showed some beautiful cases. So before 2018, I didn't get even one early gastric cancer in Odisha in my 10 to 12 years of practice. Then I visited Japan multiple times. Actually, I went to NCC for 1 month. I could not learn anything. That I told to Dr. Abe also, that is not, they taught me so many things. But what happened, at that time I didn't have any good scope, only 150 series scope. And at that time there is no concept of early gastric cancer in Odisha. So I think there should be a good coordination between the endoscopist and your pathologist also. I went to Dr. Noria, I think not in 2000, which I think I went the year 2019. Then multiple times to Dr. Noria. So my detection rate was 0%. Now after coming back from Noria, I changed completely my mindset. I stopped doing EUS and I stopped almost doing ERCP, though it was painful for my another mentor, Dr. Malay Sharma, who taught me EUS and ERCP also. So I understand your pain, sir, but somehow I was attracted to mucosal pathology. So always give a mucolytic and deforming agents to all your patients, and soft black hood is a mandatory. Use always a high definition endoscope. Follow diligently SSS protocol and avoid blind spots. Take at least 7 minutes. We take usually not 7 minutes, sometimes we take 10 to 15 minutes. I told Dr. Noria also, I don't know, I am not an expert like you, but that's why I am taking more time in examining the stomach. So here you can see the first lesion. So this is on white light endoscopy, there is small depressed lesion, but you can see on zoom endoscopy, this is suspicion of early gastric cancer. And the biggest enemy of endoscopic examination is froth, bubbles and mucus. So you have to remove it, otherwise you cannot see anything. You can see the whole of antrum is obscured by the bubbles. Next. You can see mucus is covering an early gastric cancer. After the washing of the mucosa, this is again a suspicious lesion. And as I told, this is not very complex. Once you start practicing, you go to the antrum, you see the lesser curvature, you just go clockwise. Previously in our DM days, I will say the lesion is in the antrum. Now you can see antrum has been divided into so many parts. Greater curvature of the antrum, posterior wall of the antrum, lesser curvature of the antrum and posterior wall of the antrum. Likewise lower body, greater curvature of the lower body and anterior wall, lesser curvature, posterior wall. So it has been divided into so many parts. So you have to take at least 22 pictures. So this is mandatory in our unit. Nowadays our one junior has joined us. He also finding it difficulty to take such a images and video recording of everything. So how can you suspect early gastric cancer? That is more important. Look for slight color change, whether pale or slightly reddish, and slight surface change. Colors and surface, these are the two most important things. And spontaneous oozing, even 1 millimeter oozing in the background of atrophy, if there are no multiple ooze, different size, that is different matter, but a single erosion, that's suspicious. Thickened or irregular fold, disappearance of vascular network. So how to proceed. Once you find a suspicious lesions, look for demarcation line. What is most important is what is demarcation line. Demarcation line is abrupt change in microvascular pattern or surface pattern from the surrounding mucosa. That is called demarcation line. So once demarcation line is present, then look for irregular microvascular pattern or irregular microsurface pattern. If any one of this is present, this is cancer. You can diagnose with 95% accuracy. This is called VS classification. So after coming from Japan, we did a study. I discussed with Dr. Nauria, who is my mentor, how to go that. Dr. Nauria told, even if you diagnose 1000 early gastric cancer, nobody is going to believe it. That is a rumor. You have to publish. This is at the age of 53, this is my first publication. And fortunately, this is the first publication from India. So we got 6 early gastric cancer, 2 synchronous lesion. Even in our last workshop, yesterday's workshop, we have 2 early gastric cancer having 2 synchronous lesions. Both were having synchronous lesions. And of course, Dr. Noria found another. So all EGC patients were male. I think during the learning curve, it is very difficult to detect undifferentiated cancer. What is corkscrew vessels, all those things. That's why I could not detect even single undifferentiated cancer at that time. So this is case 1. Oh, this was not referred to me. This was referred to Dr. Sonmun for ESD in a different hospital. So the gastroenterologist is a very good one there, Dr. Pratap Behra. He told he has found a lesion with low-grade dysplasia. Dr. Sonmun told, let's go and do ESD. He invited Sonmun for ESD. And so when Sonmun put the scope, she told, no, it's early gastric cancer, not adenoma. So ESD was done, and this is the ESD specimen, and this was the histopathological diagnosis. Again, I will show some videos. You see, this is a reddish lesion in the lower body towards the posterior wall. I think some slides missing. There is no video. Huh? Video, oh, yes. She knows better than me that there is a video here, because she has done ESD in this patient. So you can see, video is not running. So there are 2 suspicious lesions. You can see early gastric cancer will look like just an irregular mucosa, but on zoom endoscopy, you can delineate it better. There is irregular microvascular pattern and absent surface pattern. So this is very, very common. People think that we don't get, but yesterday my job was not to convince myself, my job was to convince my mentor that we get lot of early gastric cancer. To your surprise, Dr. Nauria is staying 1 day extra with us. If anyone wants to stay with us 1 day, you can stay with your own expense. So application of VS classification, you can see again incisura, reddish depressed lesion. But you see, here is a demarcation line, but the pattern is regular, microvascular pattern and microsurface pattern is regular. So this is non-neoplastic, though demarcation line is present. But always search for demarcation line, always. So here again pre-pyloric lesion towards the lesser curvature, there is a lesion. But on zoom endoscopy, you can see clearly there are irregular vessels. So this is demarcation line with irregular vessels. This is neoplastic. My other surgeon colleague Lalatendu is here also. I showed him in 2019 that I am getting early gastric cancer. He did not believe me. He thought Bhaiya is joking. Bhaiya is, our elder brother is bluffing. At that time he must have thought. Lalatundu, you are here? Ah, he's here. So in this patient, you can see a depressed region in the posterior wall of the lower body with slight elevation. I'm just showing the videos so that you can see how early gastric cancer in Odisha look like. Why I'm saying early gastric cancer of Odisha and early gastric cancer of Japan, Dr. Noria not now very much convinced about the difference, but I think we are getting very, very small lesions, which is very difficult to detect. We showed him, yesterday also we showed him 2 patients. You can see normal mucosa. From this, nobody can diagnose early gastric cancer. In the pre-pyloric region, at the 6 o'clock position, you look at the 6 o'clock position, small depressed lesion. Then on NBI, you see the irregular microvascular pattern and absent microsurface pattern. So this is early gastric cancer. Another video, I'll not take much of the time. I think 8 minutes is, no, it's okay. Okay. This is the lesion you see. This patient was operated in a Sridhari or Mumbai hospital. They operated him. Small lesion. We requested the patient, we begged the patient, please come to us for ESD, but he did not listen to us. He thought we are from a very small center. We cannot manage him with, or in India nobody can manage with ESD. That surgeons has a very convincing power. He told, go for gastrectomy. That poor fellow of 70, I think, what is the age? Around 68, 70. So he was operated. We did indigocarmine. In all our patients, if we get a suspicious lesion, we do NBI examination, then we put indigocarmine, and then we look for targeted biopsies required. So this came out to be signet ring cell carcinoma. So pale mucosa diagnosis is either multiple lymphoma or undifferentiated cancer or adenoma. These 3 usually. So this is the best video. I've shown it in many conferences. Esophageal cancer. So once you see esophageal cancer, don't stop there. Look for early gastric cancer. So you can see there's atrophy and absent RAC, but this is a simple erosion. This is benign erosion. But once you see in the distant, there is a reddish mucosa. I told in the beginning, look for reddish or pale mucosa. Reddish mucosa with an irregular surface pattern on the near focus. This is clearly visible, even to the in the white light examination. White light examination is also very important. On NBI, you can see clearly demarcation line with irregular microvascular pattern and microsurface pattern. Here is irregular. There is another lesion. So this patient has 3 cancer. 1 advanced esophageal cancer, 2 early gastric cancer in the stomach. So now, as I presented in many conferences, anybody can say now, like Sridhar and Srihari was this before. So can you find the lesion? Sir, Bhuvan sir, can you say where is the lesion? Where is cancer? Because sir is a very famous surgeon from Odisha. Where is the cancer in this? Which one, sir? So in this case, even white light examination did not help, NBI examination did not help. What helped is chromoendoscopy, which showed thorn-like appearance, spicules. So that is suggestive of well-differentiated adenocarcinoma, but our biopsy was undifferentiated cancer. So Sonmun did ESD. I think let's come to the take-home points. Check for H. pylori status, infected or uninfected. RSC positive indicates H. pylori, uninfected stomach. If whenever there is severe gastric atrophy, always search for early gastric cancer. Pale mucosa suggests undifferentiated cancer. Always look for pale mucosa. Thank you so much. Mike.
Thank you, Astos. You exceeded 5 minutes for presentation.
Oh,
But yeah, it's okay. Yeah, we take some question. Do you have any question? I really impressed that you present your own image. Sometimes they copy paste published
I forgot to
data
tell that.
or published image, but
always
you
I tell
present
this
it.
is my image, but somebody told me this looks arrogant, don't tell your image. So I didn't tell that these are all my images. Lalatundu. We must take from the surgeons first. Ask.
Yeah, and good morning. We have been discussing with Dr. Astos. Whenever he diagnose a case, he come to me. See, I diagnosed this case. So for last 2 years, I am with him, diagnosing all the. He showed me, and I sent to his mentor. But my one point, sir, when you diagnose a case of early gastric cancer, what is your protocol? Do you go for a CT scan to know the depth of the invasion and nodal status? Although it is a very rare thing, and what is your follow-up? How do you follow up the patient following early gastric cancer resection?
Usually for early gastric cancer, protocol is no CT scan. For how can you know the invasion depth? That is from white light imaging. This is not from even NBI imaging. So there are certain features like converging of folds, what is called extension signs are there. There are telltale signs which suggest that this is limited to mucosa, no submucosal invasion. And second is, even we do not do any cancer means people will think do PET CT. So PET CT has no role. I think Dr. Nauria can explain better.
I agree.
So we
PET
we do histopathological study. If it is limited to mucosa only, we go for ESD. After ESD, every 1 year follow.
Do you think US has any role?
US has almost no role except when you suspect it is submucosal invasion, you can do US to know the depth of invasion.
Thank you.
Dr. Noria, you can explain him better.
CT scan sometimes we do as a part of the staging. So basically indication is T1A, N0, M0. So
Okay.
you have to prove. Yeah. Srihari.
I think Dr. Noria will not agree with me because I jumped from 150 series scope. I never used in my life 190 series scope. First I jumped from 150 series directly to 290 series zoom scope and endocytoscope. So my eyes get tuned to these scopes. So with 190s now I am unable to get even single early gastric cancer. But all my diagnoses are with 290 series zoom scope. That's why I get very small lesions also, which is sometimes you apply NBI, you get it. Even in white light, it is not difficult to diagnose. There are 2 to 3 occasions I could not. I went through the antrum, but when I switched on NBI, very high definition scopes, then irregular blood vessels. I don't know. I don't have any paper to establish my claim, but I am not in favor of. Olympus people are not here, I think. I am not in favor of 190 series scope. I am always in favor of X1 scope or like 1200 scope. This is 100%. 1200 scope is much better than 190 series scope. I never advocate 190 series scope.
According to our data, previously we evaluate diagnostic accuracy of HQ290, not 190, but near focus score. The diagnostic accuracy is almost similar to zoom scope. So, But I think basically the diagnosis to evaluate vessel microvasculature, I think that resolution is good enough to evaluate the irregularity. So I think diagnosis actually changed, not so much change.
Sir,
Okay, last question.
sir, good morning, sir. My question is that when we're sitting in the OPD and taking the history of the patient, and because H. pylori is quite common in our country,
Mm.
so I'll ask you, Dr. Mahapatra, that how does history differ? The early gastric cancer, if you categorize the early gastric cancer and H. pylori related, because all that specimen will not turn into malignancy. Is it some there are cases there will be no malignancy and there are some H. pylori related. Am I correct?
I think your question,
Retrospectively, how the history differ? H. pylori related that is people and the
early gastric cancer is usually asymptomatic. Most of the cases of early gastric cancer, more than 99% asymptomatic.
Okay.
Okay, thank you.
Okay. Thank you, Ashutosh. So we would invite next speaker. Yes.
All right, thank you so much for these interesting questions. So from audience, they asked about the role of EUS in diagnosing early gastric cancer and the role of EUS. So our next speaker, Dr. Radhika Chauhan, she is from Pune, Bharatiya Vidyapit. She has a lot of experience in EUS and she was trained in AIG. So she will be talking on evaluating resectability before ESD of early esophageal and gastric cancers, the role of EUS. So she will educate us more.
Thank you, Sunmoon and Ashutosh sir. I am Chauhan, basically, not Chauhan. Okay, so today's my topic is role of endoscopic ultrasound in early esophageal and gastric cancer. Does it guide endoscopic intervention? So what is early cancer? Early cancer, which is limited to submucosa with no deeper involvement or no loco-regional or distant spread. In early cancer, that is T1, again classified into T1A and T1B. So why it is important for us to know submucosal invasion? Especially for a squamous cell carcinoma, any kind of submucosal invasion is associated with a recurrence and lymph node involvement. In this meta-analysis, they showed even less than 200 micron was associated with a recurrence. So even guidelines suggest before considering endoscopic intervention for early squamous cell carcinoma, you have to rule out submucosal invasion. So responsibility for endosonographer is to differentiate T1 from T2. T2 is which is involving muscularis propria, and T1 is limited to submucosa. In submucosa also, we have to differentiate T1A from T1B, especially for a squamous cell carcinoma, and to rule out lymph nodal involvement. So we have three kind of US scope. One is radial, linear, and mini probe. Mini probe uses very high frequency up to 30 megahertz, and it can be passed through gastroscope. It gives a 360 view, but it can be used only for a diagnosis. So with endosono, we can see all the layers very clearly. With low frequency probe, we can see 5 layers. So we can see whether that cancer is limited to mucosa or submucosa. But with mini probe, we can again differentiate which part of mucosa it has involved or which part of submucosa it has involved. So with mini probe, we can see a 9 layer of a lumen. And what are the US features of malignancy? Usually, malignancy appears as a hypoechoic lesion, and you have to see the wall layer architecture, means which layers are involved and which layers are not involved. So if you see irregularity of submucosa, that is means SM1, means involved in a superficial layer only. If you see thinning of submucosa, means SM2 and SM3 involvement is there. If you see loss of wall layer architecture of all 4-5 layers, then it is definitely T3, T4 cancer, it is advanced cancer. You can see the waist shape deformity, it usually seen in a SM1, means superficial submucosal involvement. When you see thinning of submucosa, it is SM2, means submucosa is involved more than a 2/3 of is length. So definitely US has a role, but the diagnostic accuracy is less. It is around 80%. The specificity is around 77%. Sometimes it is very difficult to differentiate whether it is infiltration because of tumor or whether it is peritumoral fibrosis. So with endoscopy we can't differentiate, and overstaging of tumor can occur from 19 to 24% in presence of fibrosis, and understaging can occur up to 30% depending on the tumor size and location. So what are the methods to improve diagnostic accuracy with endosono? So how can we increase the accuracy with the endosono or with a mini probe? Basically, you have to place a probe which is perpendicular to the lesion. What I do, I pass the scope beyond the lesion, and while withdrawing, I scan for the lesion. With that, you can see, at least you can visualize the lesion. Second, there are some locations where you are not able to see that lesion properly. So you have to manual. So these are subepithelial lesion, not a gastric cancer in this patient. It was in antrum, but they are very difficult to scan because water doesn't stay in antrum in a left lateral position. So what I do usually, I put a water and I usually see the flow of water. And based on that, what I do, I change the patient's position from left lateral to supine. So with that, we can see a lesion. You can see the very well-defined lipoma here. So in this patient, I have changed position from left lateral to supine, used an antiperistaltic agent. You can use a balloon also. So it is really useful technique to increase the diagnostic yield for a small lesion, small cancer. Second, these are the method you can use with a mini probe. One is water filling method that we usually use. Second is balloon contact and jelly filled method that we are not using jelly filled method. So what is water filling method? In esophagus, definitely there is a risk of aspiration when you put water in esophagus. So in this study, what they have used a transparent condom. They have attached transparent condom to the gastroscope. With condom, they have passed the gastroscope into the esophagus, and then they filled a condom with a water channel scope, with a working channel, and after that, they passed mini probe. So with this, their diagnostic accuracy is improved. The problem with the balloon is you can't differentiate M1 and M2. The first, second layer get merged with a balloon method. In that case, definitely jelly methods improves the diagnostic accuracy. But this is another method where you want to see a early esophageal lesion and you can't instill a water, you can go for this method. How to use a jelly? Either you can use a double channel scope, and through one channel you can pass the jelly. You have to use a very thin jelly. Basically, it is available in a cardiac department. They use for 2D echo. That jelly can be used to inject through a scope. And second, other method is you can attach a tubing, normal saline tubing to the scope, and through that you can put a jelly so that your water gel will not get occupied, will not get blocked. So these are two methods that way jelly can be injected. So there was definitely a difference between water filling method seen on an endosono. I don't have my videos of these two methods because I don't have mini probe. But you can differentiate, you can very clearly see. In this case, initially they have used water and now they are using a jelly. So with jelly, you can definitely localize the lesion. You can see a all layer very clearly, and you can see the characteristic of a lesion. And in this study, they have showed jelly method was very much accurate compared to the water filling method. The overall accuracy for invasion of depth was better with a jelly method. But problem with the endosono, either it can overestimate or underestimate. So overestimation is possible when the location is in a lower esophagus, And underestimation is likely possible when tumor is more than 3 centimeter or when there is a circumferential spread. So this was a lesion, it was referred for me ESD, it was adenocarcinoma of a G junction. That patient had a CA breast history in the past, and I did an endosono with a linear echoendoscope. Initially, I thought it is resectable in one plane, but in another plane, I thought it was touching muscularis propria. In this, when I froze that image, initially with this image, I thought, okay, I can go for ESG, but this image gave me doubt that it is little advanced. Definitely it is T1B, may likely be T2. There was no muscularis propria thickening, but the submucosal thinning was definitely there. So I did not proceed for ESD in this case. It was a bulky, large lesion. I sent her for a surgery. So definitely overstaging and understaging can occur. For gastric cancer, it happens with ulcerated lesion or poorly differentiated lesion. So which are the cases good for endosono that can increase the diagnostic accuracy is body lesion, well differentiated tumor, and definitely radial scanning can increase the overall diagnostic accuracy. In compared to other probe, definitely mini probe is better. This is one really good article, only one article I found it, that whenever there is a small lesion, what you can do, you can inject a normal saline, elevate that lesion, basically a lifting sign, and you do endosono. And in that case, definitely it improved the diagnostic rate. The misdiagnosis rate really came down. The only problem with a normal saline injection, if you are not attempting ESD at that point, maybe in future it will make your ESD difficult because it may cause a fibrosis. So if you are planning for ESD in same time, maybe you can see in the same setting, you can inject and do endosono and see for the deep layer involvement. Now artificial intelligence is booming everywhere. Definitely it is going to reduce our stress, whether it is T1A, T1B, T2. Maybe in a 2-3 year we'll get many more studies that can help in differentiating this cancer with an endosono. So other scope, definitely mini probe is better than a radioscope, and linear was found to be better, but results are conflicting. For staging, definitely I prefer a radioscope over a linear, but whenever I want to take a FNA, I go for a linear scope. NBI, nowadays we are having an image enhanced endoscopy. The role of US in a cancer definitely is doubtful because with a high image enhanced endoscopy, but this meta-analysis, what they show, though there were similar diagnostic rate with the NBI and high frequency endoscopic ultrasound, the positive likelihood value for invasion was much more with a high frequency endosono. So what we can do, we can combine endosono with a white light endoscopy, and with combination method, the diagnostic accuracy definitely get increased. It can get increased by 10 or 15%. So definitely it is useful in nodal staging also. What I suggest, whenever you are dealing with early gastric cancer, if you suspect any submucosal invasion, you can subject that patient for endosono, rule out submucosal invasion, and according to that you can plan for a endotherapy. But for early esophageal cancer, the role of endosono still doubtful. Basically, diagnostic accuracy is not very good for esophageal cancer to differentiate T1A from T1B. So to summarize, endosono definitely predicts submucosal invasion and has a similar accuracy of NBI. It should be used with a white light or magnification endoscopy. Arc-shaped deformity and submucosal thinning defines submucosal invasion on endosono. Mini probe, you can go for a jelly method and or a water infusion method. Use an antiperistaltic agent, change the position for an antral lesion, and be careful while scanning ulcerated lesion, larger lesion, and undifferentiated lesion, because overestimation or underestimation likely possible with this lesion. Thank you very much.
question from the floor or chairpersons?
Question. Actually, before planning EHD, do you do a biopsy of the lesion, and does the histology change your decision, whether it is a well-differentiated tumor or signet or undifferentiated? So if the biopsy comes out to be a signet or undifferentiated, do you go ahead with EHD, or does the plan change?
Before going for ESD, we always take a biopsy from the ages, whether it is really which type of cancer, well differentiated or poorly differentiated, and based on the size and ulceration, we take decision whether we have to go for a surgery or endoscopic intervention.
Histology doesn't change your decision.
Poorly differentiated, less than 1.5 centimeter, I think we can go for endoscopic intervention. And so, I think he's talking about endoscopic intervention. Sridhar, neck.
Okay. No question, maybe. Yeah, I would like to invite next speaker. So next speaker is Dr. Sridhar Sundaram. Sorry for my poor pronunciation. But he's talking about the diagnosis and treatment of early esophageal cancer. Please welcome.
Okay. Are we good? Okay. Are we good? Yeah. Can you? Thank you. So very good morning to one and all, and once again I'd like to thank Dr. Mohapatra, actually the Dr. Mohapatras for this opportunity. So I'm going to be speaking on diagnosis and management of early esophageal cancer. This is a brief overview of how my talk. I'm going to be talking briefly about epidemiology, detection, essential considerations, the procedure, and long-term complications and outcomes. So if you look at Globocan data, esophageal cancer, I mean, India ranks in the high incidence and high mortality region for esophageal cancer. But then again, if you look at data on early esophageal cancer, there's barely any data on early esophageal cancer in India. The issue is, of course, detection. So how to pick up early esophageal cancer is, of course, a critical question that really needs to be asked. There is really no formal screening program in India, and we are largely dependent on opportunistic screening alone. So clearly, as endoscopists, we need to have a slow examination in the esophagus. NBI or some other form of electronic chromoendoscopy, either while going in or while coming out, that is often helpful. It often helps pick up small lesions. Take your time to clear the mucosa, wait for peristalsis. And of course, flag the patients who are at higher risk, especially those with head neck cancer, chronic tobacco users. They are the ones where you'll have a higher yield. So clearly, the core tip is that if you have a good examination, there's an increased chance of detecting lesions and an increased chance of doing an ESD and cure. I'm going to be largely speaking on ESD and not EMR because I think that is the critical discussion here. So what are the essential considerations when you're talking about esophageal ESD? You're talking about the site where it is, the upper, middle, or the lower esophagus. Upper is often difficult to do, but still can be done. Surgically, I don't think upper is a good site even for surgeons. So I think that is a good site where endoscopists can actually do dissection. Size of the lesion is very, very critical. Very long lesions may, of course, have more complications. Circumferential involvement, I'll come to that later. Morphology of the lesion, prior biopsy or any endoscopic resection attempted. And of course, importantly, in the esophagus, in the stomach, and in the colon, any luminal cancer, multifocality is often the rule rather than the exception. So you always look for more than one lesion if you find it. What about morphology and depth? We all go by the Paris classification. This was given sometime in 2002. And if you look at the different stages based on the Paris classification, the depth of invasion varies significantly. So if you have a protuberant lesion that is a 0-1 lesion, you will find that the depth of invasion is typically toward more towards the submucosa. Similarly, the flatter lesions, like extremely flat lesions or slightly raised lesions, tend to be involving only the superficial aspect and do not go deeper. So clearly, it's the flatter lesions that are better for ESD rather than the polypoidal ones. Why do we need image-enhanced endoscopy is something that really needs to be asked. And, of course, we're making a diagnosis is very, very critical. So one, you need to detect the lesion, and second, you need to, determine if this lesion can be resected endoscopically. So both can be done by the help of image-enhanced endoscopy. So I think we all dependent on NBI. Before NBI, we were dependent on dye-based lumbar endoscopy. Lugol's was the standard. So this is one patient of ours wherein there was a very flat lesion. Again, with Lugol's spray, you can actually find this is the lesion that is unstained, and that is typically what the cancer is. Again, Lugol's can also help predict depth to some extent. You can actually see that the tummy sign here, it's basically a Japanese mat of some kind. I'm sure we also use a similar kind of mats. So you can see the matting on the surface. Now, this very patient also had another lesion in the upper part of the esophagus, and that is also unstained. And clearly, you can see that it is not showing the so-called matting that you can see here. So again, this lesion, slightly more polypoid, may be deeper, as compared to the lower lesion. So Lugol's, high sensitivity but low specificity. Again, there are other signs like the pink color sign, which you can often use, increases the sensitivity and the specificity. But then again, this is not commonly used by endoscopists anymore because it's cumbersome to use. Again, there's data to say that, as compared to chromoendoscopy, NBI is better, but whenever you are in doubt, it's preferable to go back to your basics, go back to, using Lugol if you're really not sure about a certain lesion. But again, as millennials, I mean, we all have it rather easy. I think we've all seen the evolution of technology through our lifetime, and clearly we're also, victims of our own when it comes to electronic chromoendoscopy. We don't do so much of Lugol, so we are all happy with the push of a button. So we all use NBI, and esophageal mucosa is typically featureless, and we depend on the microvascular pattern. And Professor Inui actually gave his classification initially on the IPCL pattern. And subsequently, of course, we started using the JES classification, which is the Japanese Endoscopic Society classification for early esophageal cancer. And there are, of course, grades, and A, B1 are typical. A is normal, B1 is superficial cancer, B2 is up to the muscularis mucosa or superficial submucosa, B3 definitely deep. The distinguishing features are dilatation, tortuosity, change in caliber, varying shape. So I'll come to images, and again, demarcation line may be evident. So this is a normal mucosa you can see in a patient. I mean, this is otherwise how a normal IPCL pattern would look. This is again another patient. You can see this is a slight demarcation line that you can see. You can see this is the JB1 pattern. This was actually, an intramucosal squamous cell cancer. So yeah, we also did a Lugol's. You can see the Lugol staining here. This is the pink color sign that you can see typically. Then this is another patient, a slightly raised polypoidal lesion, but you can see that the lesions are no longer, the vessels are no longer, coiled. There are some coiled vessels, but again, they are more linear here. This was actually a B2 kind of a lesion. The patient was a poor surgical candidate. We did an ESD. It was an SM1 lesion. Again, this is another polypoidal lesion in the esophagus. Again, in this patient, you can see they were not coiled. They were straight vessels. But at the edge, you could actually find the big ones, almost 3 times the size of the other vessels. And we also did an EUS. It was actually a deep invading cancer, squamous cell cancer. So this eventually underwent surgery. What about role of EUS? I think Radhika's done, has covered this aspect. I think this was all based on this seminal paper. And there were some challenges, of course, differentiating T1A and T1B, accurately predicting depth, and also, the use of mini probe. All of these are challenges that we face in the esophagus. When it comes to data, I think this was an elegant paper by Yuru Ishihara's group, which said that there is significant overstaging and understaging by use of, endoscopic ultrasound, and which is why at least EUS did not add to information on depth as per this paper. And in the JES guideline, the Japanese Esophageal Society guideline, there is really no role for EUS. In the ASD guideline, it is left as a question mark. It's not been answered, rather. So again, if I look at the ASD guideline, they would say that any submucosal invasion is considered non-curative, and lesions more than 1.5 centimeter preferable to do an ESD and surveil them. On the other hand, if you look at the JGES guideline, they'll say that any lesion, T1A is all good. Less than 5 centimeter, it is curative. More than 5 centimeters, you have to think of additional therapy. Again, circumferential, non-circumferential changes your role for adjuvant. And lastly, of course, the JES guideline. This has come only in 2023. Again, here there is ambiguity. They say that anything involving the muscularis mucosa and the upper submucosa is non-curative. So again, they say that anything going to the muscularis mucosa is also non-curative and should have adjuvant therapy. So at least when you look at the different guidelines, there is ambiguity with respect to PT1A muscularis mucosa or the one going up to the upper submucosa. The natural history is unclear. It's based on poor quality evidence. The recommendation would favor adjuvant chemoradiation and surgery. At least we are part of a trial now wherein we're looking at observation in these patients. So I think we'll find out the answer to that very soon. Coming lastly to the procedure, if you look at ESD, you'll have to choose your patient well, you have to have a checklist. I guess all of us follow the checklist manifesto. So you should have a good checklist before you embark on an ESD. There are certain essential equipment requirements, a high definition scope, good cutting equipment, hemostatic equipment. Closure devices, not so much in the esophagus except for clips. Traction devices, typically your dental floss works well, and additional accessories like your triamcinolone and stents, you should have handy. Schedule an ESD, very critical. Prefer to do it after a couple of procedures. You're a little warmed up. Keep the rest of the day light. Take time to assess and go ahead with procedure. Anesthesia backup is essential. Surgery should be informed in case of a difficult ESD. And most importantly, before you embark on a long ESD, have a meal. You don't want to be crabby during the procedure. So please make sure that you're well fed when you're starting an ESD. Coming to the essential steps, first is the incision and marking. You typically mark 7 to 10 millimeters away from the lesion. Start from the distal end first, then go to the proximal end, dissect in a C shape because it prevents escape of the submucosal injectate, and the lateral incisions are typically challenging. So you can see the images here. Again, this patient we did, and again, you can see the C-shaped incision. What about submucosal dissection? You prefer to use a dual knife or an IT knife. They are not longer as compared to the TT knife. TT knife is around 4.5 millimeters in length. You preferably do not use it unless, of course, you're doing a tunneling kind of a dissection. You try to do a slow dissection. Clip and line traction is the way to go. For esophagus, I don't think any other traction methods work so well. And for circumferential, tunneling is the best. So we'll just come to, and again, you can see the clip line traction. And there is data to suggest that traction is better in terms of lesser complications, lesser procedure time, and lesser need for submucosal injection. So make sure that you use traction for these patients. So let's go to a video. This is a small polypoidal lesion in the esophagus, distal esophagus. We did marking. And you can see after marking, submucosal injection. So we are taking the distal incision first. Once you take the distal incision, you dissect. Then you go to the proximal end and you're trying to dissect on that end. Then this is the submucosal injection, submucosal dissection that you're doing. Again, you created a small pocket here, going to the other edge, lateral edge, because the lateral edge is often difficult to get into. Then you apply traction with a clip and line. And once you apply traction, you'll see how well the submucosa is exposed. You dissect in the submucosal plane, and I prefer using an IT knife. Maybe that's because part of my training was in NCC. They use the IT knife quite a bit over there. So yeah. Okay. Defect closure, it's often challenging in the esophagus. You can use a fully covered SEMS. Larger clips often go through the defect, so it's preferable not to use larger clips. In centers where it's feasible, of course, suturing is an option, but I don't think all of us have that option. In case of very large defects, so near circumferential defects, preferable to use local steroids as well as oral steroids. Again, this is another large circumferential lesion. I'll quickly go over this. So distal marking first and proximal marking. Then distal incision, you take first. So you'll find the distal incision. This is the distal incision first. Then the proximal incision. Then the tunnel. Then you're joining the tunnels. You can see that the tunnel is joined now. And once the tunnel is joined, then you can see there are two tunnels that we've created. You apply traction with a clip and line, joining both the tunnels, and you have only the edges to dissect then. And then eventually you're able to get the whole lesion on block circumferentially, and you can see a clean circumferential plane. Yeah. So preventing stricture in non-circumferential cases, of course, chemoradiation is often a risk factor. Location in the upper thoracic or the cervical esophagus is a risk factor. At least if you look at our data, we just submitted this to DDW, our ESD days acceptance is there. In circumferential or near circumferential lesions, it's around 45%. So the JS recommendation would be to give triamcinolone and short course of oral steroids. And again, there is a recent systematic review on the same to suggest the same. What about prophylactic stent placement, stricture? I mean, very small data, only 8 patients in this series by Antonio. But again, I would not recommend this as a primary strategy. There is need for trials over in this area at least. So longevity is the key. If you look at long-term outcomes, 5-year disease-specific survival is upwards of 97%. Local recurrence is very low for ESD, 1.8%. And again, in comparison between ESD and esophagectomy, there is no difference in overall survival, disease-specific and recurrence-free survival. And ESD has fewer adverse events as compared to surgery. Again, added therapy for high-risk lesions, clearly there is data also to say that adjuvant chemoradiation works well after ESD. So survival is pretty much the same, 3-year overall survival upwards of 90%. So to summarize, screen and take time to find lesions. Once found, choose a right patient and lesion. Optimize techniques to achieve clear resection. In those where extensive ESD is done, use steroids to prevent stricture. And a good histological assessment after ESD is needed to determine high risk and adjuvant therapies. Thank you.
Thank you, Sridhar. We are a little bit behind time, so I would take maybe one question or comments from floor if it is available. Yeah, please.
Yeah.
Could you use microphone?
Using the steroid,
Right.
the local as well as you said that is orally also. How it actually affect that outcome?
So it reduces
Preventing
fibrosis.
the fibrosis and
Yeah, it reduces fibrosis.
Is there any literature or something?
Yeah, there's a lot of literature to suggest, and I think even the Japanese guideline says that we
After
should.
doing that ESD.
Yes.
Because steroid, when there is a stricture, we are injecting steroid when there is a stricture due to acid corrosive sometimes.
Yeah, but you do it after dilatation to prevent a refractory stricture, right? I mean, you have to, in a refractory stricture, to prevent restenosis, you're injecting steroids. So it's a similar ideology here, I guess.
Okay.
Thank you. Thank you.
Yeah, thank you. Okay, so next we will invite next speaker, Dr. Skrit. Yeah, he's talking about full thickness resection indication and outcomes. That is a recently really topic for the endoscopy treatment.
So at the outset, I'd like to thank Dr. Ashutosh Mahapatra, Sonmoon, for all the help and the kind invitation. So I'll be talking about something which has been coming to the forefront in the last decade or so, which is endoscopically tackling submucosal lesions with full thickness resection. So we have two basic techniques of full thickness endoscopic resections. Exposed technique, where we are exposing the lesion from the gastric lumen or the lumen and approaching it directly by using the ESD technique. Then there are techniques where we're using devices to first create a closure and then doing a full thickness resection over that closure. Hence we do not expose or communicate even temporarily the luminal cavity with the peritoneum. Then there are hybrid approaches. The endo-lap interface is there, where the laparoscopic surgeon will make your life easier using a lot of different techniques where either they resect and we deliver, or we resect and they deliver, or they suture and we cut. So coming to the case selections, in the stomach, we get sometimes confused. How do we approach a particular submucosal or even a mucosal lesion sometimes, depending on the layer of origin and how deep does it invade. So let's say we have a gist that originates from just touching the muscularis propria layer, predominantly endophytic. This is the A, where A and then B would be going into the muscle, but not invading through and through. Here you can just do a resection without requiring any significant full thickness closure, like in ESD. Then there's C and D, where there's predominantly involving all the layers and becoming exophytic as well. This is where section with a tight closure, because you've done a full thickness resection, is needed, and where closure becomes more important than the resection. Then the location of the lesion, whenever you have a tubular lumen like the esophagus, rectum, or the cardia, or even the antrum, you can choose STIR, that is tunneling with endoscopic resection. Other locations where maybe retroflexion may be needed, like the fundus or the incisura or the greater curvature, you can choose endoscopic freehand full thickness resection, also called submucosal excavation. So coming to STIR, this is probably the safest of the techniques, but it is limited in the size of lesion that you can take out, because you need a relatively linear lesion. You don't want to tackle something that is more than 3.5 centimeters in diameter, because not only section will be a headache, but also delivering it through the oral cavity across the cricopharynx becomes challenging. And sometimes you have to then get it piecemeal, and that negates the whole purpose of doing a endoscopic resection. So this is done like the POEM procedure. You go into the submucosal tunnel, you start separating these lesions, usually leiomyomas or cysts, from the muscle, creating as small a muscular defect as possible. And then you have maintained a mucosal flap, so using the safety of the mucosal flap, you can come out, close this defect, and with simple through the scope clips. Then comes the exposed technique of freehand EFTR. You usually use these for gastric cysts or neuroendocrine tumors if need be. It is also limited in terms of the size you can tackle. You don't want to go beyond 3 centimeters unless you have a suturing device. More often than not, you are able to resect it with time, but issue becomes with vasculature. So do a good EUS, determine the layer of origin and any major significant vessels which are feeding this. Sometimes we have fought with large vessels like a left gastric artery, trying to remove these, and burnt our hands and needed the help of a laparoscopic surgeon for the rescue. So you remove them like we do in ESD. Always first resect the lesion from the muscle as much as possible and create the defect at the end, because the moment CO2 starts leaking into the peritoneal cavity, your anesthetist will be in a hurry to shut down the procedure. So you want to do that part very quickly and then deliver the lesion and close the defect with multiple techniques I'll be coming to later. Then there are other techniques like a clip-in line technique, where we have clipped let's say a cyst or any muscular tumor already and have a line coming out of the mouth. There's a lesion in the stomach, and you create a traction, and it makes your life easier. Then they can be band-assisted EFTR as well, where you create a traction using rubber bands and 2 clips. And like we do an ESD of a neuroendocrine tumor in the duodenum, you have done a full thickness section. A lot of the ESDs end up being full thickness sections in the duodenum anyhow. So then the most important part of this talk are the closure techniques. So we can use through the scope clip, the easiest available, but choose the right clips. We can do a zipper closure like we do in POEM closures, or we can use the loop and clip, that's the King's closure technique. Then there are the over the scope clips. We have the OTSC by Ovesco and the padlock clip available in India. Then there's an endosuturing device which makes closure easier, but it is not very flexible. In India, we only have the larger device which requires the double channel scope, but the single channel device should be making our life easier. Then the newer device like the X-Tac, and then endoscopic suturing with a single lumen, and robotic suturing is coming up. So these are the usual techniques, just a second, that we have for closure. The OTSC is what we are most comfortable with. You create a small muscular defect like we do with endoscopic scope-induced perforation, sometimes in the D2 doing ERCP. And with a fresh defect, you just suction up the edges and close it with the OTSC over the scope clip. Endoloop closure may not be very robust sometimes, but be very careful in using the right clips. It has to be a reopenable clip, at least the first one. So you have held the detachable loop, and you can hold the edges of your defect and close one by one. In the end, you pull the end of the loop with the specialized hook that's available, and it creates like a purse string effect. But in the stomach, you have to be very careful. There are incidences where it will open up in a delayed manner. So always keep them on a nasojejunal tube. Do not be very early to feed, and keep them on a suction for at least a couple of days. Then there's a simple zipper closure, which you can start from the normal side and then keep coming and making maybe a oval or ovoid defect into elliptical one and then a linear one, and it makes your job easier. Newer clips are now available. The Microtech DAT dual action clip and the Mantis by Boston Scientific has come now. So these are bigger clips. The dual action clip allows double closure of one side, bringing it close to the other edge, and then taking that in the clip as well. Mantis has good jaws which do not tear the tissue but can bring the edges closer, especially in soft areas like the stomach or the right colon. It's very useful. Then coming to the full thickness section device, which is available again by the Ovesco company from Germany. There we have the colonic, which came a few years ago, and the gastroduodenal relatively recently. Different sizes, 21 and 19.5 mm. So in the upper GI, you have to be careful of dilating the cricopharynx and sometimes the pylorus if need be to enter the duodenum. So you have this 20 pneumatic balloon to dilate the cricopharynx and the pylorus in the device kit itself. You have a marking probe, and then you have the anchor and the dual grasper as well. Where do I use these? I use these for non-lifting adenomas up to 3 centimeters. I think that's a stretch. Usually we stop at 2 centimeters. Duodenal subepithelial tumors like neuroendocrine tumors up to 1.5 to 2 centimeters, and stomach 1.5 centimeters. Do not use the upper GI FTRD near the papilla. Always make sure you do a couple of dry runs with the device to make sure where you close at the D1, D2 junction does not cause stenosis later on. Then patients who have large varices, that will cause trauma and they will bleed. Stenotic areas to be avoided, and when you are expecting incomplete resection as per the angulation, because not a very flexible device, it can malfunction, so be very careful. Technique is quite straightforward. You prepare the device, then you use this pneumatic balloon, I think I can skip it, to dilate the upper esophageal sphincter. And then you have to have very good rapport with your technician. I get very uncomfortable with new technicians when I'm doing this. So you have to apply the instrument quickly. It's like how we put a EVL band ligator or Vesco clip. And when you have enough tissue, they want us to pull it with the grasper or the anchor, but sometimes suction works better and you don't get a bloody field because the barrel makes it pretty myopic when you're doing it. So you pull it in, and at the same time, when you applied that full thickness clip, you want your assistant to, and immediately this white band that you can see disappears. And you want him to cut with the snare, which is a part of the device, on top of the barrel immediately, and then you can get a full thickness section. So these are the examples of the same, and you can see we mark it, and we similarly can, like we do in the Vesco, we can apply the FTRD and we can get a specimen which looks a lot like this. So see the backside, use antibiotics maybe on the first day because some risk of infection is there as per data. You put them in PPIs for at least a month, and you can use oral liquids on the same evening if the patient is symptom-free. Adverse events are a part of any procedure. These are high-risk procedures as well. So you can get perforation when the device does not deploy, and then you can use the device itself like a clip if possible, or you can use other techniques of closure. Because you suction so much tissue, sometimes you create large perforations. Then they can be technical failures, or again you create stenosis like this. We had at D1, D2 junction, and the scope is not passing through, or sometimes the lesion comes into the pylorus from the D1 when you're suctioning, and the device does not go back into D1 easily. So give it time, maybe do a little CRE dilatation the next day, and it will pop right back into the D1. And when you're expecting incomplete, when there's bad angulation, just juxtapyloric and neuroendocrine tumors, you need to be make sure that when you apply this very expensive device, you've done a complete resection and not made the patient's life worse. So then we think that it will cause a complete hemostasis, but that's not true. The nature of the jaws of the devices are such that they usually may cause even sometimes there is some delayed bleed. So we might have to localize the bleeder and do a coagulation like this vessel was there after the patient had bled post full thickness resection. So that we may have to go back later and do a soft coagulation. So how do we maximize success? Prefer dilatation always, especially with overweight patients with short necks. And prior side view endoscopy should be done for D2 lesions. Avoid FTRD in flat lesions above 1 centimeter if there's a lot of scarring. Avoid vigorous suctioning, especially in D2. Avoid juxtapyloric lesions. And for your first attempt will be the best attempt. So don't keep suctioning, leaving, and that will make your life more difficult. There's enough data. The RESET trial was about the upper GI FTRD. The lesion size average was 11 millimeters, 29 odd patients. R0 resection rate was a meager 76%. And now the newer studies are getting a higher R0 resection rate, upward of 90% from Germany. Periprocedural bleeding in this was pretty high. A third of the patients, we do not see these numbers, and technical success is high. Then coming to the colon, for recurrent polyps, it's very important and even can be used in the right colon. Then non-lifting polyps, periappendicular, peridiverticular polyps, so where perforation is the norm rather than exception when you're doing ESD. Suspected deep mucosal invasion and neuroendocrine tumors up to 2 centimeters. When do I avoid colonic EFTR? Distal 3 to 4 centimeters of the rectum, because angulation of the device is an issue. Patients on immunosuppression, scarred unhealthy mucosa like we see in ulcerative colitis patients, large scarred recurrences of more than 2 centimeters, or multiple lesions which are satellites very close to each other, where you will not know how many you have caught in the single device. So this is data from Dr. Zahir and with a lot of different centers, PJ also involved in center from Italy as well. They did a meta-analysis, 29 studies, 3,500 odd patients, mean lesion size around 16 millimeters, so very high technical success. On block resection rate of 88%, R-naught resection rate 82%, and major adverse events were only in 2.5%. So device-assisted EFTR, we have to be careful negotiating it through upper GI tract. Inability to capture more than 3 centimeter lesions. Grasping fibrotic lesions, very difficult, and you risk incomplete resections. Reaching the right colon, you would want to be careful. Do a dry runs with the barrel of maybe an EVL band. In tortuous colon, especially patients who have had pelvic surgery. Guideway assistance and floor assistance may be needed. Device failure does occur. Sadly, snare may not close, and time or clip deployment issues may be there. Then it has a new technique is the hybrid EFTR, very large lesion, there only the center may be the depressed lesion invading, so you can do EMR or ESG of the surrounding area, and the central part which is scarred or completely fibrosed and invading can be taken out by the EFTR technique. Then there was a paper on using the GERD-X device because it's a full thickness plication in the end, just it's not working. So Schmidt et al. Showed that it can be used like a device-assisted EFTR technique as well. You put the pledgets on both sides of like a fundal gist, and then you can do a snare resection of the gist in toto. So to summarize, these are the techniques for exposed EFTR. We discussed TER and non-exposed EFTR. And the problem that we face are such that with the device, the size is a limitation, location is limitation. GERD-X we don't use in our country for this, cost is inhibitory. Freehand EFTR, take it on only if you can complete the procedure, and keep your laparoscopic surgeon aware that you are taking on this procedure, and keep an OT at bay if possible. So see if you can detect, you can reach up to 3 centimeters in these, and then above that size, you can take the help of the surgeons. So thank you everyone for your patient listening.
Thank you, Sukrit, for very comprehensive presentation. So because of time, I also want to take one question or comment from the floor, if available. If no, you presented several methods to closure. I think closure is the most important part of free section. What do you recommend? Which method do you recommend?
I think the cheapest of the lot which we get away with most often is the loop and clip closure, is what we use very commonly. If it's a small defect, an over-the-scope clip gives us a lot of satisfaction that we have got the tissue and we can sleep peacefully that we have done a good job. But otherwise we do use loop and clip most commonly. And suturing only if the patient can afford. The issue becomes the cost keeps increasing on top of the procedure. The closure cost is also inhibitory in our country. But loop and clip would be my go-to.
I see. Available.
Yeah, it's available.
Easily available.
Yeah.
Okay. Thank you.
Thank you.
Okay. Thank you. So I would like to invite next speaker, Somu Mohapatra. I really appreciate her effort to organizing and managing and speaking and performing the procedure. So she is talking about key strategy to successful gastric ESD. Okay, please welcome.
Thank you so much for the kind introduction. So my topic for today is to speak on key strategies for successful gastric endoscopic submucosal dissection. So I'll start with a case. This is a 62-year-old female who was referred to us for evaluation of this gastric lesion, and pathology was performed outside and it was not conclusive. So we performed repeat endoscopy that showed this 3 centimeter around reddish polypoidal lesion at the greater curve of the proximal gastric body, and it's covered with these food particles. And as you see the surface, it's kind of relatively depressed, but not per se ulcerated. And on NBI, there is irregular surface pattern and vascular pattern, but it's very difficult to kind of put NBI and assess because of the adherent mucus as well as this spontaneous bleeding. And we did perform a repeat biopsy and that was inconclusive as well. And as you can see here, with suction, the lesion is collapsible, which is kind of saying that probably it's not attached to the deeper submucosa. And also, like the background mucosa was severely atrophic with multiple xanthomas that says that probably this is early gastric cancer, or very high suspicion for this to be a neoplastic lesion. Now, when we find this type of lesion, our first question is what to do next. So to assess the depth of invasion and the lateral extension of the lesion endoscopically, and then to find the histologic subtype, whether this is differentiated type or undifferentiated type, because our endoscopic management is based on these answers. So now, the indications of ESD, it differs a little bit depending on the organ. So in the stomach, if the lesion is limited to the mucosal layer, then that means the lymph node metastatic rate is low, and we can definitely dissect endoscopically. And as the lesion depth goes down, or depth of invasion increases, then the rate of lymph node metastasis also increases, and then our curatability from endoscopic resection, that decreases. So if there is a deep submucosal invasion, then that are the candidate for surgery. So endoscopically, actually we can say that whether there is any evidence of deep submucosal invasion, because if there is any irregular nodularity or extensive ulceration or markedly elevated margins, deep ulcer, abrupt cutting of the conversion folds or fusion of the conversion folds or clubbing, these are the signs of advanced cancer. So now the question is whether the lesion is differentiated type or undifferentiated. So if the lesion is reddish or pale, or elevated, or present in an atrophic area, and they have irregular or fine network pattern, then probably they are most likely differentiated type. Compared to if the lesion is pale, like Dr. Ashutosh Mohapatra said, pale lesions, depressed, and if they're present near the atrophic border, and if they have corkscrew pattern, then most likely they are undifferentiated type of early gastric cancer. So once we determine this clinically by just looking at the lesion, that means endoscopically, then we can assess if the patient needs to go to surgery or an endoscopic resection is helpful. Now the answer to our question, what would be the depth of invasion in our case? So by looking at the lesion, we thought this is probably T1B and differentiated type. So we thought to proceed with endoscopic submucosal dissection, not only to get a curative specimen, but also to have a diagnosis in this case. So this is the endoscopic resection criteria. So it depends on the lesion size, if there is ulceration or not, and the depth of the invasion. So if this is limited to the mucosa and think of differentiated type without ulceration, then mostly they can be cured with endoscopic resection. Whereas if undifferentiated type and large lesions with ulcerations, and most likely they are the surgical candidates. So coming to the factors for successful ESD, as I told you, the good patient selection is the most important thing. Then, because this is a very technically complex procedure, adequate training is very necessary. Then you should have availability of the necessary equipment in your endo room and have a proper strategy, because without a strategy, the endoscopist can struggle during the procedure and the procedural time can be delayed. Then the procedures are generally long procedures, so have patience, and complications that do happen, so do not panic, and always have a plan B. So the pillars for successful ESD, so first is indication that I already mentioned, then availability of necessary equipment. So always have an endoscope with a water irrigation pump because bleeding mostly happens during the procedure, and to see the vessel, it's important to have a water irrigation pump attached to the scope. Then have a transparent hood cap, then electrosurgical unit with all necessary knives, then hemostatic forceps, then CO2 gas insufflation, injection solution, and as I said, flushing pump. Handling of the scope is extremely important because it needs to be handled with one hand, because with two hands, it's very difficult to maintain a stable scope position while cutting. So, so keep the scope always straight and control both the dials, like the up, down, and right, left with your left hand to have the precise transmission of your movement to the tip. So the tip control is the most important thing when we do the third space endoscopy. Then coming to the distal attachment cap, they can be straight or tapered, and generally the endoscopists, they prefer which one to use based on their expertise, and they help to kind of access the submucosal space while dissection. And we do have multiple electrosurgical knives available with different properties. So it's very important for us to know the different properties because sometimes more than one knife can be necessary during the procedure. So know your electrosurgical unit very well, and Dr. Srihari is going to speak more about it in my later talk. So I'm not giving too much emphasis on this, but always need to have a very good balance between the cutting current and the coagulation current to have a clean dissection. So steps of ESD, so first is marking, and then injection, then mucosal incision, then dissection. So injection is a very important step because that's the first step, and always prick deep first and then withdraw. And once you are in the submucosal plane and you see the bleb, then continue to do a dynamic injection. So that's very important to have a success in ESD procedure. And the injection shouldn't be too deep or too superficial, and it shouldn't be too close to the lesion because that can make the field bloody. Then coming to the mucosal incision, this is also very important steps because most times the beginner, they try to cut very superficially, and what happens that because of the scare that they'll perforate. But there should be adequate pressure of the knife with the mucosa to have an adequate cut. So always maintain an appropriate distance from the target to have a negative margin, and always maintain a good contact with the mucosa, and you shouldn't manipulate the knife too much in and out because the more out you put the knife, you kind of lose the control. So always have that white ceramic tip with a blue band seen and kind of continue with the dissection and shouldn't put too much knife out. So that's very important. Then coming to the submucosal dissection, so it's recommended to stay in a plane in the middle and kind of dissect the submucosa in the middle of the plane. Too much close to the muscle can risk for muscle injury and perforation, and too superficial actually bleed more. So it's always nice to stay in the middle of the plane during dissection. So there are challenges in ESD. They're not simple always. So it can be non-lifting. There could be instability because of the difficult location of the lesion, or scope can be unstable in the position, and we don't have any traction that we use during ESD, so sometimes exposing the submucosa can be difficult, and they are associated with complications, and that can happen, and it has a very slow learning curve. So to to mitigate that, there are multiple different approaches been described, like pocket creation method, modified pocket ESD, bridge ESD or tunnel ESD, multiple tunnel, hybrid, traction-assisted ESD, and I'm not going to go deeper into all this different modalities, but I'm going to show what we did in our case. So after marking, so I started the submucosal incision, and I started proximally, and I accessed the distal margin in the retroflexed position. The position was little unstable. However, I completed the mucosal incision, and then the lesion didn't lift, so I had to apply traction, and I used a clip-in line traction. There was profuse bleeding occurred during the procedure. The patient blood pressure dropped to 90 systolic, and then, but we were able to control it with our coag grasper. And after controlling the bleed, this is the non-lifting part that made the procedure extremely difficult. As you can see, even with injection, it's just not lifting. So when this happens, we just lose the plane of cutting. So, and there is a high risk of perforation. And at this point, I was thinking whether there is deeper invasion present in this case, because this indicates two things. One is fibrosis, other is deeper invasion. So I very carefully started cutting in the middle and in the retroflex position with a cutting current, and then I was able to finish this procedure without any complication. So this is the cutting of the submucosal fibrosis part, the non-lifting part, and finally, this is the resection bed. You can see there was no muscle injury, no perforation. So final path was 3.1 by 1.8 centimeter, well differentiated, grade 1, tubular type cancer, limited to the mucosa. It was T1A, and there is no ulcerations, and there is no lymphovascular invasions, and margins, both deep margin as well as lateral margins, were clear. And the part that was non-lifting, it was actually fibrosis. It was not deeper invasion. And as you can see, the lamina propria was expanded because of the dense inflammation and desmoplasia. So this is the curatability criteria. So based on this, our specimen or our resection was curative resection, and I did follow up endoscopy, and unfortunately I don't have the picture of it after 4 months, and it was clear there was a nice healed scar and there was no recurrence seen. And we also repeated CT scan, and everything is fine. So the take-home message, first careful patient selection, then understand where your weapons well before deciding on which one to use, and make a proper strategy. That is very important, and I think that plays like 50% role for a successful ESD. And follow the basic principles and do not rush during the procedure. Complications do happen, but most of them can be managed endoscopically. Thank you so much.
Thank you so much for excellent presentation. Yeah.
Thank you.
And congratulations for the procedure. And I want to take one comment or question. My question, one question. So I always ask, what is a learning curve for getting a, skill of gastric ESD?
Yeah, I think that's a great question, and many of us has the same question. But what I have learned is, if you are just learning the ESD by yourself without having a mentor, then the number of procedure you need, then it's more, probably around 200. But if you are properly trained, for example, me, I was in a training program for ESD, and I have done probably 40 ESDs in animal model, and 5, 6 in live animal, and then I have done 40, 45 in patients. With that, I'm here doing ESD, and at least I'm confident that I can finish the procedure safely. So that's the main thing. I just don't look or put too much importance to the time because if you rush, then you will complicate the procedure. So that's the main thing for the beginners, not to put too much emphasis on time, just continue doing the procedure safely. And if you have a mentor who can guide you, then definitely the learning curve is better with less number of procedures to have the same level of competency.
Thank you for very
Thank you.
practical,
Thank you so much.
important information. Thank you.
I would like to thank the chairperson and speakers for this first half of the first session of day two. Before we proceed to the next session, we'll be having 10 minutes of live transmission from the live demonstration. Do we have the live transmission? I would like to take the opportunity to invite Dr. Bijay Mishra, Dr. Lalatendu Mahapatra, Dr. Sarat Chandra Panigrahi, and Dr. Kanu Charan Das to chair the live demonstration and the second half of the first session.
We are not hearing anything from there.
Hello, Dr. Dr. Zakaria.
Yes. Can you
Good morning,
hear me?
sir.
Good morning. Yeah.
So, yeah,
So-
audible? Yeah.
Yeah. So this is a 52-year-old lady with type 2 achalasia and 10 years history of dysphagia. So she has been posted for peroral endoscopic myotomy. We just cleaned up the esophagus. There was some residue there. So this patient has been intubated. Dr. Santanu, he is our anesthesiologist here. And I have Mr. Prakash assisting me as a technician. So I am using the X1 and upper endoscope. So the GE junction is at 40 centimeters, so I am starting at around 30 centimeter. I'm just, I'll be going in about to the right of the spine at 5 o'clock position. So I'll first inject something. Yeah, can we have?
So, what is the manometry says?
Type 2 achalasia.
Okay, understood. So, you are going to do this myotomy, the smaller myotomy.
No, it's a regular 6 to 8 centimeter, 6
Right,
centimeter.
that
at
is a
least,
smaller
yeah.
one. Yeah.
Inject. Inject. Yeah. Yes. Okay, good. So I made an injection. So I'm now going in with, I am using the TT knife. currently in the which mode are having because it is getting is the near vision mode? Is it the near mode? Because it is becoming normal mode.
What are all the settings are you using?
Because it is becoming blurred, no? And you're just off? Yeah. Can you? Quadrip. So you should use it on the thigh. Yeah, put it on the thigh, please. Use it on the thigh. Yeah. We're just fixing up the cautery here. This is over the muscle. It should tends to be over the muscle. Muscle here. Here. Over the muscle. Yeah. That's good. Okay. Right? Right? No, it is not on. Can you just, you're having some issue with the cautery, yeah. Now it's fine? Yeah. Okay? Yeah.
It's a good cushion.
And then, so we have just entered the submucosa space into the, yeah.
I think this is the important step.
So we are, so I'm just doing the dissection into the submucosa.
So one large blood vessels.
Yeah.
So you'll be dealing with the quad grasper or will
Pardon?
because it is a larger and there is a chance of bleeding. So will you able to yeah,
I'm able to. Yeah, I will. Close. Yeah. Inject. Inject. Yeah. Out.
Due to constraint of times, we'll be moving to the lectures now. So I would like to request the chairpersons to invite the next speaker, Dr. Sihari.
Yeah, good. So we'll just proceed with the tunneling. We'll get back once the tunneling is over. Just inject. Inject.
May I invite Dr. Sihari Anikhandi to speak, give his lecture on understanding of ureterosurgical unit, which is very important. Dr. Sihari, please.
Yeah, audiovisual team, can you please help me with this? Audiovisual team? So at the outset, I must thank Dr. Ashutosh and Dr. Sunmun for giving me this opportunity to present on this platform. In the next 15 minutes or so, I'll be speaking about understanding the basics of the electrosurgical unit. Though I think it's a complex topic for us as gastroenterologists because we don't get into so much of the intricacies of how these electrosurgical units work, but I'd like to make this topic simple and just run you through the basics of what we need to understand as gastroenterologists when we start doing these complex procedures. So basically, endoscopy has transformed as an art. What was done previously was very primitive, and now what we can achieve with an endoscope is a lot of procedures which involve a lot of cutting, fulguration, coagulation. And for this, we need to understand our electrosurgery. So this was an art which was good to know previously, but now it's a must know, especially for us gastroenterologists who are planning to enter into the arena of third space endoscopy, ESDs, etc. So why should we as gastroenterologists learn about electrosurgery? So first, it helps us achieve desired therapeutic outcomes with optimized results. And second, it allows us to avoid most of the complications that can be associated with these procedures. So it's very important that we understand the principles correctly. So my talk is based on this agenda, and I shall start with the basic principles first. So understand that electrosurgery is not equivalent to electrocautery, okay? So in an electrocautery, a direct current is used. So this direct current goes through your probe, it heats that probe, and that heat is used for dissection. Whereas in an electrosurgical device, it's an alternating current which goes through the probe. This alternating current goes through the tissue, it completes the circuit, and within that tissue, that heat is generated, and that is how this cutting occurs. So most of our devices which we use now are based on the electrosurgical principle, and we have very less accessories which are based on the electrocautery principle, especially in endoscopy. So all energies are based on an electromagnetic spectrum, right? So the electricity that we have as an electromagnetic spectrum of around 1 kilohertz. This is where our muscles and nerves are stimulated and you get electric shocks. But your electrosurgical device, here the electromagnetic spectrum is in the radio frequency range. So that is why your muscles, your nerves are not stimulated and you don't get that shock. So we're basically dealing with radio frequency range of the electromagnetic spectrum. So we need to understand this very principal law, that is the Ohm's law. So that is how the current and the voltages work. So basically current is the flow of electrons that is flowing through a circuit, right? That is that green man over there. Voltage is the person who's trying to push this current against a resistance, right? So Ohm's law tells us that voltage is current into resistance. So this is the basis of all these electrosurgical devices. So this voltage, this current can be regulated on the settings that you can do on the electrosurgical device. So that can be done on the machines that we have, right? But whatever setting that you do on the electrosurgical device need not necessarily translate into the tissue effect. That means whatever setting you do here, similar outcomes might not happen on the tissue. Why? Because there is something called current density. So current density is the actual density which is delivered to the tissues. And this depends not only on the settings of the ESU, but also the characteristics of the tissue, like how much is the water content in the tissue, how much is the fat, how much is the fibrosis. That also determines how much current is delivered. And it also depends on the operator technique. For example, how much is the surface area that you engage? How much is the tension that the operator has placed on the tissue? What is the velocity at which you're using your devices? So eventually what matters is the current density that is transmitted to the tissue. Then let's see the ESU modes. Let's see how you can set your devices. So basically you all see these two pedals on the electrosurgical unit. By convention, the yellow pedal is used for cutting or blended currents, and the blue pedal is used for coagulation. So what does this mean? So whenever we start heating tissues, at around 40 degrees centigrade, up to 40 degrees centigrade, there's no effect on the tissues. Between 60 degrees centigrade and 80 degrees centigrade, there starts occurring some coagulation. So in coagulation, there is just some heating. The tissues don't burst, the cells don't burst. But at 100 degrees centigrade, there is a sudden vaporization. So where the cells actually start bursting. And 200 degrees centigrade is very high, where there is a lot of carbonization. So when you apply a coagulation current, there is a gradual rise in temperature which rises up to 70 to 100 degrees centigrade, and this leads to coagulation. It leads to desiccation of the cells and shrinking, but there's no bursting of the cells. But when you apply a cutting current, so here there is a rapid rise in the temperature to more than 100 degrees centigrade, and here there is a rapid cell rupture, and the cleaving of the tissue occurs without any coagulation. So you need to understand certain other principles called like duty cycle. So duty cycle is actually the percentage of time when the electrode is actually delivering the energy. So if you have a 100% duty cycle, that means whenever you are pressing the pedal, continuously the energy is being delivered. So when you have a 100% duty cycle applied, the cutting effect is much more, okay? But when the duty cycle goes on reducing, so you have a gap in between, so that gap in between allows the tissues to cool. So if you have a 50% duty cycle, you have cutting equivalent to coagulation. But if the duty cycle is much lesser, like 6%, so you have a lot of gap in between. So here the tissue cooling occurs, and that is why the coagulation effect is much more than the cutting effect, right? Then comes something called as the crest factor. So crest factor is basically the peak voltage that is delivered by these devices. So coagulation currents have a lot of voltage that is being delivered. So coagulation currents have higher crest factors, whereas cutting currents have lesser crest factor. So because more voltage is being delivered in coagulation currents, there is a risk of injuring the surrounding tissues, unlike in cutting current where only the nearby structures are affected. So if you see our routine currents that are available, in a soft coag, when you apply a soft coag, your voltage is very less. The voltage is less than 200. The duty cycle is continuous. So you are applying a continuously low voltage current which helps in coagulation, only coagulation. But when you apply a cutting current, high voltages, continuous cutting, continuous duty cycle, so that leads to cut. Whereas in other coagulation modes, high voltages but a smaller duty cycle. So there are different ESU modes that can be used. You have pure cutting currents, which come by different names by different manufacturers. The commonly that we know are auto cut and pre-cut. You have blended currents, whereas there is a mix of cutting as well as coagulation, like dry cut and blend cut. And you have fractionated. Fractionated means cutting at one point and then coagulation. So you have endo cut and pulse cut. You have currents which have coagulation and cutting both together, like the swift coag, power coag, etc. And then you have pure coagulation currents like a soft coagulation current. So these are the usual modes that we have in most of our manufacturers. So let's talk about fractionated modes. So fractionated modes are slightly different from these conventional modes. We commonly know about these two types, the endocut I, which we usually use for doing a sphincterotomy, and the endocut Q, which we use for doing a polypectomy. So what happens when you use a fractionated current? You press on the pedal, and you press this pedal continuously. So when you press this pedal continuously, you're pressing the yellow pedal. But still, despite that, there is a cutting followed by a length of coagulation, then again there is a cutting, again coagulation, again cutting, again coagulation. So don't make this mistake of pressing the pedal and leaving it, again pressing the pedal and leaving it. So what that will cause, that will only activate the cutting current. You leave the pedal, again you press it, again it will activate the cutting current. So the coagulation effect is lost. So whenever you are doing a sphincterotomy and you are using the endo-cut mode, press the yellow pedal continuously. It activates both your cutting followed by coagulation. So that is protective for you. So that is how these fractionated modes work. So in a fractionated mode, you see that you can adjust certain settings. So what are these settings? So you have a coagulation cycle which you see in blue. So that is the effect. So when you increase the effect, you are actually increasing the coagulation. When you increase the cut duration, that means the duration for which the cutting is occurring, that you can increase. And when you increase the interval, that means it increases the duration between two cutting cycles. So these three things can be modified on your machine when you're using the endo-cut current. Different manufacturers will give you their own recommended settings. So there is no gold standard to it. Different operators will prefer different settings. Different manufacturers will give you different settings. It's up to you to decide what suits you the best. There's no gold standard to that. Then let's talk about ESU circuits. So basically for an electrical circuit, the basic principle is that the circuit has to be completed so that the currents can flow. The circuit has to be completed some way or the other so that the current can flow. What happens in a monopolar mode is that the current is generated by the generator, it goes through your scope, it goes through the device, it goes into the tissue. And from the tissue, it is collected by the patient pad. We call it as the patient pad. Mind you, that is not the grounding pad. It is just a dispersive electrode which takes this electricity back to your generator unit. It's not an earthing pad as most people label it to be. Okay, so these patient pads are not built just like that. They come backed up with a lot of quality parameters. It is made sure that these patient pads work fine. So basically why it is important is because this is the pad which is receiving the electricity back. So if it malfunctions, all the electricity will cause burn over that area. So it is important to orient these pads correctly. So your long axis should be in the line of the current so that the electricity is dissipated. If it is not aligned properly, so all the current will go to one focal area and that will cause burns, that will cause injuries. But nowadays you have these omega-shaped plates which help you dissipate the current equally everywhere. So there are some very important tips which are given by the manufacturer. I have highlighted some of them over here. You can go through this later on. And especially for patients who have cardiac implants, this is a common question that many people ask. If there are pacemakers or there are an implant, what you should do? Preferably use a bipolar cautery. How it works, I'll tell you later. And if you are using a monopolar device, you should make sure that you attach the patient plate far away from the current path. Okay? What happens in a bipolar current? In a bipolar current, the generator is generating the electricity. It goes through the device, and that electricity is captured by the same device and again sent back to the ESU circuit. So it doesn't go through a longer route. So it just goes through a shorter route. Lesser current is used, lesser the risk of injury in such cases, right? So then comes about these specialized devices like APC. So what is done in an APC? The device is releasing argon gas, and in that gas, if you send electricity, it creates something called as a plasma. So plasma is the flow of electrons through that gas. You have different kinds of APC firing devices. You have the axial, you have the side firing, and you have the coaxial system. Depth of coagulation is usually superficial up to the mucosa or maximum superficial submucosa. And we know that different tissues have different thermal sensitivities. So especially if you're dealing with the right colon or the duodenum, your APC setting should be lower as compared to the rectum especially. And you have different modes. You have the forced argon, you have the slow or the pulsed argon, and you have the precise APC. So you have this speedboat device. So speedboat device is slightly different in a way that it's a bipolar device and it works on radio frequencies, radio frequency cutting, and you also have a coagulation in that which is based on microwave. So it's slightly different from our conventional electrosurgical devices that we use. So ladies and gentlemen, ESU, electrosurgical unit, is as important as any other instrument in an endoscopy unit. You need to know the principles to optimize procedural outcomes. The final tissue effect is determined by current density, which in turn is governed by patient factors, accessories, and the settings. Multiple modes are available for use, and you should know to individualize your settings based on patient and the therapy which is planned. Thank you so much.
For your clear demonstration and elaboration of how to use the electric surgery unit in clinical practice, that in gastroenterology. I think it has given a very clear idea. So if any questions or queries are there, one question can be asked.
Sorry, sir? So, right, other than speedboat, I think your gold probe works as a bipolar device. Most of them are monopolar device.
As a surgeon, we are lucky to have many other units except electrosurgery. We have ultrasonic vibrator, many other instruments. I hope you guys also get those things except the electric.
So maybe in the near future, like the speedboat that we have, which is also working on microwave.
Those things are very easy to handle and very particular in sealing the vessels and cutting.
Where to apply forced APC? Forced APC, where to apply? In which case?
So forced APC is when you want to fulgurate a larger area and deeper fulguration, and especially where the tissues are little thicker, like the stomach or the rectum, it is okay to use a forced APC.
In radiation proctitis?
Yes, a forced APC might be better, especially if the area is very large.
Okay, thank you.
Sir, can you announce that we can go to live session that is going on the
To whom to tell?
in between?
Okay, before the next lecture, I think we will go to the live demonstration.
Should I have one live demonstration? 5 minutes. Dr. Zakaria, where are you now? And we can see you. Yeah.
Yeah, out.
So almost you are nearing to G junction.
Yeah,
Because this
that's right,
trauma
that's-
separate vessels and
You can see the vessels change in caliber. Yeah. Out.
Are you going to deal with the left side vessel?
We are just going
I think we
by the
should
right
leave it.
side of that.
We should
Yeah.
leave it because
Yeah.
it will not encounter or it will not come,
Needling. Yeah,
it
inject.
will not hinder your work. I think we should leave it.
Inject. Yeah. So we have reached, you can see the caliber of
So you
vessels
are
has
going
changed
from
in
left
the
to right, or you are how you are actually doing this?
Yeah, you can do it either way, yeah.
Either way.
Out. Okay.
So numerous, this is a comma-shaped vessels that indicate that you are reaching that G junction.
Yeah. Yeah. You can see a lot of
big
vessels
vessels
now.
that is in front of you.
Yeah. So we'll just reach there. Yeah. So just come back, come out.
You have
See
to check the tunnel. You should go to stomach.
Yeah. Come out. Yeah, go in. Reached here. We'll go a little more and then
Yeah,
we'll
you have to
start
go
the myotomy.
1 or 2 centimeter more.
Yeah, we'll go that. Yeah.
Yeah, the mucosa is all right.
Yeah. So if you have a talk or something there, you can join, or you can keep going. We'll just, when we start the myotomy, we'll be back with you.
The next talk is Managing Difficult Common Bad Dog Stones, Strategies and Techniques, none other than Dr. Sanjeev Nijavan, sir. Sir, please.
We have reached beyond that, see? We have gone into the same. We have reached the second, actually. See, the perforating muscle, we have got 40, 41. Yeah? Yeah, we have reached 45. Inject. We'll just see a little more, we'll dissect here.
Good morning, everyone. At the outset, I'd like to thank Ashutosh and Sonmun for the kind invite. How actually we define the difficult CBD stones? So any stone which is of more than 15 millimeter in size, we define it as a difficult stone, but there are many more factors. So a difficult stone are defined because of the character of the stone, the location, the anatomical situation, and the patient's factors. So if the stone is large, that is more than 15, it becomes difficult. If they are actually more than 10 millimeter and more than 3 in numbers, again it is difficult. Any stone which is hard to break is a difficult stone, and of strange shape, may not be round or oval, but they are actually square or barrel. Then they are difficult to remove, and the impacted stone, the accessories can't actually open to catch up the stone. So these all are situations where you find it difficult to remove. So chances of doing lithotripsy are more. Then, it's not moving. It is not moving actually. It's not moving. So if the stone is impacted, again the accessories can't open. Stone is above the stricture. It is an impacted stone, so there is no space to work, and stone is impacted in the cystic duct. So it is difficult to assess these stones, so they are difficult. Then narrow distal CBD of more than 3.5 centimeter, or there is an angulated distal duct that is less than 135. It also makes the accessories difficult to work there. Altered anatomy, Billrod 2, Roux-en-Y loop, papillary opening within the periampullary diverticulum. Again, it is difficult to assess, so these are the difficult situations. Any patient who is very old, poor general condition, unstable vital signs, these are the patients where there is a bleeding tendency, the risk of adverse events are more. So how to manage these large difficult stones? There are two approaches. Either you increase the diameter of the sphincter or you reduce the size of the stone. You increase the sphincter by doing a wide sphincterotomy or using a large balloon sphincteroplasty, and reduction of stone is by lithotripsy. So what are the ways to actually reduce the size of the stone? So we have intraductal devices like mechanical lithotripsy, laser lithotripsy, EHL, and there are external devices which can break the stone, that is ESWL, which is being used even for the urinary stones and pancreatic stones. So there is RCT, which is actually comparing the balloon dilatation with EST alone, the efficacy and safety. And in this table, actually, it's a pooled analysis of as many as 300 patients on either of the arms, only EST arm and EPBLD plus EST. And you see everything is comparable except for the requirement of the mechanical lithotripsy, which is much decreased in patients who are actually undergoing balloon dilatation. A meta-analysis using large balloon versus endoscopic sphincterotomy for the removal of bile duct stones, six randomized trials, 835 patients, and it has been shown that using EST plus balloon dilatation have a lower risk of complication, and the use of lithotripsy is much decreased in patients in whom we use balloon dilatation. And the indications are the dilated CBD with single or multiple stones, that is difficult stones, and usually we use 12 to 20 millimeter balloon, ideally 13 to 15 millimeter, and tight distal CBD stricture is a contraindication because it will lead to perforation. The small sphincterotomy is always required to put the balloon inside. Then we dilate the balloon up 12 to 20 millimeter. We keep it for 1 minute, but there are studies showing even 30 seconds is enough. A slow inflation reduces the complications. So this is how actually it works. So it's basically a slow dilatation in which actually the balloon at times, it tend to slips in. So you have to apply a continuous pressure over the balloon, and a slow dilatation after doing a small sphincterotomy, and then releasing it slowly, and then it opens up the common bile duct, and by retrieval balloon, you can actually retrieve the larger stone. So the ECG recommends a limited sphincterotomy combined with a large balloon dilatation as the first line approach to remove the difficult CBD stones. Now we come to mechanical lithotripsy. There are a few tips. You should not drag the stone near to the papilla and crush. Catch the stone and crush in the middle of the CBD, and multiple stones are there, so you actually tend to crush the distal one first and then the proximal one. Less than 2 centimeter, almost 100% success rate. 2 to 3 centimeter, 90%. If it is more than 3 centimeter, it's difficult to catch, so there's a drastic decrease in the success rate. So impacted stone you can't do, that's a failure. Stone size more than 3, again your accessory doesn't work. And if the stone to CBD ratio is more than 1, that means stone is stuck up in the narrow CBD, again you can't do it. In mechanical lithotripsy, actually, there are a few tips which should follow. That means you should actually always drag the stone in the middle part. You should actually leave the elevator, otherwise, it's a heavy instrument, it can lead to damaging the elevator. And then slowly build a pressure on the stone by the device, and then this is how you crush the stone. Sohindra lithotripsy, we don't use it. It is only being used in emergency. When you have a stuck-up stone with a conventional basket, then you remove it with the Sohindra lithotripsy. But one should have this in every unit. Then we come to cholangioscopy. There are various types of cholangioscope available. Mother-baby scope, hardly we use it now. Single operator cholangioscope, these are the scopes we use it now. We have per-oral cholangioscopy. It can be used by using a forward-viewing ultra-thin scope with the help of a retrieval balloon stuck up into the intrahepatic system after wide sphincterotomy. And then there are procedures, electrohydraulic lithotripsy and laser lithotripsy. So large CBD calculi, electrohydraulic lithotripsy, again there are actually chances of injuring the CBD during the procedure. It can lead to perforation. The success rate is a little lower, 75 to 98%. This is how actually the probe is taken to the impacted stone, and then you actually crush it. Helium laser, with the SPY scope, every unit should have it. The success rate is almost 93 to 97%. Complications is acceptable 3 to 13%. Then it decreases the need for mechanical lithotripsy in the extrahepatic stones, 92% success rate. And if you actually compare with the conventional therapy, then the success rate is 93% versus 67%. And there are actually multiple studies in which the clearance has been shown to be, except for one study, more than 90%. And most of the studies have used the laser and EHL, the less numbers. Systemic review, laser with EHL comparison, a higher completion rate with laser than EHL, and more adverse events with EHL. So a total of 27 prospective studies in which actually laser, EHL were used, and it was shown that total clearance was around 88%, and it was higher, 91% with laser and 75% with EHL. So this is how it works. It is very precise. Under the vision, you go inside and actually blast the stone under the vision. So, and that's the reason the adverse events are less and the success rate is pretty high. So EHL, the efficacy is lower, 65 to 90%. There are multiple sessions required. There are procedure-related complications as well to the tune of 37%. Indian data, AIG study in which 283 patients, total clearance 84%, 12% are still left. There are minor complications to the tune of 15%. So multiple sessions are required in ESWL, MDD drain placement, continuous saline irrigation is required. Adverse events like cholangitis, pancreatitis, purpuric lesions on the area where the shots are given, and even hematoma. So ESD recommends extracorporeal shockwave lithotripsy when conventional techniques have failed, but we don't have other techniques of direct cholangioscopy, direct cholangioscopy lithotripsy available. So if they are not available, ESWL is a good modality. Altered anatomy, balloon enteroscopy assisted ERCP can be used. Even we can use ES-guided biliary assist in a patient where you can't reach by the conventional method to the papillary area. Intrahepatic stones, you can do it with various attempts. Attempt with Domia basket on a guide wire, and you take the Domia basket there, or per-oral cholangioscopy with the intraductal lithotripsy can be done, or percutaneous transhepatic cholangioscopy lithotripsy can be done, or ES-guided intraductal lithotripsy. Ultimately, if all these fail, surgical segmental hepatectomy can be done for recurrent intrahepatic stones. CBD stenting, in case of incomplete drainage, multiple plastic stents can be placed. Multiple are better than the single one, and studies have shown that 7 French is as good as 10 French, and they have to be kept there for 3 to 6 months, because otherwise it can block and lead to infection. So management algorithm, if it is not a difficult stone, simple by doing sphincterotomy and balloon extraction is enough. If it is a difficult stone, we predict the difficulty by studying the stone size, the size of the CBD, and the narrowness of the lower common bile duct, the angled common bile duct, and then we decide what to do. In the same session, we can do limited sphincterotomy and balloon dilatation, but somebody who has gone in sphincterotomy before, EPA BLD can be done directly. If there is a failed extraction, then consider for mechanical lithotripsy by direct cholangioscopy assisted method. If it is not available, even ESWL can be done. Failed extraction from all the above procedures, if they are not readily available also, then insert a plastic stent to tide over the crisis and refer the patient to a higher tertiary center where these methods are available or consider for surgery. So in conclusion, stone characteristic, common bile duct, patient factors predict the easiness of removing the difficult CBD stones during ERCP, and an anticipated difficult stone extraction, recommended first line approach is sphincterotomy and balloon dilatation. Alternatively, stone size can be reduced by doing mechanical lithotripsy. A laser lithotripsy, direct cholangioscopy is preferred over EHL, and if the conventional techniques fail and the intraluminal lithotripsy techniques are not available, even the ESWL can be considered for removing such difficult stones. Thank you for your kind attention. Thank you.
Thank you, sir, for your clear demonstration of different techniques and in different difficult situations, starting from size, distal CBD strictures, etc. So this house is open for the any sir.
Now in 2025, you have all the gadgetry and armamentarium with you. You have EUS, MRCP. When do you say upfront, oh, this is not a patient for endoscopic removal, and send the patient directly to surgery? Or you want to attempt in all and sundry?
You see, in 2025, we should attempt in all, though you have to decide which technique you have to use when. MRCP is a very good modality by which, smaller stones, simple ERCP is recommended. By any patient in which MRCP shows an impacted stone, a Mersey's syndrome, where you have to go directly with a better instrument. And the better choice here is a direct cholangioscopy and crushing the stones if it is not impacted. If it is not impacted, then mechanical lithotripsy, even with the mechanical lithotripsy, the Olympus one is quite good. You can use that.
I think there's slight difference in approach. Young man, intact gallbladder, large stone in the mid CBD, non-dilated lower end. You will make all efforts to remove the stone. Still, he will require a cholecystectomy. A big stone popping out near the cystic duct. Why not have a laparoscopic one-time procedure? Because you'll keep struggling to remove the stone 1, 2, or 3 sessions. That will add up to the cost. So we recently have changed our tactics. Young man, large CBD stone, non-dilated lower end, intact gallbladder. One time, surgeons do an excellent job. Let them also do something.
I agree to you. If you suspect that it's a difficult stone, like an angulated common bile duct, lower down, narrow lower CBD, and intact gallbladder, and in a young patient, you can go ahead direct doing surgical procedure.
Sir, I would like to point something. Dr. Lalatundu is there. Sir, we have now laparoscopic cholangioscope, na? That is also a better modality, bigger stones.
Sorry, the mic is not, is working? Yeah. Surgically, yes, I agree with sir. If it is upfront, there is a definitely complete stricture like chronic pancreatitis, non-negotiable stricture and large stone and intact gallbladder, young patient. Laparoscopic removal of CBD stone with repair, usually we do combine and put a stent inside, and same time removal of the gallbladder. I think that is a better procedure than doing a multiple sitting CBD stone extraction followed by laparoscopy.
Laparoscopic cholangioscope also now.
Yeah. We can use ureteroscope, the flexible ureteroscopes are also there. Cholangioscopes are there, you can use that.
I think larger the stone, more proximal the stone in the vicinity of the cystic duct, I think it is a boon for the surgeons.
Yeah.
Problem occurs when the stone is in the non-dilated part, especially in the retroduodenal region, which laparoscopists find it difficult to reach. That is where we have to make all attempts.
Exactly, sir.
Yeah, you have to decide before going inside that in which patient you are going to fail actually. So the difficulties you must actually assess before attempting the removal.
Initial days, what happens, the laparoscopic repair of CBD is not very common. It is very, the training, learning curve is very high. Now, most of the surgeons are doing laparoscopic CBD repair also. So now, in a same port, within same port, we can remove the gallbladder, CBD repair, and remove the stone at the same time. And the surgical time hardly matters, another half an hour maybe extra.
Another reason, Sandeep, for upfront surgeries, now since a lot of people are doing laparoscopic surgery in the peripheral towns, we recently have been having patient with partial cholecystectomy and a large leftover cystic duct remnant, which contains stone. So what do you do in that?
Yeah, that's the most difficult situation we find actually, because post-operatively, post-laparoscopy, in the stump the stone is lying. It is difficult to approach that with the endoscopic method. And the only way by which you can approach is if your cholangioscope can go into that and crush the stone. Otherwise, laparoscopic removal.
But even if you remove it one time, you have a big stump. It's likely to get back to the stone. How is it easy for the surgeons to move?
Now we are seeing very commonly, our approach is if the patient is symptomatic with that stone and we have given sufficient time for healing, at least to 3 to 6 months, so that all the adhesions of previous surgery went out, we can go laparoscopically with open-minded. If it is not possible, go for open surgery.
Can I make removal of that stump as well as stone?
When we have large CBD stone, then there are two issues, whether it's isolated CBD stone or CBD stone with the lower end stricture. So if there is a stricture, then surgeon has to remove CBD stone, and same time he has to also do hepatico-jejunostomy. So when the patient has CBD stone with the lower end stricture, then the situation becomes challenging for surgeon also. So if he does only the CBD exploration and closure, there can be risk of leak and the recurrent stone. Then in that setting, we have to decide whether the patient will require endoscopy with the repeated dilatation of stricture, or surgeon has to do hepatico-jejunostomy. We have to explain to the patient. Large stone without stricture, I think surgeon can very well remove the stone easily.
Yeah, stricture is a problem, because once there is stricture, even the endoscopy is difficult, and even your laparoscopic surgery becomes difficult.
Sandeep sir, we have now moved out to a metallic stent placement and doing lithotripsy and removal of the metallic stent after 6 months. That resolves the stricture as well with the removal of the stone. So we always put a metal stent before
fully covered,
and then remove after 6 months.
I think to have a stricture because of the CBD stone is very uncommon.
It is usually because of the chronic pancreatitis.
And inflammatory. To have a stricture requiring dilatation is very uncommon. It is primarily because of the chronic pancreatitis.
Chronic pancreatitis.
CBD stone causing stricture is quite uncommon thing. You may have functional narrowing because of the large stone or passage of the stone. To have stricture requiring repeated dilatation is not a common problem unless you have a concomitant chronic pancreatitis.
We can have a live session now, please.
I think we have to consider a lot of factors before deciding upon whether to offer surgery, upfront surgery to the patient or not. To me, one of the most important factors is to consider whether the patient endoscopically will merit multiple sessions or not. I think that again can be because of multiple large stones in the duct, because even if you do laser in the one session to break all the stones, it's very difficult. Or the patient has got a stricture down, for which obviously endoscopically you need multiple sessions. I think that becomes very, very important. If the surgeon can do the same job
in single
one
setting,
session and you do it in 4 sessions, I think obviously surgery scores over that.
Yeah, fully agree.
Thank you, sir.
Thank you. Thank you so much.
So where are you now, Dr. Zakaria? Am I audible? Hello? There I think the end part, that is the closure of mucosectum side.
No, it's good. You just watch. In the meanwhile, I will introduce my next speakers. One is Dr. Jahangir. You stay there. He is a very well-known gastroenterologist from AIG. He works on US, very young, famous gastroenterologist. Next is our Dr. Anil Arora, who is a chairman of GI Sciences in Gangaram Hospital. I asked one of his junior, tell me about good quality of Dr. Anil Arora. He told, Srihari told, his most beautiful quality is childlike inquisitiveness. Then I was gossiping with Dr. Randhir Sood sir. He told he is the most intellectual person in gastroenterology community. Next is my senior, just immediate senior, Dr. Prabir Rai, master of USGJ. कल मॉर्निंग वॉक कर रहे थे हमें करथुलू वी आर डूइंग ए मॉर्निंग वॉक मैं बोला कि बॉस आपके पास USGJ है ठीक है कर लेंगे तो ही वॉज नॉट बॉदर्ड नेक्स्ट इज मैग्नेट मैन ऑफ इंडिया डॉक्टर संजय राजपूत he manages biliary injuries. His lecture is there, he will give. Then Nitin Jagtap, these are very young people. Nitin Jagtap from AIG, he will tell you about AI and how to manage your hospital profitably. So he is in a different league. Then manometry man. Hello? Jubin Sharma. So they are very passionate and young gastroenterologists. And Bikas Singla is synonymous with poem in India. So I think I didn't hurt you because your name is synonymous with poem. Bikas Singla means poem. So these are the persons which you are seeing because I am introducing each and everyone because so many local gastroenterologists here. So they want to listen from you. They are very attentive. They are sitting there, many DM students and very young gastroenterologists are there. Kanhu.
Thank you, Dr. Mahapatra. So now we're going to, hello, Dr. Zakaria.
Yeah, close.
So what type of that clip and that is being used?
We are using the, just get a closer. We are using the Olympus clip, yeah. Get a closer. Yeah. We are getting the clip loaded. Yeah, we'll just get close. That has gone to the other side, so we'll have to close it. Open. Now this turn. Close. Okay.
These are, we can start next session.
May I call Dr. Anil Arora to present the endoscopic approach of subepithelial tumor, techniques and outcomes. Sorry.
Yes, keep loading.
Sorry.
One will put it in front also, one more.
Yeah. I'm talking about management of water.
Just switch it.
Close.
endoscopic management of walled up pancreatic collections.
Yeah.
Pancreatic necrosis.
Yeah, no, yeah, we'll put in. Yeah, we'll do it. Open.
So good morning all. So I thank Dr. Ashutosh sir and Dr. Sunmu for the kind invitation, and thank you chairpersons. I'll be talking about management of one. First I would like to discuss about standard approach, differentiating the various types of collections, when to drain, how to drain. And I would also like to discuss certain hot issues in the management of one. With the recent robust data from different centers adopting the different strategies, there is some confusion. So I would like to address when to do the drainage, what are the choice of stents, should we adopt step-up approach or upfront necrosectomy, and how to approach to one after the resolution. So basically, pancreatic fluid collections occur in the background of acute pancreatitis, which can be acute interstitial in majority. In 20%, it is acute necrotizing. After 4 weeks, mature wall form to develop pseudocyst and walled off necrosis. Here you can see on left side, this is a clear, well-defined collection. In the background, there is a well-enhanced pancreatic parenchyma indicating interstitial pancreatitis, whereas in one, the collection replaces the entire pancreas. MRI and EUS are better modalities to differentiating the types of collection and to delineate the morphology. The common indications for drainage are infection, persistent pain, mass effect in terms of jaundice, vomiting, and failure to thrive. So when to drain? We should adopt a 4-week rule. We should delay the drainage until at least 4 weeks after the pancreatitis onset to allow the wall to form. The only exception is infected pancreatic necrosis when it is not responding to conservative treatment. The modalities of drainage that are available is traditional approach surgical. Percutaneous drainage can be considered as a sole treatment or as a part of step-up approach. In endoscopic drainage, currently EUS has become standard of care. This is RCT from Dutch pancreatitis group comparing the surgical and endoscopic approach, showing that both treatment approaches are similar, but the rate of fistula formation and length of hospital stay was higher in surgical step-up group. And similar results were shown by Sham Varadarajulu group also. So coming to the standard steps of EUS guided drainage, we'll identify the cavity under EUS guided approach. First step is to puncture with a 19 gauge needle. Next, pass the guide wire. We can use O25 or O35 guide wire. Next is to create a fistula by using a cystotome, then subsequently dilatation of the fistula with the balloon, and subsequently we can place the plastic stents. Here we are showing EUS guided drainage with a LAMS, which actually a biflanged metal stent, Nagi stent, where we'll deploy the distal flange under EUS guidance, and we usually deploy the proximal flange with the help of a fluoro and endoscopic guidance. The common available lamps in India are Nagi and Plumber, whereas the typical lamps used for other indications are also hot axios or cold axios and SPAX stents. Coming to the various hot issues in the management of one, I would like to discuss one by one. First is coming about timing of drainage, whether to do early or a standard approach. Early drainage means doing drainage less than 4 weeks. This is a nice paper from Martin Freeman group where they have shown that endoscopic drainage can be considered and it should be considered in patients with infected pancreatic necrosis, where it has shown that there is no increased risk of adverse events. But it is not a straightforward thing that we should adopt into the practice. Before considering early drainage, we should consider whether the wall maturity is there or no. Generally, 4 weeks is the cutoff time for the maturity of the wall, but this is an arbitrary time frame. Some collections mature even before the 4 weeks. So before considering drainage, we need to assess the wall under EUS guidance. In this paper also, where you can see that some wall formation is there at least in 50% of the patient. So that should be enough to prevent the complications. So without a complete formation of wall, it is risky to adopt this approach. And another thing is in early drainage with infected pancreatic necrosis, most of the time they land up with percutaneous drainage because wall is not formed. Even in this paper also you can see percutaneous drainage was considered in about 30% of the patients as a first modality and also as an adjunctive treatment in about 40% of the patients. That means two important points need to identify here. One is even though we are draining less than 4 weeks, we should see a safe wall should be there, and also there is a need for percutaneous drainage also. This is a meta-analysis based on the papers, almost 7 papers showing the similar efficacy. Coming to the choice of stent, whether to use a metal or plastic stent. So hot lamps has become the game changer because it's easy to place, very high technical success, can be placed bedside even without a fluoroscopy, totally operator control, and time taken just to deploy the stent is less than 1 minute. The another advantage of lamps is they act as a port for necrosectomy. There is no need to dilate repeatedly like in plastic stents. We can go into the cavity how many number of times you want. You can take large chunks of necrosis and can do a safe necrosectomy when it is required. So another advantage is sometimes some hidden vessels can't be seen very clearly, and immediately after the puncture, where you can see here, there is a massive bleed from the puncture side, and tackling this situation can be challenging, especially when you are doing a drainage, and if we can't control, it requires IR. Here you can see a massive bleed, but after placement of the lamps, you can see because of the tamponade effect of the lamps, the bleeding is completely controlled. So it is a rare situation, but if it happens, definitely lamps will be a savior here. So various studies are there comparing the metal and plastic stent. Many of the retrospective studies have shown that lamps is better, but the so-called RCTs, almost 6 RTCs have been published, and every study has shown both metal versus plastic were comparable. But we need to understand certain important facts, and we need to understand little depth here also, because the number of patients small, the primary outcomes were different, and ultimately we consider plastic stent to save the cost. The total cost both in metal and plastic is almost same at the end of the treatment, and certain caveats are also there. So this is our paper comparing the metal with the plastic stents, which has shown that re-intervention free clinical success is better with the metal stent. The third important thing is, should we do a step-up approach or upfront necrosectomy? Step-up approach is nothing but first doing the index drainage with the lamp, then we wait for the symptoms at 48 to 72 hours. If there is ongoing symptoms, then we consider necrosectomy, NCT placement, additional interventions if required. Adopting endoscopic step-up approach, we have shown that there is a significant improved clinical success at the end of the treatment. And basically what step-up approach does is it allows the formation of the mature cystogastric tract, so it reduces the risk of stent dislodgement, and it allows the liquid component to drain out, which could obscure the vision, and also it avoids the necrosectomy in some group of the patients. So the current papers suggesting upfront necrosectomy. What exactly is upfront necrosectomy? Here the hypothesis is by allowing early mobilization and debridement of the necrotic debris, we can minimize the number of intervention, we can shorten the hospital stay, and we can reduce the treatment cost, and the same has shown in this paper from Shyam Varadarajulu group. We are also part of in this, where it has shown that the number of interventions were reduced, length of hospital stay, there are no adverse event, and it reduced the treatment cost also. But it is not a straightforward thing that we can take into the practice. Certain key factors are there that decide the strategy. We need to consider if at all we are doing drainage in unstable patients and in early drainage who are very sick, unstable patient, we cannot venture doing upfront necrosectomy. Here step-up approach again is important. When the necrotic debris percentage is less, without necrosectomy also they will improve. Type of stent also is an important. Ultimately we should compare the safety in terms of the cost also. Coming to the last hot issue, that is the approach after the one. The stents, whether to remove or not, when to remove, should we do MRCP, ERCP or both, or when to consider long-term stents. So to address these questions, we published this paper in Gut where we had shown the approach how to proceed in case of a VON. Usually after the resolution between around 4 to 6 weeks, we can consider MRCP, and we have done MRCP and ERCP also to confirm the PD anatomy. Usually 3 different types of the pancreatic ductal anatomy expect. We can see a normal PD or a PD leak and disconnected pancreatic duct. Whatever is the pancreatic ductal anatomy, we should remove metal stents in all patients. In case of a PD leak, we can consider a plastic stent in the PD, whereas in DPD, which we can't bridge, so we have to consider long-term plastic stent in case of the drainages with the plastic stent, but metal stents has to be removed. In this paper, we have shown that in majority of the patients, almost in 75%, there is a DPD. Leak can be seen in 7%, normal PD in 14%. And in DPD, you can see this is the classic picture on MRCP, where you can see the normal PD in the suprapapillary area, long gap of disconnection and a dilated duct. In ERCP, there is a complete connection. We have a nice talk next by Dr. Vikas Singla. I am not going too deep into the disconnected pancreatic duct. And we also shown that there is an excellent correlation between the MRCP and ERCP. So there is no need to do ERCP in all patients. We can just have MRCP to know the pancreatic ductal anatomy, and then we can take a decision. Coming to the take-home message from this talk would be, understanding the morphology of pancreatic fluid collection is crucial before the drainage. Train only symptomatic collection and wait until at least 4 weeks in most of the patients, unless there is a compelling indication. In case of a VON, EUS guided drainage with lamps is the best choice. Adopt the step-up approach in majority of the patients to have a better morbidity and outcome. Early drainage and upfront necrosectomy can be considered in a select group of patients when it is required. Thank you.
Thank you, Jahangir. It's an excellent presentation. So, any question from audience? So, one thing I'll ask, what is the actually tricks that when we are putting that stent, plastic stent, the cardia or in the fundus, or putting the same thing in the distal part of the stomach, is there any difference?
So usually if we are very close to the G junction, we should be careful that there is a chance of slippage, especially if it is a large collection creating a bulge. So it is better to have a safe view, and margin should be there, and better to do everything in case of plastic stent under endoscopic vision with some gap between the wall and the scope. Whereas in distal part of beyond cardia and beyond 3-4 centimeters below the G junction, it is always easy and safe.
Easy to.
Yes.
What is about when we're establishing 2 stents at a time? So how will establish, one by one, or how will you establish
better
the
to
guide
place
wire?
2 guide wires before deploying the first stent. First guide wire is anyway it's there. To place the second wire, many approaches are there. You can use a 10 French stent pusher over the first guide wire, and you can pass the guide wire.
Right. Thank you.
Hello, Dr. Jahangir?
Yes.
You always stage 1, or you only the symptomatic patient like gastric symptoms or bleeding or infection, or all the one beyond 4 weeks you drain it? My first question. Second question, do you have any publications or any paper comparing laparoscopic cystogastroctomy one-time procedure compared to a multiple sessions of stenting and removal?
Yeah. So coming to the first question, that is about symptomatic. Yeah, we should consider drainage only in symptomatic collections. If it is asymptomatic, we can wait. So usually what we are discussing in VON is acute necrotizing with large amount of necrosis, where it has been clearly shown that both have equal efficacy, surgical and the endoscopic drainage. You can consider laparoscopy in a well-defined wall, like a pseudocyst or VON with debris, and definitely the outcomes are good, and papers also have shown that it is equally efficacious. But in cases of infected pancreatic necrosis, this type of endoscopic approach with step-up approach should be adopted.
Hospital stay also less hospital stay.
Yeah.
As compared to surgical.
With endoscopy. Yes, sir.
Jahangir, I had very good talk. I have 2 questions. One is when there is a one and you have symptomatic one with the necrosis more than 70-80%. So will you consider endotherapy or percutaneous drainage in this patient or directly sent for surgery? And secondly, on necrosectomy, sometimes we have a brownish hard tissue which is difficult to remove during necrosectomy. So how do you handle that tissue?
Yeah. So when the debris is 70% and if it is infected pancreatic necrosis, not improving, definitely requires drainage, better to hand over to surgeon. Because it's very difficult for us to complete, we have to look at the outcome ultimately at the end. Placing a stent is easy, simple thing, but after that we have to face many challenges. Even surgeons also first they will place a PCD and then minimally invasive approaches they follow. But 70% necrosis we usually hand over to surgeon or we'll consider them in the picture and then after the multidisciplinary we'll take a call.
So surgery will be laparotomy or the percutaneous approach?
So in our center the practice is open surgical necrosectomy, nobody is doing. They place PCD, then only they take a call depending upon the outcome.
So the PCD also, they are using the ureteroscope actually, and we are also using the, we can do pen also. So how do,
Yeah, so after the PCD, we have to assess clinically whether he will allow us to dilate the tract and pass the scope inside and then do the necrosectomy. If it is complicated course and the patient is very sick, then we should not waste time and we have to take aggressive approaches by what?
second of the necrosectomy, sometimes you face the, it's a brownish tissue which is adherent and difficult to remove. So how do you tackle that tissue? You pull it out or wait for the softening of tissue?
So we, in that case, what we do is we place NCT, we irrigate the cavity around 1 to 1.5 liters. We'll again come back again 48 hours. Most of the times it will be easily removable. And we'll attempt removing by grasping with a snare gently, not with too much force. And sometimes bleed happens, it is from the granulation tissue, no major vessel is there. But if it is too much adherent, better to do NCT and irrigation and then come back again.
So we have just done two like cases of almost similar what you said about having almost 60-70% necrosis. So with our surgeons, we done a hybrid approach. They did a laparoscopic wound drainage into the stomach with a much wider mouth than what we can create with the EUS guided this thing. And after a week or so, we went in and with an endoscope, normal endoscope, and they did an endoscopic necrosectomy. So that somehow gave us a wider mouth and less chances of block to that mouth as compared to even a maximum of 2 centimeters of the axios that we can use. So we done only 2 cases with that hybrid approach. It's better.
I agree with you. If
Yeah.
surgeon is doing laparoscopic transgastric approach, that is better. But if they are doing the percutaneous, I think they pass ureteroscope.
That is, I think, is equal to
as
us.
good as doing pen actually. So
As
we
good as
prefer
us.
doing pen in these patients.
Yeah. And sir, regarding another question of the necrosis removing, we have also, last year we published use of the NCD as what you said. In 2 cases, we have also done a very diluted peroxide into the NCD, continuous irrigation for a day or 2. Somehow that has given us a better results.
Yeah, we also doing regularly. There is some whitish tissue which is easier to remove. You just pluck it out.
Yes.
And
The
it's
black
white
and the
tissue is
one
very
which is
stubborn.
other end, yes,
And
yes,
there are,
that becomes the
I
problem.
think it's a necrosed pancreas only.
Yes.
When you pull it out, there are hidden vessel, very high risk of bleed.
I agree.
Thank you, Jahangir.
Thank you, sir.
Excellent talk.
A very good talk. I came very late, but question is that previously people are telling the percentage of necrosis do not determine which modality you need the treatment or percentage of sepsis more. Have you any guideline or you are following beyond this percentage of necrosis, you will proceed to this way?
Yeah.
Are you following any things?
Yeah, definitely the percentage of necrosis guide us in taking the decision. For example, if the necrosis is not there or less than 20%, even we can do drainage with the plastic stents. If necrosis is more than 20% and less than 50%, you can do endoscopic drainage, preferably with the lamps, and you can do necrosectomy. But if the necrosis is more than 50%, then if the patient is not that much symptomatic, we'll wait and we'll again reassess for symptoms. If the debris comes down, then we'll do endoscopic drainage. If it is still ongoing symptoms with more than 50%, then definitely we'd consider surgery.
And even if you are taking 4 weeks, at the 4 weeks the wall may not, WOPN may not be formed. Can you proceed or you will wait for another 4 weeks, 2 weeks to till the wall become formed, then you will proceed?
So ultimately, it's a clinical decision. After 4 weeks, if the patient is having a organ failure or the complicated course, some wall formation, if at all, is there, when we can consider early drainage. If it is looking risky to do the drainage, then conservatively we can prolong some more time. If it is still not happening, better to go for PCD.
Another point, if there is a small bulge in the fundus, there is a collection, a large collection in the lesser sac, but there is no bulging anywhere else, only mildly bulging at fundus and easily approachable percutaneous. Yesterday we have drained it around 2 liters, 1.5 liters. It has drained completely. Now it has drained completely, no fever, nothing. Then whether you are going to for other intervention or you go to percutaneous intervention.
So if there is opposition only in the limited area in contact with the stomach, then we have to see where exactly the collection main source is there. If it is close to the stomach, still less surface contact, we have to consider lamps in this case. We should not consider plastic stents if at all we have to do drainage.
No, I am telling percutaneous. If it is there is no bulge, only mild bulge in the fundus.
Then you can consider percutaneous. No
Now
problem.
it is drained completely, now asymptomatic, then you will proceed.
But only risk is there is some fistula formation.
Okay, another
that
point,
has to-
as for Dr. Vikas, he is my senior in AIMS, I know him. We are following the same rule. If we cannot drain, there is a significant amount of necrosis, cannot able to drain, as he told, we follow like that. And most of the cases, they improve.
Yes.
After multiple times. Very few cases, there is a bleed. Okay, thank you.
Thank you. Thank you, sir.
Thank you, Dr. Jahangir.
Endoscopic approaches to subepithelial tumors, technique and outcomes. None other than
Sir, please start.
At the outset, I am extremely thankful to Dr. Ashutosh and Sonman for giving me this opportunity. The topic which has been allotted to me is approach to GI subepithelial lesions. What are the techniques and the management principles? So what is a subepithelial lesion or subepithelial tumor? Definition is any lesion which is protruding into the lumen of the GI tract beneath the mucosal lining of the GI tract. That is a submucosal epithelial lesion. In fact, there is a data of about 26 crore 85 lakh endoscopies published recently in 2020, in which the incident of detection of the subendothelial lesions, SELs or SETs, whatever you want to call it, it was to the tune of about 3%. We surprisingly do not have our own Indian data. Luckily for us and fortunately for us, most of these so-called SELs or subepithelial lesions are asymptomatic and are detected incidentally when you are performing endoscopy for unrelated reasons like for GI bleeding or for cause of anemia, etc. Occasionally, patient may have classical presentation requiring assessment of these subepithelial lesions, and these are far and few and include conditions like dysphagia when you have a large submucosal lesion in the middle esophagus. Patient may have a bleeding subepithelial lesion in the GI tract, and only rarely and occasionally you can have a ectopic pancreas causing pancreatitis which can present as a subepithelial lesion. But as I said, majority of them are incidentally picked up during examination of endoscopy for different reasons. So an iron deficiency anemia, GI bleeding, abdominal pain, or obstruction of the submucosal lesion primarily in the ileum or in the jejunum because of neuroendocrine tumor are the reasons for presentation in patients who occasionally present with symptomatic disease. So whenever you tend to encounter a patient of a subepithelial lesion, we have to know, does the patient have symptoms which would have been incidentally missed? Does the patient have a potential to develop malignancy, what are the patient's aspect of understanding the lesion, what are the endoscopic aspects of confidence and experience in handling these lesions, and we have also to look at the availability of the treatment modalities in a given situation. Most important aspect which concerns the patient is this subepithelial lesion benign or malignant? Because if you have a potential for malignancy in a particular lesion, you have to make all efforts to get rid of the lesion. How do we assess and evaluate the potential of malignancy? You can either do an endoscopy with or without biopsy. Then you have EUS guided procedures, both for assessment and for removal of the lesion, not only for giving you a diagnosis, but also giving you a complete composite picture of what the patient has. When you are trying to do an endoscopy of for the subepithelial lesion, you have to look at the surface of the subendothelial lesion. And even during simple endoscopy examination, you have different maneuvers to see what is the type and pattern and the color of the lesion, and then you have different signs which try to assess what is the possible and probable location of the lesion beyond the mucosa. After all, subepithelium does not mean it is limited to the submucosa. It may be going deep down into the muscularis mucosa, submucosa, and even muscularis propria. So we have different ways of evaluating it endoscopically to know what is the site of the lesion. So during endoscopy, whenever you tend to encounter a subepithelium lesion, try to look at the location of the lesion, try to look at the shape of the lesion, color of the lesion, surface of the lesion, and look at the mobility of the lesion. These are the simple, very simple, cost-effective tools, free of cost, which give you a lot of clue to the nature of the lesion, which will further make you decide about the further treatment modality. Look at the consistency of the lesion, and obviously size is the single most determinant of the outcome of the lesion whenever you want to do endoscopic therapy. So the color of the lesion may be a normal color, which may be just mimicking and the surrounding mucosa. You may have a lesion which may look translucent, or a lesion which might look bluish. Depending upon the type of the lesion which you are seeing as a gross examination, you can have a clue to the etiology. A yellowish looking lesion is more likely a lipoma. A lesion which looks bluish is likely to have a vascular malformation or fundal varices or any vascular lesion in the surrounding. Also, please also try to have a look at the surmounting signs onto the lesion in the form of either dimpling, umbilication, erosion, or ulcer. These different clues not only give you an idea about the type of the lesion which is harbored in the submucosa and in the muscularis propria, but also tells you about the depth of the lesion, which is so important in taking a therapeutic decision of management. When you want to look at the mobility of the lesion, it gives you clue. So there are different signs which are available in the literature to tell us what do these different signs mean and how do we interpret these signs. So three signs which we tend to look at is the rolling sign or a pillow sign. Rolling sign and the pillow signs are slightly different. In rolling sign would mean that you take a firm biopsy forceps, which should not be sharp, and tend to put it at the side of the lesion. If the lesion rolls, that is a rolling sign. Whereas in pillow sign, if you tend to have your closed biopsy forceps onto the lesion, there is a dimpling of the lesion, and as if you are sleeping on a pillow, which because it is soft by the pressure of your head tends to dimple down. These all signs like rolling sign, tenting sign, or a pillow sign have clinical meaning. They would mean that this lesion is at least not present in the mucosa. It is anywhere in the mucosa or a deeper lesion. Usually, the rolling sign is absent in patients who have ulceration or fibrosis, and it also means that a patient having a wider base in the muscularis propria. Subepithelial lesion without rolling sign tend to occur in patients who have ectopic pancreas, neuroendocrine tumor, granulosa cell tumor, malt lymphoma, etc. Tenting sign is another sign which is important. That means you try to lift the mucosa and it will come away from the subepithelial lesion. This means that there is a component of the lesion in the mucosa, in the lamina propria, and in patients who do not have ulceration or fibrosis, you may be able to lift the mucosa over and above the lesion. Pillow sign I have already mentioned. Pillow sign and cushion sign is almost the same. It is a classical setting in patient in which the lesion contains either air, liquid or the lipid component. Classical example is lipoma. So this is as you put your firm object or a biopsy forceps onto the lesion, all these lesions like cystica, profunda, lipoma and lymphangioma, because they either contain liquid or a fatty material, they tend to dimple down. Endoscopically also, as I said, size is an extremely important component of any lesion. Any lesion which is small, less than 20 millimeter, is rounded and protrudes within the lumen with an overlying mucosa. If it has a central depression, they do think of malignancy. You should suspect malignancy when the patient's lesion, which is larger than 2 centimeter, or if it is growing in size on follow-up, or there is a presence of ulceration. So size and the overlying ulceration and the growth over follow-up period are important clues to the presence of the malignancy. What are our expects as an endoscopist when we try to look at the subepithelial lesion? It depends on the confidence in your own ability to do it and the availability of the equipment and the area where you are practicing. So depending upon the type of the lesion, you will have different armamentarium for taking care of these lesions. I am happy both Sukrit and Sonmoon has given us excellent demonstration of the various modalities which are available for treatment of these malignancies. How does EUS help? EUS tells us what is the level of origin of these lesions, and as we know classically, there are 5 layers which are seen on endoscopic ultrasound examination, and depending upon the layer of the region of the lesion, you can confidently make a diagnosis using EUS tool. EUS is the best tool to characterize the type of the subepithelial lesion. It is accurate in telling you the origin of the lesion in about 82% of the patients, whereas accuracy for the size of the lesion is 87% of the patient. That means even if you are doing EUS, you can characterize the lesion as to what origin, what layer it is arising from, and it also tells you what is the nature of the lesion. It is pathognomonic only in 2 conditions. If you have esophageal varices, if you have lipoma, or if you have in rest of the condition, you cannot have a pathological diagnosis based on EUS alone, unless you have lipoma or varices. Diagnostic rate and availability of the malignancy in patient with undergoing tissue sampling is possible in an 85% of the patient if you add this technique of using biopsy during EUS examination. Now, as I said, location of the tumor is extremely important. Starting from the upper GI tract down into the GE junction, these are the various lesions you are likely to encounter. A lesion starting just below the cricopharynx, I think Dr. Nitin's group had recently posted in the 3rd space endoscopic group, a large hanging fibrovascular lesion which started from the just below the cricopharynx and was being vomited out. AV malformation, tuberculosis, leiomyomas are common, and depending upon the different sites in the stomach, lesser curvature, fundus of the stomach, cardia, as well as the antrum of the stomach, you can encounter different lesions. Then depending upon the location which is seen on endoscopic ultrasonography, you have an 85% chance of not only diagnosing the site of the lesion properly, but also can have a tissue diagnosis if you do. Fortunately for us and fortunately for our patient, 85% of all subepithelial lesions incidentally encountered on endoscopy are benign in nature. Only 15% are malignant. How do we know which patients, which lesions are likely to have malignant potential? Almost all patients with neuroendocrine tumor, all patients with gastrointestinal stromal tumor, all patients with malt lipoma, and patients with the set-like carcinoma metastasis. These are the lesions which are definitely malignant. And conditions like GIST, especially if you have a GIST which is smaller in size, or a glomus tumor, or a granular cellular tumor, these are the lesions which are likely to have malignant potential and hence needs to be removed. If you see from patient's point of view, patient wants to know, is the lesion malignant or not? What is the size? Is it increasing over a period of time? Because if you do not remove the lesion, patient will always have a lurking doubt in the mind. Is the lesion increasing? Is it malignant? What will be the implications of management? And certainly he would like to know from you what are the complications associated with it. So when do you require a tissue diagnosis? In fact, these are different guidelines. Do all patients with subepithelial lesion require a tissue diagnosis? can we leave the smaller lesion untouched without tissue diagnosis? These are the guidelines. For for all suspected GIST, you have to do a biopsy. Japanese surgeons require that all patients who require surgery for indications like suspicion of GIST or leiomyoma in the stomach or other conditions, you do require a tissue diagnosis. As I said, tissue diagnosis is primarily done today with fine needle aspiration biopsy. In fact, now almost we are writing an obituary for fine needle aspiration because it has been convincingly shown that 22 gauge needle with the EUS gives you a best answer. And most of us, because not only do you have to confirm the diagnosis, but you may have to do a molecular testing and KIRAS testing, which is so important because patient will come back to you from an oncologist that if these parameters are not available, then therapeutic management may change. Biopsy is also useful in patient with, as I said, in patients who have a malignant potential, who are likely to have malignant potential, and in almost 80 to 90% of the times when the lesion is accessible, and especially if it is more than 1 centimeter, most of us can have enough tissue diagnosis on EUS FNAB. Now, depending upon the type of the lesion which you have encountered, the various modalities which are available include endoscopic submucosal resection or endoscopic submucosal dissection, depending upon your conceived and perceived depth of invasion of the lesion. So, in general, if the lesion is less than 2 centimeter, preferably less than 13 millimeter, endoscopic submucosal resection is the best way of modality, and then we believe that this lesion is arising either from the mucosa or the submucosa, and you can easily do a procedure of EMR. This is a classical example of inflammatory fibroid polyp, where you can inject it into the mucosa and then do a simple EMR and send the tissue for examination. At times, you can even try to put in a band, especially if you have a small duodenal net, just put in a band at the base of the polyp, and then after you have put in a band, you can do a polypectomy at the base so that you can have a good tissue diagnosis. This band and resection is an extremely useful modality, especially in duodenal lesion of less than 1 centimeter. Endoscopic submucosal dissection, you have been repeatedly seeing in the live workshop, how do we do these procedures, and you need to have a gadgetry of these tests. Patients with GIST, especially with low GIST, you can easily do a resection of the lesion using ESD, and in patient with ESD, the best indications are depending upon the site which is preferable for doing ESD. So if you are doing a ESD, the best location will be in the lower end of the esophagus or at the cardia of the stomach. At times when the location is difficult, when ESD is not possible, Sukrit has shown very elegantly that you can do an EFTR. EFTR can be both exposed and non-exposed depending upon the location, size, and the availability of the lesion. The only thing you have to understand is if you are doing a exposed EFTR, which means you are creating a hole by default and then trying to close it, you need to be totally equipped with the accessories to close it, which could include a Apollo stitch or loop and closure divide or large clips depending upon the size of the defect. So these are the advantages and disadvantages of using an exposed versus covered EFTR. Covered EFTR is something which most of us prefer in day-to-day practice. So ladies and gentlemen, if you have a subepithelial tumor, look at the EUS depending upon the layer of the region. So if you have a layer of the region which is in the second and third layer, and most of the lesion, if it is popping into the lumen, the treatment choice is EMR, that is endoscopic mucosal resection. If you have an intraluminal growth and the lesion is less than 13 millimeter, you can either do an EMR, or if the lesion is more than 13 millimeter, you can do an ESD. But if the lesion is arising from the fourth layer, that means muscularis propria as per your assessment during EUS, then depending on the location of the lesion, whether it is in the esophagus and stomach, your approach may be variable. It is very good to do an ESD in the esophagus, but if the lesion is in the stomach, especially in the areas which are not accessible to ESD, then EFTR is the preferred location. This is another way of classifying the same type of lesion, subepithelial lesion, depending upon the color, surface, and the presence or absence of the Cushing sign, you have to do EUS, and depending upon the size of the lesion, this origin of the lesion, you have different modalities for extirpating it. So to sum up, ladies and gentlemen, subepithelial lesions are commonly found during upper GI endoscopy. At times, it is not easy to decide whether to resect or leave it alone. I think the color of the lesion, the rolling sign, the Cushing sign, and the layer of the origin of the EUS and presence or absence of the potential for malignancy make us decide which case patient can be taken up for resection endoscopically. All lesions which have a potential for malignancy need to be removed, and hence we need to have a good knowledge and experience before taking up the patient for therapy. Thank you.
Thank you, Professor. Extensive descriptions of the subepithelial tumor. So previously it was told that it is a submucosal lesion, but nowadays it is a subepithelial
I think,
tumor.
earlier this is a recent change in classification. I'm glad you asked it. When you say submucosal, that means and anything which is beyond the mucosa will be submucosal, but that could lie into the muscularis propria, muscularis mucosa, and deeper layer. Subepithelial would mean that is beyond the epithelium, and which will cover up all other layers, including submucosa, muscularis mucosa, and muscularis propria. So subepithelial lesion is the currently accepted definition.
That is the characterization.
Yeah.
So I have one question, sir. So when we are doing endoscopy, if you find elevated lesions like this in the mucosa, so as you know, if you do take biopsy subsequently, EST or MR may be difficult. There will be a fibrosis. So in which case we should not take biopsy at all, and in which case you can take, because all patients may not do EUS. Subsequently, if I advise EUS, they may not afford it. So, and they may not come again also. So in which case I should not take at all, never, and in which case I should take biopsy, even if there is chances of fibrosis still there.
Yeah. You see, whenever you have a subepithelial lesion, let's use the correct definition. That means the lesion is beyond the mucosa. That means you are not able to see it with the naked eye. So you need to have a second modality to look at the nature of the lesion. So second modality could be two ways. One is you can have a cross-sectional imaging, good quality contrast and then CT scan, or a preferred modality which we use as endoscopy is called endoscopic ultrasound. Short of that, you will not be able to differentiate between the two. Regarding which patient should not have an FNAC, if you think there is a submucosal lesion which is a varix, or a lesion which has a AV malformation, or a dulifoid lesion projecting into the lumen. So if you end up doing biopsy in vascular lesion, you will create problems. Depending upon the size, location, and the superimposed finding like ulceration, dimpling, none of these should be left alone unless you are sure that is all benign. Make all efforts to get onto the tissue diagnosis. Best can be achieved with endoscopic ultrasound guided biopsy, that too to the tune of about 80%, not 100%. That is the reason finally you end up removing these lesions, so that in toto you have a diagnosis as well as you have got rid of the lesion.
Yeah.
That is a good point, sir. But my point is, he may not come afford US also. He may not come again. So we may miss also early gastric carcinoma. Suppose in the stomach. So in taking that scenario, whether I should, I will not take from varix, I will not take from vascular lesions, I will not take all those things. Point I will take into consideration.
Absolutely. Biopsy will not be helpful.
After that, still if some elevated lesions with some hyperemia, because now early gastric cancer is looking similarly. If I will not take, he may not come again for endoscopy. So what should I do?
You see, if you have nothing else to do, if you are sure it is not a vascular lesion, best is to remove it. That removal will not only give you assurance that everything is out, but you will also have a tissue diagnosis follow-up. You cannot leave it. If a patient cannot afford anything, EUS, CT scan, he cannot follow for something, then you have to tell him that he has a chance of this lesion being malignant and may flare up later on. Something has to be told to him.
Yeah, actually Anil, there are a few points in EUS actually. To actually focus a small lesion on a linear endoscope is difficult, because if it is in the stomach, then actually you can't actually, put your probe on a very small area. So that is one problem. And second problem is that when you are using FNB needles, so at times these are vascular, you get a lot of blood. So the exact histology may not be there on that. And a comment about maltoma. I had a patient a month ago, referred from oncology actually, and started on H. pylori treatment. So H. pylori positive, maltoma, ISC proven. So I called him for EUS. So to my surprise, after the 2 weeks of therapy, there
Lesion
was
had
no
gone.
tumor. There was no. So it's a melting tumor like melanoma.
I agree. I agree. This is the most gratifying tumors to treat. If you want to have the maximum advantage of a patient, gratitude to you, start treating maltomas with therapy for H. pylori. That I agree. Regarding the size and the ability of the EUS to pick up a lesion, I do agree, especially in a voluminous stomach. A small lesion, it's not easy to focus onto an ultrasound. That is the reason there is a school of thought that is subepithelial lesion with less chance of being a malignant potential. You can just follow up small lesion till they grow up to a significant size. It depends on your expertise and your ability. At times you have to make different maneuver, put a lot of water, and let's have a water interface and try to change the position of the scope so that you can get onto it. I agree. That is the reason I said EUS does not give you 100% diagnosis of tissue. It occurs even in the best centers of the world to the tune of about 85%. So that if you are in doubt, then it's better to take it off. If you think there is any suspicion of dimpling, ulceration or scarring, it's better to take it out rather than leave it alone. But there is a school of thought which believes that anything less than 1 centimeter, you can simply follow up and put them on surveillance.
And regarding the bleeding during taking the
Yeah,
tissue.
that is if it is a small lesion and if you are doing a biopsy, bleeding will always be a part of it. In this subgroup of the patient, maybe an EUS FNA may give you a better result than EUS FNAB.
Thank you.
Sir, sorry, larger lesion, smooth outline. If you take biopsy, nothing will come.
Yeah, in fact, there are
It will-
two
nothing
ways
will
of
come.
taking, this is a very good question. There are two more ways of taking biopsies. One is called bite-in-bite biopsy. Second is mucosal incision and assisted biopsy. So what you do is, because the lesion is primarily in the submucosa, so you make an incision in the biopsy or take a bite with a jumbo biopsy from the mucosal lesion, and then you have to expose the submucosal lesion. Then you take more biopsies. The only disadvantage is at times the bleeding may be significant. But this is called mucosal incision assisted biopsy as well as bite and biopsy. So these are two ways of having tissue diagnosis from the submucosal lesion. But still the best modality is EUS.
Will you move on to close this session? Will you request to switch on to live session, please?
Thank you, chairpersons and speakers, for this excellent session, for sharing the expertise and insights on the interventional endoscopy, all the key areas. So for the next session, I would like to invite Dr. Girish Kumar Pati, Dr. Shakti Prasad Chaudhary, Dr. Devkant Mishra, and Dr. Gadadhar Panda to chair the session, which will be on exploring endoscopic advances in the pancreatobiliary diseases. So now we'll be going live to see some of the cases for a couple of minutes, then we'll be moving to the lectures.
So video
Over to you,
demonstration.
chairpersons.
Sir, am I audible? So we have a 69-year female.
Yes, you are audible,
She's
sir.
a known case of adenocarcinoma distal tumor. She underwent a surgical GJ 4 months ago. Now she presented with 1 month history of a gastric outlet obstruction with endoscopy suggestive of ulcerated growth at the pylorus and narrowing of the efferent loop of a gastrojejunostomy site. And so plan is cold axios of the anastomotic site, and it will be performed by Dr. Rahul Pannala. So over to room number 3 for the demonstration.
I'll use that as a teaching.
Management of disconnected pancreatic.
Good morning. Can you hear us from the room?
First Dr. Vikas Singla, with after Dr. Sanjay Rathi, after Dr.
Yes, sir, you are audible, sir. You can proceed.
Okay. Good morning, everyone. So as Dr. Guru pointed, this is a lady with gastric adenocarcinoma who has had a sort of a gastrojejunostomy, a decompressive gastrojejunostomy. And I have with us our team here and Dr. Amir and Dr. Sumit from anesthesia. So this is maybe a very good teaching case for what we can do and what we cannot do. The original plan is, the thought was that this was a stricture at the gastrojejunostomy. And when Dr. Sannoon did the case, she did it when initially with an endoscopy which was not sedated and the patient could not tolerate. So she saw a stricture at the gastrojejunostomy. So our original plan was to put a cold axial stent. As you can imagine, if you have a circular stricture at the gastrojejunostomy or any kind of gastrojejunostomy, then it's a very effective way to treat that because of the dumbbell-shaped nature of the stent, which can prevent serial dilations, things like that. Now, luckily we have anesthesia today. Patient is airway is protected, so I can be a bit more aggressive. So I was able to get my scope through the gastrojejunostomy, and I'll show that in a second. But we were able to get into the jejunum, and about 15 centimeters into the jejunum, we reach a area of complete blockage. Area of complete blockage. So we were able to get a wire past the jeju into that and inject contrast. As you can see the, can you show the endoscopy image?
Show the fluoro now.
Can we show the fluoro image? So using a hydrophilic guide wire, in this case a VisiGlide, we are able to pass that. We will again inject some contrast just to demonstrate. What we are finding is an additional stricture, fluoro. Inject kariye. Are you able to see the fluoro in the hall?
Yeah.
So what you can see now, wire thoda add kariye. As you can see, there are multiple, there's another area of obstruction that is much more distal. And as I'm injecting my catheter, you'll also see the fluoro kariye. You'll also see the stricture that's much closer to the scope. So I think, so what would you do here, doctor?
So the plan was to place the cold axios, but considering that there are metastatic deposits on the mucosal surface also, and multiple strictures, I think there is one stricture that we could locate like around 10-15 centimeters beyond this stricture also. So we are planning nasojejunal. We are abandoning the axios and planning a nasojejunal tube only.
Yeah, so in this case, it looks like patient has widely metastatic serosal disease, which is causing multiple points of obstruction. So stenting just the gastrojejunostomy, and I'll show you, is not necessarily going to help. And even stenting this one segment does not inject contrast, is not going to help. So she needs more of a decompressive type of procedure. So any other thoughts from the audience? What would inject? So as I come back, you'll see this stricture. So now can you inject? Yeah, so you can see the stricture. Fluoro dabaye. Stay done. So as you can see, there's a very tight stricture there, like where our catheter is, and there's an additional stricture with a dilated bowel loop. So that's good. So also right there. That's good. So that is the point of obstruction. I think there are multiple teaching points here. What I'll do is add the wire, and I will come back. I also want to show you the stomach and the gastrojejunal anastomosis and how edematous this is as I come back. And you can see as I'm coming in, this is the gastrojejunal anastomosis. And it's not completely obstructed, but it's very edematous. And you can see that the rest of the stomach is also very edematous and likely infiltrated with cancer. So we have so we're looking for ideas and options.
Option one is, if we put in a nasojejunal tube deep down,
yes,
then do a cholangiogram or CT enterography by through the tube,
yes,
and find whether the lower part of jejunum is patent. Then offer a GG.
Correct.
That is one of the ideas.
Yes.
Or because I don't believe you can go on even with an endoscope dilatation long.
This is cancer and likely serosal disease. So
that a GJ palliative GJ from remaining part of the stomach to the
unobstructed
unobstructed part of jejunum below the muscle.
Yeah.
Because if we look at it pathologically, how this cancer would have spread it, because this would have spread it from the superior mesentery. And that superior mesentery is encasing along the mesentery, encasing the jejunum. So I believe the ileum part or lower jejunum part may be spared.
So you want to pull that and make a...
So we want to make sure whether it is upper jejunum is blocked, whether it is lower jejunum is blocked. So if lower jejunum is patent,
you can pull that and do a...
we can place a tube only in that. Then the challenge would be to identify that on fluoroscopy, but we have to make sure that our tube is lower down.
Much lower down.
Much lower down. But that pulling back, if it is visualized at the time of doing a GJ, if we can see the fluid moving within the same loop,
then we can do it.
Pulling back is not done, because if we are identifying the loop,
Yes.
then it can be pushed or readjusted. Maybe if it comes close,
Yes.
maybe.
The only one of the challenges there is also going to be ascites. So in this, she has ascites, but there's some data to show that you can still do it safely, but it definitely makes it a very higher risk procedure.
The only thing is patient wants to eat for remaining, say, 30 days or 20 days. So that is patient's choice.
Yeah. So as you can see, when I come back here, this is the gastrojejunostomy, and then this is the rest of the stomach with extensive disease. So at this point, we will see if we have a jejunal tube. We'll try to put it as far as we can to try to decompress, but the main challenge is going to be the gastric decompression. But any questions, anything from the audience?
All right, so that's a great teaching case and practical case, I believe. And it's very important to assess the entire jejunal site in case of peritoneal metastatic disease, because sometimes we do GJ and there is stricture downstream and the patient, they don't get better. So thank you, and we will first decide what we will do for this patient, and I can move to room 1 first to Guru to present the room 1 case, and then that's a short case, and then once that's done, then probably we can switch to the sessions. Thank you.
It's not widely metastatic.
So we are moving to room number 2. Room number 1, we have a 74-year male
into the J.
with no comorbidities.
NJ does it. So, I mean, what I'll do is
duration,
I'll go.
and his endoscopy was suggestive of an irregular nodular mucosa in the proximal body along lesser and the posterior wall of the stomach, with NJ suggestive of irregular microsurface and microvascular pattern, and it will be demonstrated by Dr. Noria Uedo from room number 1.
Are we audible from this room?
Yeah, you are audible, but if volume will be little bit increased, it will be better. Volume inside the room should be increased little bit.
Yeah. Hello, can you hear me?
Yeah, we could hear you.
Okay. So now we assess that region, small region, with a magnifying NBI. So before insertion of the scope, it is very important to use the black hood to perform magnifying observation, and then to adjust the length of the projection of the hood. We usually use this kind of scale. So this is 1 millimeter square scale, and then after this is a cap, black rubber cap, like this, and then we put the cap to the tip of the endoscope. At that time, it's better to see the endoscopic image in order to see the tip of the cap, to see the periphery of the endoscopic image, and then to adjust the projection length is optimal. We usually use this type of scale, and then use full magnification. And when the lateral side is between 4.5 or 5 millimeter, this is the optimal length. If it is too short, it can be 4 or 3, a little bit shorter. But so this is optimal length. So anyway, this is a very important preparation.
So the black cap is different from the transparent cap in the sense that it is much softer.
Yes,
so
yes.
it prevents injury to the mucosa when you are doing a diagnostic endoscopy. And second, it prevents the dissemination of light outward. So you can focus all your imaging to one aspect of the stomach. So that for diagnostic endoscopies, I think the black cap is much more suited than a transparent hood.
And the patient has a melanosis. And again, this is a high risk finding for esophageal squamous cell carcinoma. So I think it's better to evaluate hyperpharynx or esophagus, but I think this time there's no sedation. So I just quickly pass the pharynx. But just take one picture, but not so much obvious lesion. But anyway, this is upper sphincter. So with cap, actually we can really see the upper sphincter very well. That is also benefit. Upper sphincter or even lower sphincter as well. It helps evaluation of easy junction or narrow lumen.
So Dr. Vedo, do you always prefer going in with an NBI upfront rather than one side?
Yes, in my practice, yes. Can I submit home? Maybe either insertion or withdrawal, it's better to see with the NBI because it detects, randomized control trials show that it detects more superficial squamous cell carcinoma compared to white light. And so during withdrawal, we can choose NBI, but after insertion and procedure, maneuver, sometimes scope can cause mucosal trauma. So I prefer to evaluate initially with NBI. So now you can see some small brownish area as well. So such region we can perform magnifying observation. But one important tip is if you locate the lesion into the 6 o'clock position, the lesion becomes very tangential. So sometimes a bit difficult to get a very good magnifying image. So at that time, we rotate the scope and make it 12 o'clock position, and then suck the air. So the mucosa becomes forward, and then we can see good magnifying image. And then it sucks the air. I think this is little bit suspicious, but the very tiny region. So easy.
So why do you say it's a suspicious lesion?
Because it has a very clear demarcation.
So one of the important things that you need to look out for is a demarcated lesion.
Yes. And then not only dilatation of the vessel, there is color, epithelial color also change.
Yes.
So that is epithelial change and the vessel change is simultaneously happen. So
So what you're looking out for was the IPCL, right?
IPCL, irregularity of the vessel, and also discoloration of the epithelium as well. So if it is fulfill the both criteria, I think the neoplastic chance of neoplastic lesion becomes higher. But anyway, but the lesion was too small, so I think we can just leave it.
What do you say of the IPCL pattern you saw?
I think it's still type B1. And then this is G junction. Can you see the palisade vessel here? Yeah, this is longitudinal 3 o'clock position, you can see the palisade vessel, longitudinal vessel. According to Japanese endoscopists, this is a landmark of end of esophagus, lower edge of esophagus, anatomical esophagus. So in this patient, end of esophagus, EG junction, and the squamous-columnar junction is the same level. So it means the patient does not have a Barrett's, no columnar line esophagus. So this is a diaphragmic pinch. So very short hiatus hernia and no normal EG junction.
So the fluid that he transiently used to flush was a mixture of N-acetylcysteine and thiamethicone, which actually helps in mucosal visualization as it clears out all the bubbles and the mucus.
Ah, I see. So can I have thiamethicone as well? Yeah, thiamethicone.
So in Japan, you depend on the palisade vessels to determine the end of the...
Yeah.
You don't rely on the end of the gastric folds.
We do, but priority is a palisade vessel. And then if we cannot evaluate the palisade vessel, we evaluate gastric fold. Probably because many patients, Japanese patients, has atrophic gastritis. So some of the patients with atrophic gastritis, already gastric fold is gone. So it's very difficult to evaluate.
And maybe it also helps because the insufflation, the amount insufflation you do, the gastric folds tend to disappear sometime. I mean, maybe it confuses things more. I think the palisade vessels are more...
It's a more anatomical landmark. So I start SSS protocol from upper corpus, 4-quadrant direction. So, but anyway, there's a many elevated lesion with some small erosion.
So in the stomach, you would see white light first, not NBI in the beginning?
Currently, standard observation is white light. Yes. So middle body, 4-quadrant direction, anterior wall, lesser curve, and posterior wall. And when we look at the gastric corpus, maybe you see that the gastric fold is almost proximal stomach. There's a gastric fold, but distal stomach already, even greater curvature side, gastric fold was gone. So it means the patient has an atrophic gastritis.
So the point here to note is that despite seeing some suspicious lesions, he's still being very meticulous, first doing his systematic examination of all the quadrants.
Yes.
And then eventually he'll be going on to examine the suspicious lesions in more detail.
Yes. So, and also it's better to evaluate the risk of gastric mucosa. If the patient has a gastric atrophy or intestinal metaplasia, maybe index of suspicion for the localized lesion increase. So if patient does not have any atrophy or intestinal metaplasia, it means no H-pylori infection. Maybe erosion should be likely to be more benign. But for example, this patient has atrophic gastritis, and also if we switch to NBI, you can see many whitish patches, meaning the intestinal metaplasia in the stomach. So I think this patient is a high risk for development of gastric cancer.
Could you tell us more about how do you say why this is atrophic gastritis? What are the features?
So yesterday I explained, but mucosal atrophy is defined by the pale. One is loss of gastric fold, and second is a pale color of mucosa, and then increased visibility of the vessel. So lost gastric fold, and the mucosal color is a little bit paler in the lesser curve compared to greater curve. And then visibility of mucosal vessel, maybe it's better to evaluate with a retroflex view. Anyway, we proceed the scope to...
So the atrophy progresses first along the lesser curvature, is that true?
Yes. H. pylori associated atrophic gastritis, yes, lesser curvature predominant. And autoimmune gastritis usually more diffuse or rather greater curvature dominant. So distribution of atrophic mucosa also associated with a different etiology or pathology. So now you can see in the white light there is some whitish elevation. It's a kind of mosaic pattern or cobblestone-like appearance of whitish elevation. This is intestinal metaplasia. And then NBI really enhance the color or appearance of such intestinal metaplasia. And the reason why intestinal metaplasia look whitish is we change to NBI and use magnification. Now you can see the whitish, some substances accumulated in the intervening part of epithelium. So this really obscure the brownish subepithelial capillary. So this is called white opaque substance, which is the absorbed lipid droplet to the intestinal metaplasia.
Do you also see some light blue crest?
Yes. Yeah. And then on the surface of epithelium, there is a kind of whitish lining of the light reflection. Like this. Not so much obvious, but anyway, you can really differentiate area of intestinal metaplasia and non-metaplastic mucosa. So NBI really enhance this type of color or difference change, characteristic finding. So anyway, but still I don't see, there's many multiple elevated lesion with small erosion, but not so much obvious, very large independent lesion. Anyway, I continue systematic observation. Please ask him to saliva. Or just discharge. Yeah. Don't swallow. So this is D2, and then check the duodenum circumferentially, and then come back to the stomach again. And then we change to retroflex view, and then continue systematic observation. Let's start posterior or...
In the retroverted view, can you tell us about which is the lesser curvature, greater, anterior, posterior?
I see, but basically, this is lesser curve, center of the lesser curve, that pylorus, and then cardia. So the line between two orifices is the center of lesser curve. And then for downward view, this is posterior wall, and then anterior wall. So same direction. Even retroflex, this is posterior wall, and then this is anterior. So same. That is my what I remember. And then during retroflex, I usually use a small wheel to the left, like this, so that we can see the corpus lesser curve in the frontal view.
So the atrophy is going all along the lesser curvature?
Yes. So
it is closed free?
No, open, yes. Because atrophic mucosa, pale color, and then now you can see the increased visibility of the submucosal vessel. So it really extends to the cardia, and then almost extended here and here, extended to the anterior wall and the posterior wall. So I think this is Kimura Takemoto classification, open 2.
So
Yes.
Kimura Takemoto classification is to see the extent of
The
atrophic gastritis.
atrophic mucosa.
Atrophic mucosa.
Yes.
So greater the atrophy, more the risk?
Yes.
of having a
Yes, yes, yes,
neoplastic
yes. Neoplastic lesion. Actually, there is some cohort study to show that a patient with a wide area of endoscopic atrophic mucosa has a high incidence of gastric cancer.
Is that a xanthoma there?
Yes, here.
So
This
xanthoma is also a high risk?
Xanthoma is also associated with extensive atrophic gastritis. So some observational study also indicated that the presence of xanthoma also is a risk factor for the presence of basically anywhere. Yes, it's usually associated with extensive atrophic mucosa. So according to my systematic observation, he has many multiple elevation with some erosion in the mucosa. And then background mucosa has an extensive atrophy and intestinal metaplasia, even in a corpus. Usually the intestinal metaplasia develop from the incisura and then extend proximal to the corpus, to other cardia. For example, this is also intestinal metaplasia. Yeah, you can see that. Yeah, light blue case sign. So usually non-metaplastic normal corpus mucosa has a really regular round pits, but this mucosa is almost like a piriform, which is very similar to antral mucosa. So this is very extensive atrophy of intestinal metaplasia. But anyway, so actually he has many depressed lesions. And then in that case, maybe we choose some lesion with larger than the others, or more redder than the others, or some more irregular than the others. But so according to that policy, there is some small one, and then I think this has a little bit large. Oh.
Where did you choose that?
Maybe that.
Can we switch for a while? We'll switch to some other room.
Yeah, of course.
So we'll just transiently switch to the other room.
Yes.
We'll examine the stomach until then and we'll get back to you.
Because the depressed area is larger than the others. But, not so much. Not so much suspicious. Maybe in such case, I just follow up.
So many reasons.
Yeah. And then maybe no. Yeah.
So when there is slump there, you clean it up and then.
So we are shifting to room number 2. So we have a 40-year
Patient is positive for expiring
to us
infection,
with
maybe we eradicate and then also follow up.
We are shifting to room number 2 for our first case of room number 2.
Eradication
So we have a
maybe
40-year male. He presented to us with
to see the improvement
and
of
unintentional
mucosal
weight loss of
appearance
5 kg in last 2 months. With
3
endoscopic
months
history of
or
a
6
epithelial
months.
lesion of approximately 8 by 10 millimeter in the duodenum, and evidence was suggestive of a well-defined hypoechoic lesion originating from the layer 2 and layer 3, predominantly from the layer 2. So plan is endoscopic submucosal dissection, and it will be performed by Dr. Sridhar Sundaram. Over to number 2.
So in intestinal metaplasia and atrophy will remain.
Yes, especially intestinal metaplasia remain.
Now we are requesting Vikas sir to tell about disconnected pancreatic duct syndrome. So that we are going to, we are requesting Vikas sir,
3-5
please.
years or something.
That's okay. I've injected and I'm cutting
Once
it.
he's developed atrophy and metaplasia, he's always predisposed to
Yeah.
even if you grab.
So am I audible?
Sorry sir, Doctor, please focus on Sridhar sir's view.
So, okay. I think we went ahead with injection and so the initial plan was ESD, but the lesion is only 6 millimeters in size. It's a very small lesion in the duodenal bulb. So, which is why we changed to conventional EMR and we just injected the base and we're just planning to do a resection. What is the partition? Okay. So I'm doing a plain EMR. I mean, there are multiple options in this location. Typically, for lesion more than 1 centimeter, I do an ESD, or you can do an EFTR with a FTRD device. But I mean, this is 6 millimeters. You can actually band and leave also. But the other option is doing an EMR. I prefer doing a conventional over a band EMR because the band may tap muscle sometimes. So which is why I usually inject and then cut directly. Okay. I've already gotten the lesion in my snare. Can I cut? Okay, can flush. Okay, that's okay. That's clean only. Usually, no, that's not a residue. Usually, not this bit you're saying, not a residue. You can actually remove that also. Okay, open. Hey, boss. Is there a loop here? Loop holder here? Don't flush. Yeah, I'll go ahead. Won't be an issue. Nah, yeah, that's what so. I mean, is there a... I'm looking like I'm going to be chasing this NET. It's a grade 1 net, so I'm not too worried, even if it goes ahead. Okay, let's just suck everything out. Yeah, we have a trap here. Yeah, I'm hoping. Just one second. I think. Wait. Let me come back till the site and then we can. Okay. I think now you can just see. Yeah, it's it. So it's a very small lesion, maybe 4-5 mm. Okay. I think you can go back to the flush, please. Yeah, flush, please. Yeah, you can, I guess, go back to the session, so, yeah. I know. You're sure, right? Typically flush नहीं करते मेरे भाई.
So we can go with the lecture presentation at the Mayfair Hall. Meanwhile, we will.
3-4 mm ही है वो क्योंकि हाँ okay चल ठीक. नहीं रे टिश्यू है क्या देखने से फ्लश करेगा. हाँ ठीक है वो निकाल देंगे ये करके.
Now lecture view.
मैं बैंड नहीं करता यार टिपिकली. बैंड करके छोड़ना है तो बैंड करके निकालना है.
Lecture view. Sorry, sir, for mild
So
interruption.
actually, yes. But I prefer a Gelofuscin injection. Saline usually doesn't say so, which is why you can see that the base is still open. No, not before doing band. Okay. Yeah, polypectin. ठीक है, हो जाएगा. Open करना.
Can I get my slide? Can I start? Good afternoon.
Yes, sir, please start.
Good afternoon to all of you. At the outset, I'm thankful to Dr. Sunmoon and Dr. Ashutosh Mahapatra for the kind invitation. So this was 2016. So me and Ashutosh met in Japan National Cancer Center. We both went for ESD training. We used to have a lot of discussions and learned a lot in that part. And Ashutosh used to be very aggressive as usual. He always was full of ideas that you do this, you start your own hospital, always full of ideas. Even today, even we meet, he's always full of energy, and he passes on energy to me and give new ideas. Thank you for that. So coming to the topic, DPDS. So what is DPDS? So we call it disconnected pancreatic duct syndrome, but in fact it is discontinuation of pancreas. So if we see the imaging in detail, we will find that in patient with the DPDS, there is discontinuation of the pancreatic parenchyma. So it can be called disconnected pancreatic syndrome also. So there is a complete discontinuation of the pancreas. For the syndrome, there should be some viable upstream parenchyma. So two things are required. One is the discontinuity of duct and some viable pancreatic parenchyma. So this parenchyma keeps on secreting the pancreatic juice, and which will lead to the complication and increase the morbidity. So this video shows the normal course. So the pancreatic juices are secreted in the duodenum. There they help in digestion. So what happened in DPDS? So there will be discontinuation of pancreas. So this fluid will accumulate at the site of discontinuation, and this will, we can call it either acute fluid collection or the wall of necrosis, depending on the timing and the wall formation. And sometime during acute pancreatitis, when we place a drain for the treatment of WOPN, so sometimes there can be external pancreatic fistula. What happens? This parenchyma keep on secreting fluid, and this fluid will enter the catheter, and the patient will develop external pancreatic fistula, and this condition becomes difficult to treat. So we'll discuss all this in detail. And sometime in patient with DPDS, there can be a dilatation of the duct in the pancreatic tail. So this will lead to recurrent pain abdomen in the left hypochondrium, a situation very similar to chronic pancreatitis, but pain in the lesser left hypochondrium. So DPDS can occur mostly in the setting of acute pancreatitis. There we have a segmental necrosis, mainly in the neck region with the viable body and tail region. Few patients with chronic pancreatitis may develop, especially alcoholic patient, post-surgery after the median resection of the central part of pancreas, and sometimes due to the blunt trauma of the pancreas in children. So DPDS occur in 16 to 80% of patients with the acute necrotizing pancreatitis. As I mentioned, the patient who had necrosis of neck of pancreas, they are more prone to develop this DPDS. And the fluid will leak in the surrounding area, lead to acute fluid collection or the wall of pancreatic necrosis. So this condition can be diagnosed in the early part of the pancreatitis also. Generally we don't look for it. So we are worried about the other clinical features in the patient. So if on CT scan we can see there is a necrosis of pancreas and the fluid collection, it's an indirect evidence that patient is having DPDS. And in the later part of illness, if the WOPN is replacing the central part of pancreas, that can tell us it can be a DPDS. So how we diagnose DPDS? We can use MRCP, endoscopy, ultrasound, ERCP, or the CT scan. MRCP is the best test to diagnose the DPDS without any complication. On here we can see there is a dilated duct and there is a ductal discontinuation after an attack of acute pancreatitis. On ERCP we can see opacification of duct only in the head region. We cannot opacify duct in the tail region. ERCP can lead to pancreatitis, should be avoided. DPDS can be diagnosed easily with the MRCP. On the endoscopic ultrasound also we can see dilated duct in the body and tail region. Then suddenly there is a cutoff and this duct may continue with the fluid collection. So this is another evidence of DPDS. On CT scan we can see this is the pancreas. This part of pancreas is replaced by necrotic collection. Here we can see a viable parenchyma. So this will be a DPDS, viable parenchyma and the ductal discontinuation. Here we can see whole pancreas is replaced by a fluid collection. So this cannot lead to DPDS. So this is because there is no viable upstream parenchyma. In the later part of illness, patient will develop WOP and walled off pancreatic necrosis. If we don't do any drainage, the fluid collection may persist. That may not disappear. That can be one evidence. When we do the internal drainage and remove stent, these patients are more prone to develop recurrent fluid collections. And when we do external drainage, they are more prone to develop external pancreatic fistula. So what is external pancreatic fistula? Here the patient will have a continuous outpouring of a fluid through a percutaneous drain or a surgical wound. And to diagnose any amount, maybe 10 ml is sufficient to diagnose external pancreatic fistula. And the amylase content should be more than 3 times of upper limit of normal in the fluid. So external pancreatic fistula occur mostly in the setting of acute necrotizing pancreatitis, where we use the percutaneous approach to drain the fluid. It can be high output or the low output fistula. Cutoff is 200 ml per day. So after the Panther study, step-up approach has become preferred approach for the treatment of acute necrotizing pancreatitis. So this trial shown that the percutaneous approach is preferable over the open surgery. Here we place a percutaneous drain mainly in the left retroperitoneum. So when we place a drain, there is high risk of external pancreatic fistula to the rate of around 30% after placing a drain. So when a patient develops external pancreatic fistula, so what are the treatment options? One is the conservative approach. You just wait and watch. Second is doing an ERCP. Third is surgery. Then doing a EUS guided special procedures. So if the drainage is less than 200 ml per day, one can wait and watch. And it has been seen that in 90 days, most of the fistula will disappear if the fluid is only less than 200 ml per day. But the patient has to wait for 2 to 3 months for fistula to heal. Other option is doing an ERCP. So if there is a partial disruption, we can pass a wire in the tail region and one can perform ERCP and the fistula will heal. I think Dr. Rajput will agree that in necrotizing pancreatitis, there will be total discontinuation. We will not be able to pass a guide wire in the tail region and it will be difficult to bridge the leak. And in a study of 43 patients who underwent ERCP for the external pancreatic fistula, there was a high risk of failure in acute pancreatitis, suggesting there is more likely to have DPDS rather than just a discontinuation. These patients had complete discontinuation of the pancreatic duct. Other option is doing a distal pancreatectomy, but this has a high morbidity and potential mortality also. So one can use various specialized endoscopic approach. So one option is we can inject fluid through the PCD and there will be a transient fluid pool formation, and this pool formation can be drained with the endoscopic ultrasound, but mostly this cavity is fibrotic. Even with the injection of fluid, sometimes difficult to expand the cavity and difficult to place a stent in the cavity. So at our center, we are treating this patient with the special technique, which we call it dual scope technique. So here we can see the patient has acute pancreatitis and there is a drain, and for the last 60 days, the patient was draining 200 ml of fluid per day, which is high in the amylase. So, first we remove the tube and the bag, then we can pass a ultra thin scope. So this scope diameter is the 5.2 mm, and for this technique, the hole size should be at least 24 French. So here we are passing a scope inside the sinus, and on the left side we can see this is the image inside the sinus. We can see we have gone inside the sinus. So the idea is to connect this tract with the gastric lumen. So once one scope is inside, now through this scope we can inject fluid. So from the outside tract, the scope is inside the tract, and we are injecting the fluid inside the virtual cavity. Then through the gastric lumen, we are doing the endoscopic ultrasound. So now we have two scopes simultaneously. One scope is in the tract, and one scope is inside the stomach. So when we inject fluid in the tract, this fluid can be seen from the stomach. With the endoscopic ultrasound, we can see fluid there. Can you appreciate the moving fluid? So we inject fluid in the tract, and this fluid is seen through the stomach by the endoscopic ultrasound. Then we puncture this virtual with fluid collection with the 19G needle. and you can see this needle can be seen in the tract. So the needle has been passed through the gastric lumen, and this needle can be seen in the tract, and through this we are passing a guide wire. So this guide wire will be secured at two places. One is outside the drain, and second is at the oral cavity side through the scope. And now, once you have secured wire at two places, it's very easy to place a stent. We will do the dilatation with the coagulation current and with the diathermic catheter, and then the balloon. And over the wire, we can place a stent between the gastric lumen and the. So we can see here, we are placing a stent between the sinus tract and the gastric lumen. So now, whatever fluid is secreted by the residual pancreas, it will enter inside the tract, and from the tract it will be diverted towards the gastric lumen, and this outside opening closes within 24 hours. So with this technique we can close the external pancreatic fistula. Another technique is single scope technique. So here we, with the endoscopic ultrasound, we can see here, this is the drainage tube, and in the vicinity of tube we can puncture with the 19G needle, and then we can manipulate the guide wire. We can use the soft tip guide wire, and this guide wire will come out from the PCD site, and again over the wire we can place one or two stents. So either one scope or two scope technique can be used for treatment of external pancreatic fistula. Another complication of DPDS is the pseudocyst or walled-off pancreatic necrosis. So mostly we place a stent for a transient period for 4 to 6 weeks. So this excellent study from the AIG, it has shown that in patient with acute pancreatitis, there is high risk of DPDS. So we can see in patient with acute pancreatitis, 73% of patients, they have DPDS, and after the removal of endoscopic stent, there is high risk of again development of pseudocyst. Around 15% of patients with the DPDS, they will develop pseudocyst. So other option is when we are removing the metal stent, so initially we place a metal stent for drainage of walled-off necrosis. Then if we can keep a plastic stent inside the cavity for the long period, the rate of pseudocyst formation can be reduced to around 10%. Another complication of the DPDS is the dilatation of duct in the pancreatic tail region, leading to obstructive pancreatitis. So with the endoscopic ultrasound, we can puncture this duct and place a stent between the gastric lumen and the pancreatic duct. This is called the pancreaticogastroscopy. This can lead to relief of pain in these patients. So to summarize, DPDS is complete disruption of main pancreatic duct with the viable upstream parenchyma in the body and tail region. It increases the morbidity of acute pancreatitis. The manifestation can be external pancreatic fistula, walled-off necrosis, recurrent fluid collection after removal of the stent, and stricture in the pancreatic tail region. Surgery has been the mainstay of treatment for a long time, and the patient who had a lesser output fistula, they can be treated with the conservative approach with the wait and watch policy. The patient who have a persistent fistula or the output is more than 200 ml per day, they can be treated with the US guided innovative procedure, and it can reduce the morbidity. Thank you very much for your patient hearing.
Thanks a lot, sir. Really, it is a wonderful and a marvelous presentation. Now the topic is open for a discussion. I have few queries to you, sir. So my concern is why neck region is commonly affected. Whether the duct is it is narrower in that region or more prone for injury. And another thing is that when should we suspect? Is it usually 3 weeks after any acute event or following or before that? And can it be cured of as of its own without any intervention?
Can this be cured for?
Sir, can it be cured spontaneously if there is?
Yes. So first question first, why it occur in the setting of neck? So necrosis can occur anywhere. It can be in the head, body and tail. The patient who had necrosis confined to the neck region, they will have a viable parenchyma in the body and tail region. So they will have a manifestation of DPDS. So if there is a necrosis of body and tail also, so there is no viable parenchyma upstream. So this is not, there will be no issue of fluid collections. So necrosis can occur anywhere, but necrosis confined to the head or the neck region will lead to more chances of DPDS. Then coming to second question, when we are worried about the DPDS. So we are worried either there is a walled-off necrosis or there is a external pancreatic fistula. So when there is a world of necrosis, you have treated it with the endoscopic approach, then you are worried about the recurrence of the recurrence of the pseudocyst. So most of the center, we remove metal stent at 4 weeks and we do the MRCP. If MRCP reveals it's a DPDS, then you can change metal with the plastic stent. But the issue is that when you remove metal stent, there is hardly any space left to hang your stent inside, but still it's worth trying. And sometimes we place plastic stent. If the necrosis is only 10%, 20%, we also place plastic stents. So if MRCP showing it's a DPDS, we can leave plastic stent for a longer duration to reduce the chance of pseudocyst formation. And third question is regarding the spontaneous healing.
Spontaneous rejuvenation.
So if the that question arises in the setting of EPF, when there is external pancreatic fistula. So if the output is less than 200 ml per day, it means there is a small amount of parenchyma which is left in the tail region. So sometimes there is spontaneous necrosis of the tail parenchyma also, so that ceases to secrete any more fluid, and the condition may heal by itself. Or sometimes there is a stricture formation in the pancreatic tail region. So when there is stricture formation, the fluid may not come inside the retroperitoneum and the condition may improve itself. But after stricture formation, there can be another issue of pain. Patient may complain of pain in the left side. There you will require either surgical pancreaticojejunostomy or the EUS guided pancreaticogastroscopy.
Sir, I have a question. So a person with acute necrotizing pancreatitis, week 4, symptomatic walled up necrotic collection on prior to the drainage, we are doing an MRCP and we found that there is a large collection which needs to be drained and there is a total duct disruption. So sir, in that case, what you prefer is just you do the LAMS placement drainage of the walled up necroticals, or you want to do a pancreatic sphincterotomy or something like that? So is it pancreatic sphincterotomy or putting a stent, is it helpful or?
So when you have world of necrosis which require drainage because of sepsis, the first priority should be saving life of the patient. So if you are doing pancreatic ERCP in the setting of acute pancreatitis, there is high risk of worsening of underlying pancreatitis. In my opinion, ERCP for the pancreatic endotherapy should be avoided in acute pancreatitis. Biliary ERCP can be done, but that has a different indication of cholangitis or CBD stone. ERCP is a risky procedure in a setting of acute pancreatitis. Now coming to the question of WOPN, so if you have done the MRCP and you think it can be a DPDS, and even on CT also you can diagnose it. When your fluid collection is replacing the pancreatic parenchyma, it's likely to be DPDS. And we can see that in the AIG study, around 80% of patients with the necrotizing pancreatitis with WOPN, they will have DPDS. Now you have two questions. WOPN, you want to improve sepsis, and second question is, if DPDS which is there, you want to prevent future complications. So here what you can do, so if there is high amount of necrosis, you have to place metal stent. If only necrosis is only 10%, you can place plastic stent and leave it for a longer time. But yes, if you are planning for the necrosectomy, necrosis is more than 30%, so you can do the dual drainage. First you place a plastic stent at one side, and other side you place a metal stent. So to the metal stent, you can remove the solid tissue. After 4 weeks, remove the metal stent and leave the plastic stent in situ. That will take care of future chances of development of pseudocyst or the fistula.
Okay. Thank you, sir.
Sir.
Thank you, sir. If there is no question, then, sir. Yes, sir. Yes, sir.
You see, if you have a viable tissue,
sir,
which is normal, with a pancreatic duct, with a fistula,
sir,
or with a collection. So there is no fistula or a collection, or you have a fistula.
Sir.
So once you drain it, then you have said that it should be there for a longer time.
Sir.
So these plastic stents are basically you want to internalize the external
Yes,
fistula to internal, and ultimately
Yes,
those
sir.
stents are there. But how long?
Sir,
if there is a viable tissue and there is no another pancreatitis in that part, so that is going to drain forever? Or?
Yes, sir. So it can be left for the indefinite period. The data up to 5 years also, that you can leave the stent in situ for even 5-6 years also.
You have to monitor in some way when it gets clogged or...
No, sir. The patient has symptom of pain. If the patient is coming back with a symptom of pain, then we need to investigate whether there is a stricture formation or the recurrent. Sometimes the stent may migrate actually. So the stent migrates, then there can be another pseudocyst. So maybe you can do ultrasound every 6 months in the follow-up to look
You
for
have to
any.
follow with the history of pain.
Yes, sir.
Collections. So if
Yes.
it is there, then again you have to.
Yeah, re-intervention will be required, sir.
Otherwise, you can keep it for years together.
Yes, sir. Definitely.
Hello, Vikas sir.
No, we can hear you.
The question is that the external fistula, less than 200 output, roll of octreotide, is it healthy or not healthy?
So in the conservative approach, ideally they should be nil by mouth, then you give octride and the total parenteral nutrition. But I don't think any center follows that. We just send the patient home, start on the oral diet and keep him on the wait and watch technique.
Okay.
So no need of giving octride.
Even if you have put it in external fistula, percutaneous fistula, you have put plastic stent either by 2 scope or a single scope.
Yes, yes.
How many days you will wait? Till
How many?
How many days or month or weeks will need for the healing of the fistula?
No, it heals within 24 hours. So once you place the stent between the sinus tract and the gastric lumen, you can close the external site. It will be healed within few hours only. The fluid will be routed through the intragastric route.
When you will remove the stent?
No, you don't remove the stent.
You have to
It
keep
has to be kept for a... So what you do, you keep on doing the repeated MRCP, maybe annual MRCP. So if there is a necrosis of the tail, there is no parenchyma left in the tail region, then you can remove it.
Okay.
But otherwise you can keep it for the indefinite period.
Okay, thank you, sir.
Thank you.
Thank you, sir.
Thank you.
Next, we will invite Dr. Sanjay Rajput to talk on advances in the management of biliary injuries and transection.
Good afternoon, everybody. I am thankful to Dr. Mahapatra and Sunmun for giving me this opportunity. Today's topic is bile duct injury. Now what? So every surgeon has once in a lifetime opportunity to face this, because bile duct injuries are not decreasing. I am very thankful to Dr. Mahapatra, and I had a pitha, the Odisha delicacy in the morning with Mahapatra sir and Dr. Norio. And as we know that bile duct injuries are why not decreasing? Because there are learning curve in laparoscopy still going on in the center of municipal hospitals or the training centers. So people start learning in their early days and they are going to make the injuries unless they are supervised by the senior person. And now we are getting more and more colleges, but less and less teachers in the colleges. So people used to have honoraryship in that, and they don't want to work that which our teachers were working. So they are not decreasing still. So it is the most serious complication for a surgeon to have a bile duct injury, and it is not decreasing. They can present as leak or biliary obstruction or as a combination of both. Now, successful treatment depends on the multidisciplinary team of biliary endoscopists, interventional radiologists, and the hepatobiliary surgeon. The incidence is higher in laparoscopy versus open, and mechanism is mainly failure to recognize the anatomy or inexperience in treating difficult cholecystectomies and trying to do much more than what you know, trying to do heroics while there is a complication. Try to stop the bleeding when you don't know how to bleeding, or you are not finding the cause, and still you are trying to not to get the help of your seniors while you are in trouble. So these are the most common scenario why the bile duct injury occurs. And there is lack of experience to manage them intraoperatively, and there are you don't know the options of management. Do it yourself, but you do not call your senior surgeons before help. This is how they present Strasbourg classification. As you know, A to D, A and D are the most easiest way to how we manage is the just put a stent and they will heal by themselves. Other require special attention like E1 to E3 are the E5 are the most complicated ones, where you require lot of attention and lot of expertise, and most of the surgeons still don't want to do the surgery immediately because whenever they have a problem, they around 25% of them they find out immediately that they have the bile duct injury. So during that they have to be calm. There is a 1 minute rule that you have to take a deep breath, assess the complexity, assess your experience, whether you are going to, you are able to do this complex surgery by yourself or call for help. Most of them, they know that they have injured the bile duct. Some of them, they try to repair. Must be done by an experienced surgeon only, and success of the bile duct repair only depends on the experience of the surgeon and the number of attempts to repair the surgery also, and timing of repair. Sometimes it is better to do intraoperatively, and sometimes it is better to wait, keep calm, put the drain, come out and send it to the center where it is available, more experienced surgeon. So around 73% of surgeons, they identify the bile duct injury in the OR only. But only 20% of them, they take the help of senior surgeons. So that is why the injury chances and the later on the complication occur more commonly. So common therapeutic options, we know that endoscopic treatment is the still best, and in complex biliary fistula, we may put covered metal stents. Balloon dilatation with placement of multiple plastic stent is the Costa Magna protocol. Usually we follow in all types of bile duct injury, and it should be exchanged every 3 months till the resolution of the stricture itself. This is how we can put multiple stents, and we have put around 10 stents in one patient till the resolution of the stricture. Fully covered metal stent is another option if you want to avoid the multiple stenting protocol, but it comes with the cost of the metal stent, and you have to remove it after around 8 to 12 months, and then still there are 20% chances of recurrence of the stricture. We have recently published an article of magnetic compression anastomosis of post-cholecystectomy benign biliary stricture using modified accessories. This patient was presented to us with bile duct injury with complete cutoff, where PTBD was tried and they could not pass a guide wire through the PTBD into the bile duct, and from lower down they could not pass the stricture. So we have given her the option of magnetic compression anastomosis. This is the magnet which we made, and the most important thing is how you push the magnet into the bile duct. It is the most difficult part. So we made a special pusher tube for this, where we can place the magnet inside the pusher tube, and by that, after loading this magnet, we can push this magnet into the common bile duct from the lower down. This is how it goes into the lower bile duct. Once this magnet has gone into the bile duct deep enough up to the stricture, you pass another magnet from the PTBD side. And these magnets are very powerful magnet. As you can see, they can attach up to 2 centimeters. These are the magnets which are available. So they attach to itself they are very strong magnets. You cannot take them out easily. So they have very powerful source. So then both of them, they attract each other and they form a new lumen. After 2 weeks, we pushed out the magnet from PTBD side because we did not have the catheter to remove it. Now we have made another catheter to remove the magnet from the bile duct also. And you can see the newly formed bile duct. As we know that the liver has a tremendous capability of healing by itself. So these magnets also help. They have a healing property by themselves also. So liver and magnet, they together, they heal the injury, and this patient can be saved of their surgical. This was another case where post liver transplant, they had a complete cut off and they tried to put a PTBD guided wire, but they could not, and from the lower down also they could not. So here we again put a magnet from the liver side with the help of PTBD. And because there was a altered anatomy, we have to place a metal stand lower down to pass this magnet inside. Sometimes you have to do that because you have altered. And then after 1 week, these magnets were opposed, and now this patient is having on multiple stenting protocol with us. Another case, right aberrant duct injury, is another injury which we have to be very careful in monitoring, because these patients, they present with bile duct leak. On ERCP, you will find out a cystic duct leak. And you put a plastic stent, they don't heal. You put a metal stent, they don't heal. Then you should always suspect that there is something else. So this right duct injury is very commonly missed. So again, this patient developed the bilioma, which was drained with the help of catheter. And on next MRCP, you could find out there is a right aberrant duct injury. Here also, you can, through the PTBD catheter, you pass a magnet into the duct, and from below you pass a metal stent. Over the metal stent, you pass a magnet there, and you can see both the magnets are attracting each other. Once they attract each other, you can leave there, and after 2 to 3 weeks, these magnets are attached to each other. 6 weeks later, they were removed. And now you can see one wire is in the hepatic duct. The second wire magnet, after removing the magnet, the second wire could easily pass into the lower CBD. And you have a track, truly from track, where a metal stent was placed, and post metal placement, there is plastic stent in the left duct and a metal stent in the right duct to prevent the cholangitis. And after, when they removed this for after 3 months, you can see the completely normal right hepatic duct connection to the area. Again, if you don't have a IR facility and you are very good in EUS, you can place a metal stent in the left hepatic duct. This was a case of complete cutoff where the EUS guided left hepaticogastroscopy was done, and through that they have passed a metal magnet into the hepatic duct. Through the left hepatic duct, they have passed it, and then, because it is very difficult to pass the magnet through the hepatic duct, and then from below they could pass a magnet there, and both of them, they have attracted each other. They have formed a lumen there. Then fully covered metal stent was placed to make the continuity of the lumen for long period. And once this metal stent was removed, you can see the completely normal hepatic ducts. If you do not have the access, you can do PTBD guided, passing a guide wire up to the hepatic duct where you can reach, and from below you pass another guide wire. You try to push both and try to attract each other. But here, if you do not have access to these magnets, you can directly puncture with the help of 2 scopes. You pass a scope from the PTBD side, and you can see the light from the below with the another scope. Then you inject the methylene blue from above, just to confirm when you are puncturing from below, direct puncturing. See, here they are directly puncturing the bile duct. From below, under the illumination guide, here you can push a guide wire inside. After they put a needle, you can directly see the methylene blue coming out. So, methylene blue is coming out through the catheter, and here you can then normally dilate, pass a guide wire, normally dilate the stricture, and put a metal stent, fully covered metal stent through this, and treat this patient as a stricture. This is through the cystic duct. As I told you that liver has a tremendous capacity of healing. Here, if you don't have the duct, you can pass the guide wire through the cystic duct into the right. This is segment 6 duct was injured, and there was a stricture in the segment 6. So they have passed the guide wire through the cystic duct, and with the PTBT guided, they have taken out the guide wire through the cystic duct into the segment 6 duct, and over that you can pass a fully covered metal stent which heals by itself, and after 6 to 8 weeks you remove this metal stent and you can see the cholangioscopy picture of completely healed and newly formed cysto-hepatico communication. So you can go through the cystic duct into the hepatic ducts, and this is newly formed connection. So this is another option which we can have, and you can see the fibrosis later on through the cholangioscope. Now future is what? Magnetic spiral stent. You can pass a EUS guided coil which has a magnetic power. If you have pathology in the bile duct or common bile duct, this is the future where you can pass a coil into the gallbladder and another coil, magnetic coil outside the gallbladder, and they will, within a week, they will have necrosis in the middle, and this can form a new track between the gallbladder and the duodenum, and you can have the therapeutic options available with you. So review whenever a patient of bile duct injury. Another method is cholangioscopy guided rendezvous techniques which people are using. That is also an option with putting a metal stent later. So review an MRCP which is coming from outside. Never believe. If it is required, you can do another MRCP. Reduce the cost of your therapy in your charges and do another MRCP, good MRCP, because otherwise you will regret why you are doing this ERCP, and you may find something what is not there on first MRCP. Durable and less morbid long-term option is magnetic compression anastomosis. Bile duct injury is not uncommon during cholecystectomy. Experience is required to repair, intraoperative detection and repair. Do not repair if you have a less experience. Call for help or refer to an experienced surgeon. Magnetic compression anastomosis is safe and feasible in transected bile duct. Follow-up requires after removal of stent for recurrence of stricture, which is around 10 to 15%. And endoscopic intervention can be done with long-lasting results and less morbidity. You require a good interventional radiologist, endoscopist, and always keep a surgeon with you. Very recently, 3 days back only, we did one colonic anastomosis with the magnets. So we have a horizon of new stricture therapy with the use of magnets in multiple strictures. So this is how we did a Hirschsprung case, post-Hirschsprung stricture, surgery stricture. We pass a magnet from the colostomy side into the stricture, up to the stricture, and from below we put another 15 millimeter magnet, and this is anastomosed. So this is another modality of colonic stricture management by magnetic compression anastomosis. We can use lot of other areas where we can use these magnets. So thank you very much. Jai Jagannath.
Jai Jagannath. Thanks a lot, sir, for a wonderful presentation. This metallic, this magnet placement is, this is very upcoming, and really it is worth praising. Sir, my concern is, sir, whenever the lower distal biliary you're putting the fully covered, but in the right and left US guided, you are going to put it uncovered.
No, it is always fully covered.
It is fully covered.
Yeah, it is. You have to remove it later.
Then drainage, the drainage part will be.
You put another stent in the left duct or right duct through that. Okay. You can put another stent through the same catheter, same stent, to drain the right duct.
Sir, is there any experience regarding putting up the fully covered the metallic stent with versus multiple plastic stent?
If patient is not affording, you have to put multiple. We have put 6 stents in one patient. He is following up now, 1 year follow-up. 6 stents, plastic stents.
So prognosis is better with metallic?
It depends on, both are same. They have around 20% recurrence, most of them. So you have to follow them up chronically. But they have been saved of their moribund surgery because there are a lot of adhesion post-surgery. So So surgeon also don't want to go inside. And there are non-dilated ducts, so they may not be able to do this.
Yeah, excellent, Sanjay. Is there a possibility that the magnets get impacted after making the fistula? Because it's always, it's not possible to follow.
Usually follow them about every 3 days for first week and then every week. Till the time either they pass themselves or after 6 weeks we remove by ourselves.
How
we
you
remove it
remove
after
them?
6 weeks.
How
We
you
have a
remove?
catheter, sir. We have a catheter now made to remove from the bile duct. Or you can push it from there is a PTBD catheter already with the patient. Always we put a PTBD catheter. So from there you can push it downwards, but now we have a catheter. So we put another magnet down and then that will take the...
So that means you actually attract the magnet with the other magnet at the end and then you remove. That's a good idea.
Hello, it's a very good technique, but my question is little controversial. You will do PTBD, you will spend money. You will attempt ERCP, you will give 2 magnet. What is the cost of the magnet? I don't know.
No cost.
No cost.
It's very cheap.
Then
sir.
you will wait for few weeks.
Yeah.
Then you have to canal by giving a guide wire by PTBD track, put a metal stand, remove the metal stand. How much it will take? You just imagine and tell
Sir,
me.
we have cleared from our side that we will not charge this patient for lifetime.
No, this is not practical to everywhere. No?
No, we will give this magnet to everybody free of charge.
No, okay, I understood.
Yeah, so
for procedure, single man, minimum 4 to 6 weeks. How much money, other things will have?
sir, this should be done, I think, free of charge to all the patients.
No, this is from your side, your government is giving.
Yeah.
Even Odisha government can give, but there is a multi-faceted ways it is stopped. But it is not practicable always.
It is
Why will
always
not go to
practical, sir.
surgery?
Anyways, this patient will go for surgery which will cost him lakhs. So this is not in lakhs also. Any surgery for this patient will have another chances.
Another point.
Yeah.
What should be the distance between 2 strictures?
It should be less than 2 centimeters.
2
But our one patient has 2.5 centimeter more, and these magnets have attracted each other in 2.5 centimeter also. So we are going to publish that also.
That distance will calculate by
Less
which
than,
way?
yeah, it is MRI people, they will give you the
They will
distance.
give you.
Yeah, they will give you the distance.
No, why? This discussion on what basis? Magnetic field basis or the electromagnetic field basis?
You have to take it outside. These magnets, yeah.
Distance is less than 2 cm.
Yeah.
How it to decide by which mechanism? Physics or something else?
I don't understand
No,
the question.
this distance is less
Yeah.
than 2 cm.
If you
It will respond?
If you measure by MRI, they will
No, I
give you-
understood.
Yeah,
2
so
cm
if it is less than 2 centimeter, their results are 93%.
If it more than 2, it's less.
Yeah, more than 2 centimeter, less than 20% chance that they will attract. Less than 20%.
No, why this is happening?
Because the magnetism, they do not attract more than 2.5 centimeter. They do not attract itself.
Okay, okay.
So it depends on the strength of the magnet as well as the distance.
Sir, I have 2 questions. One regarding the metal spiral you told us about. That's similar to EUS GB drainage with lamps. Any advantages of the technique you mentioned?
It's not come yet. It is just under pipeline. So it may be cheaper than this. It may be more physiological than the metal stand. And it may have a longer lasting effect when you remove them, because it is a natural process. Natural process by healing by itself, they don't have the another chances of getting again blocked. So if you put a metal in this metal also, there are chances of recurrence are less than 20%. So this magnet, they have a healing property. They heal by fibrosis, but that fibrosis is not as much as the normal fibrosis during the stricture.
And sir, another question. How do you decide on placing more than 4 stents? Like the Costa Magna regimen, usually we place 4 stents, and at subsequent ERCPs, we don't perform a cholangiogram to see the structure.
Every time you have to remove the stents, old stents, and do the cholangiogram. If it is not resolved, then put more. After 4 you put 6. After 6 you can put 8.
Thank you.
Thank you very much.
Thanks a lot, sir, for wonderful presentation. Now we are switching over to live presentation. Live presentation mode, please.
Sharma. So over to room number 3.
So in this case, my job was to first go into stomach and see what I find in front of aorta. Once I found this aorta, I found a mass right in front of aorta, and this is body. And then I found that behind this mass there is this vessel, and when I applied flow, I found that this is a vessel, splenic vein, but I will just see. So if I from this position, I rotate my hand clockwise, I will go to the tail of the pancreas, and I will, if I rotate my hand anti-clockwise, I will go towards the head of pancreas. Just to clarify, in this case, beyond the mass, you are able to see in this particular position the superior mesenteric artery also, and if I apply color, sometimes you may not be able to see the color of the superior mesenteric arteries because of the distance from the tumor, and in this case, you should apply pulse to confirm. So this is a mass which has got some vessel possibly coming on it from the anterior surface, which has got a splenic vein on its posterior surface, and this mass is anterior to aorta and superior mesenteric artery, as well as on the top part of this mass, I am finding this is the splenic artery, this is the splenic artery, that, so this is what we are, so this is the mass, splenic. Now let us see what happens.
One second, I will confirm that they can. Just want to confirm that you can hear Dr. Sharma in the hall.
So can you
Yes,
hear
we
me?
can hear.
Okay.
Okay, thank you.
So we are seeing the splenic artery, we are seeing the splenic vein, we are seeing some vascularity, possibly within the tumor. We will find now power, because that is more sensitive to detect flow, and there is flow within the mass. So this is a vascular mass. Okay? So now we'll remove flow, and now see what happens when I rotate this. Once I rotate this, the splenic vein, this I said, I showed you that this is the splenic artery and this is the splenic vein. Once I rotated this splenic vein joins with the superior mesenteric vein coming here and form the portal vein. Now this is a very important confluence which I sometimes call as the butterfly sign, because all these veins are confluencing, and this particular place demarcates or identifies this particular border of the left border of the superior mesenteric vein, and left border of portal vein identifies the junction of body and head of pancreas anatomically. So, but there is a couple of more interesting things which are happening here. Once I rotate it, if you can appreciate, we have pointed out that this is not just a union of 3 points. Sometimes the left gastric vein and the inferior mesenteric vein also joins it. Why I am trying to show that the inferior mesenteric vein is separate? Because if the surgeon is going to do a surgery, then identification of inferior mesenteric vein becomes important, and this is the union of 5 vessels. It is the confluence, and this portal vein confluence is confluence of IMV, splenic vein, portal vein, and at this particular place there is left gastric vein, and at this particular place there is inferior mesenteric vein. So now I remove this, clear the characters, clear the characters, clear. So this is. Not only that, I want to emphasize on this, that this particular tumor is also below the tuber omental. This, as I have pointed out, is the highest point of pancreas within the body, and this tuber omental is identified once you see the splenic artery looping up and joining with the hepatic artery to form the celiac artery. So we have a tumor in body of pancreas extending from about the whole of the head and body junction, but not involving any of the veins, and splenic artery is touching on the upper border of the tumor. The splenic artery is probably supplying this mass, and this mass is supplied by the splenic artery at it. So this is what we have identified so far. Now we will come to find out whether this mass has got any ductal displacement or not. Because where has the rest of the pancreas gone? So as I rotate it clockwise, find out that this part of mass in this particular portion is sort of becoming a bilobar. It is bilobar, and then it disappears. So I start thinking whether this mass is really extending in some peculiar manner, because why should this mass become dipped like this and then become like this? So this is the second lobe of the mass. So this does not look like one of the differential diagnoses could have been so SPM, solitary neoplasm. But anyway, now we rotate it further and we try to identify the tail of the pancreas. And you see this mass is coming anterior to the adrenal gland. And within this mass, this may be the pancreatic duct. We apply color. Yes, this is indeed the pancreatic duct. So this mass in the pancreas, if we can show the figure, is below the pancreatic duct, starting from below the pancreatic duct. Possibly it is mass is extending outside, because this is the initial margin of this mass. You see, here this is the normal pancreas. What is the body and tail junction? The body and tail junction is an arbitrary criteria identified when you see that the adrenal gland has appeared and the kidney upper pole is disappearing on floor and the pancreas is falling away from you. Pro-criteria. Pancreas is falling away from you. Rotation, upper pole of kidney has appeared, adrenal has disappeared. So this is. So I am finding this normal pancreas in this distance, and this normal pancreas in the lower part of this pancreas below the pancreatic duct. See? So maybe, see this pancreatic duct, now you can see it is coursing here. It is coursing above, we'll increase the depth. This pancreatic duct is coursing above, and this is going anterior to the duct, anterior to. So this is, at this place, the pancreatic duct is sort of visible, and there is possibly a dilatation of pancreatic duct. So this mass, which is arising from the body of lower part of pancreas below the pancreatic duct, is displacing the superior mesenteric vein upward, because you can see this is the compression of superior mesenteric vein. I cannot comment, but this is too smooth for me, and this is displacing the pancreatic duct. This is the information I have. Now, see, this is the rim of pancreas. So this is the rim of pancreas that I am seeing, and if I were to enlarge this further, this and increase the frequency also. Frequency, how will you? Increase the frequency to higher. I can try to show that right now in this picture, this is the pancreas above, this is the outline, and this pancreas is compressed. So now I will rotate it and follow this pancreas in the hope that within this pancreas, I can find the reappearance of the pancreatic duct, and this I could not find. So I will now go decrease the depth and see this tumor again from the duodenal bulb and identify it. So for example, for going to the duodenal bulb, I am particular, I go in, rotate, move in, rotate, push, and then go inside and just move it down. So this mass we have to now assess from the duodenal bulb also. The duodenal bulb, I have already said that we want to rotate clockwise to see the lower end of pancreas, and we want to rotate anti-clockwise. So right now, as I have already shown you, that in this picture, there is union of the superior mesenteric vein with the splenic vein, and the other veins will be also seen here, but that is not what we are interested. As I rotate clockwise, we will go towards head. As I rotate anti-clockwise, and you can see here that this mass is seen on the far side of the screen, just beyond. So now my question is, can I trace the pancreatic duct from here? It appears that this is the pancreatic duct. So I will again apply color to confirm that this is indeed the pancreatic duct. Remove color and then try and trace this part of pancreatic duct. This part of pancreatic duct from head towards the body. So this is the border and this is the head, and then as I rotate here, head towards the body. I rotate clockwise, I can see, and this is the, so this mass, I am unable to till now identify the pancreatic duct very clearly, but I am trying. So I am not going to make too much effort about it, because if I cannot, because in this case I will push in, and you can see right now nicely the pancreas going on. Can we increase the frequency now highest? And it may be increasing the increase in frequency is associated with decrease in the visibility. So decrease the frequency once more, because I am not able to see the decreased frequency. So this is the mass. Okay. So we have not now identified this mass. Now we'll come back into stomach, characterize it, and take a piece, and take opinion of how, whether we should go ahead and now take a piece of this mass. Few more things which are left are, if I want to establish the supply of this vessel, whether the superior mesenteric artery that was here is giving an additional supply to this mass or not, because I have applied that splenic artery is giving supply to this mass, and this is it. Okay, now.
First I want to say that's a master class in how you assess and look at the tumor and look at all the vascular supply, because the tendency is to jump to see the mass and put a needle in.
Yeah.
So I think for anybody listening who does EUS, that's a master class and taking the time to analyze. So I did have a question for you. When you look at this, when you look at the vascular supply of the mass, when you look at the lobulated nature of the mass that you showed very nicely, what do you think that the differential would be as people are looking at this and as you go to put a needle into this?
I have already my needle in place, because I believe the surgeon who has sent it must be as itching to know what is the histological diagnosis. The first thing is, before pushing in the needle, I would like to get an extent of the mass. And this is a young lady measure. If I have to measure it from this place, it is a fairly large mass enter, and this mass is approximately about 5.5 centimeter. So in this young lady, again, this of course solitary neoplasm is a tumor, SPN is a possibility. So what goes against SPN is not
cystic. There's nothing cystic or heterogeneous.
Nothing cystic.
So a neuroendocrine tumor also comes to mind.
Again, neuroendocrine tumor comes to the mind. So instead of debating what it is, I think in this case, a biopsy is what. Now in the biopsy, I have to tell few suggestions to proceed. See, one of the things that happen when people do biopsies, that they are not able to see the needle very well. So there are 6 or 7 tricks of increasing the needle visualization. Number one is decrease the gain, increase the frequency to highest. Now I will increase the frequency to highest, because I am not interested in visibility, I am interested in highest visibility of the tumor distance. Second thing, I will decrease the grain in just a little bit. Third thing I will do is, if this machine has compound imaging, I will stop the compound imaging from functioning, because compound imaging will not produce such a needle artifact. Then I will distribute, in this case, is there a dynamic range? This machine has a dynamic range? DR? No. Dynamic range must be, No, there is nothing called inbuilt. Now I'm sorry, those people who cannot play with the knobs, knobology, and then they say it is inbuilt. There is nothing inbuilt. The dynamic range can be changed, must be changed and reduced to minimum. What is dynamic range? See, because you are seeing on the side screen that this is most white and this is most black. I just want to see white and black. I don't want to see anything range. So though I don't know where it is written, so there will be things somewhere. So we have increased frequency and we have increased the line density to maximum. No, this is not depth. And then I will increase the depth to maximum depth that I see. So now is the time that I am seeing full depth. I am not interested now in quality of image. I am interested only in the visualization of needle. So I will take the needle out and then apply it, fix it. I will confirm the needle by 3 ways. One by movement of elevator up and down. Second is by endoscopy visualization. And third is
we have
by
some,
EVS visualization.
We have some doubt
that
or
the
question.
needle
Hello.
appeared here.
Yes, sir. There's a question from the audience.
Whether you will use elastography before the biopsy. Second question is that there are two lesions,
yes,
two type of echo pattern. Like in the down there is a hypo and above that is a hyperechoic. So from where you will target that?
So
where
So
you
the
will target
first
the
question
biopsy?
is, will you use elastography? I think this machine does not have elastography. Oh, it has?
Elastography, we'll use elastography. And then, see, this has got a variable echogenicity, and the elastography, the principle is that we should have some sort of a normal tissue here. So this machine, we'll try to compare it with this part of pancreas. So if we try to compare it with this part of pancreas, this is the normal pancreas on the side, and this is this part. I don't find any broad difference. So that is. Characterization of this mass broadly tells that this is not a malignant mass. That broadly, this is not a entirely adenocarcinomatous mass.
Yeah, the other question I think was a very interesting question, is that the posterior aspect of it, you see a more hypoechoic aspect. So the question was, but it's a large mass for your needle to reach there. So that
No,
could
it
show,
will be.
I think the question from the audience was, what's your biopsy strategy? Are you going to go deep here, or are you going to restrict yourself to the...
Okay, now that is an interesting question. So one of the things that I would say, can somebody hold it? Okay, one of the things that I would like is, you see, you should actually, if this is a smaller issue, you should actually go to the edges. Because central part, so I will go all the way to the deep. Now I am going to go, so now I have done something, whatever I have done, I increased line density, and that has not compromised most maximum line. I am not interested in quality of image. And then I will rotate and go as deep as possible. So what is the problem? Now once you see here, now I will have to explain that there are 3 types of artifacts. 3 types of artifacts. That right now in this needle, there are 3 types of artifacts. Remove one of the needles, the first part of artifact is very close to this part, and this part of needle is reverberating artifact. And remove. Second part is this part of the needle is remove it. This part of the needle is grating lobe artifact, and this part of the middle needle is sort of invisible, and this is displaced artifact. So now I will explain this later if somebody wants. Why? Because you must, sometimes what happens, that if you push it only this much, then sometimes what happens, people are saying that this needle is, and second thing is, when you are pushing it deep in, it goes into several fingers. You can see, appreciate several fingers, the grating lobe artifact. And you don't know which one is the real needle. The most proximal is the real needle. But it needs, it's divided. So you can see the reverberating artifact will not move at all. They will stay in the same place. And the grating lobe artifact is moving in and out. So, and the displacement artifact has displaced the needle. So why is displacement artifact is there? Why is displacement artifact is there at all? Because the sound waves are traveling to the tip of the needle and then coming back. See, right now you can see the grating lobe artifact is very well seen. So the person who is doing endosono must be accomplished in understanding the type of artifact so that he can understand while he is doing ultrasound as to what is happening and I have tried to increase these artifacts so that I can follow the movement of these artifacts. So we will do just section once because maybe suction. So now the panning, if this is a big mass, so panning is no thing. What is panning? You bring it up, then move either elevator up or up, now up, and then change the direction. You bring it up, elevator up, change up. So if we can show the figure, we have identified where exactly in this mass.
Listen, that was fantastic. They want to move to room 1 to demonstrate as we process the sample. So
I think we are done.
Yeah, please.
Unless they have any more question,
Any last minute questions from the audience?
So, would you like to use that contrast
formally,
enhance?
formally.
Because there are, if the uniformly, if it is one lesion.
So we will be shifting to. So we will be shifting to room number 1. Dr. Noria is waiting there. So we have a 43-year female with no comorbidities. She came to us with efficacious pain of scheme and duration. She had no family history of GI malignancy. On endoscopy, there was a deep spleen-based ulcer at the incisura along the anterior wall with mild to moderate C2 atrophy along the left curvature. So the plan is image-enhanced endoscopy by Dr. Noria Uedo. So over to room number 1. Thank you.
Okay. Hello everyone, welcome back. We are already inside the scope into the stomach and then wash some mucus. So previously I already explained a little bit, so I quickly observe, evaluate the background mucosa. So this patient also already mucosal fold, but almost gone, especially the great lesser curvature side. And if the patient is no H. pylori atrophic gastritis, mucosa should be very smooth, but little bit bumpy, irregular. So this means this is also a characteristic finding of H. pylori associated atrophic gastritis, because H. pylori associated gastritis usually develops multifocal. So maybe you can see some whitish depressed area, which is a little bit enhanced by NDI. So such kind of some patchy appearance of atrophy is characteristic finding of H. pylori associated gastritis. But anyway, so I think patient has atrophic gastritis caused by H. pylori infection. So now you can already greater curve, anterior wall, and lesser curve, and posterior wall. But now you can aware that some depressed, irregular shape, depressed area exists in the anterior wall of incisura. I think this is a pointed out lesion. I think this is very suspicious, very solitary. Previous patient has a multiple elevated lesion with small erosion, but this is very solitary. And also previous lesion, distribution is really symmetric, multiply, but this is very solitary and then asymmetric. So I think this is very, only white light image, it indicates very suspicious lesion for neoplasia, early gastric cancer. And also, if we look at the shape and the color distribution, when we just put the cross to the lesion and then divide it into the 4-quadrant portion, I think each portion has a different distribution of color and a different shape. So very heterogeneous, so very suspicious for neoplasia, early gastric cancer.
So, Professor Vito, on
Yes.
a white light examination,
Yes.
when you are not using magnification,
Yes.
so how should you, what are the features which would tell you that this is something very suspicious? Pale appearance or?
So as I mentioned that Astos also mentioned that localized, demarcated, localized irregularity of the color of or surface, that is a suspicious finding. So slightly elevated, peripheral elevation, and then whitish pale color depression. And then inside some granular reddish part is available. Right? So even white light we can detect obviously, and then we can make diagnosis. This is very suspicious lesion as a early gastric cancer. And then when we forward the scope to pylorus, you also see some localized lesion as well. But this lesion, compared to this lesion, demarcation is not so obvious. For example, like this lesion, whitish color has a demarcation from the surrounding mucosa. But this lesion, it looks a little bit demarcated, but when we get closer, some whitish color is gradually changed from the surrounding mucosa. And when we switch to NBI, we can evaluate the mucosal pattern. But from surrounding mucosa to the lesion, mucosal pattern is gradually changed, somewhat connected. In some central part, we can see slightly irregular vessel, but still demarcation is not so much clear. So such kind of no demarcation line and just irregular vessel can be caused by inflammation or scarring. So I think this is not suspicious for neoplasia.
So for early gastric cancer, you should have all three: demarcation, irregular vessels, and irregular surface? Or
Not all three. Demarcation plus irregular vessel or irregular surface pattern. So two criteria.
So demarcation is a must?
Must, yes. And demarcation line usually has a higher sensitivity compared to irregular vessels. So initially we screen the area with demarcation first. And then we look into the inside the demarcation line and whether there is an irregular vessel or irregular macular surface pattern. That is a strategy to how to detect or how to evaluate, characterize the lesion. So D2 and then observe circular. Okay. Okay. So now this is the lesion. So I show some benign depression with near the pylorus. So I just want to see. So from the surrounding mucosa, we get close to the lesion. Here. Now you can see irregular vessels. This is a little bit difficult. Demarcation line is not so clear, but I think this vessel is quite irregular. Usually, inflammation, coiled-shaped vessel is situated inside the papillae, mucosal papillae, but this area, papillae itself is a little bit irregular shape, and then some are large and some are small, very heterogeneous. And then inside the vessel has a very tortuous.
Hello, Dr. Noria, can you hear me?
Yes.
Hello. I think these vessels are within the marginal crypt epithelium, is it?
So I think this is demarcation line. Now center, from right side, it's a neoplastic area. And then left side, if we really compare the each side, left side, the structure is very regular, little bit homogeneous. Compared to left side, you can see the very large, small, and the irregular shaped papillae with irregular vessels.
Beautiful demonstration.
Yeah. So that is so as I mentioned that demarcation, I said demarcation must, but this region, demarcation line is not so clear. But when we compare the shape of microsurface structure and the vessel, I think this is demarcation line. And on top of the, this is demarcation line. You know, now you can read it, clearly. And this is irregular cancerous. No, I think definite. From here. Now, from the lower part and the upper part.
So that's such a meticulous examination of a small area.
So I think
for beginners it's very difficult to even make out the difference.
But actually, white light image really increase the index of suspicion. And then maybe, so this is irregular papillae. So from here, still this is continuing. So maybe this is still, maybe here, this is demarcation line. Yes. Now, around here. And then this is another side. Here, upper part is neoplasia, and the lower part is very regular mucosal pattern. And maybe very difficult explanation, but usually gastric cancer has a gastric type and intestinal type. And Western criteria, you divide it glandular shape early gastric cancer as intestinal, and then diffuse non-glandular type as a diffuse. But the glandular type cancer can be also divided into gastric mucin phenotype, or according to mucin staining, it can be divided into gastric type and intestinal type. And the gastric type usually has this type of granular or papillary surface shape, while intestinal type differentiated adenocarcinoma has a network capillary and regular arranged orifice. And the characteristic of gastric phenotype adenocarcinoma is usually a bit difficult to make diagnosis. It really resembles surrounding gastric mucosa. So,
irregular vessels, sir.
Yes. From here, maybe this is demarcation. And so even biopsy diagnosis and the delineation is a bit difficult for gastric type, differentiated type adenocarcinoma, and also biologically little bit malignant. It means likely to convert it to diffuse type adenocarcinoma, unlikely to invade some mucosa.
Any role of a dye-based chromoendoscopy here in this case?
I try, but I think such kind of very flat lesion, usually NBI is better. Okay. I do this. No, chromoendoscopy. Maybe someone will perform ESD for this patient. Okay. Yes.
So is this indigo carbon?
Little bit more stronger. Yes. Yes. Wow. Can you give me only syringe? Now I use indigo carmine dye. Yes. I flush with using syringe.
So the role of dye-based chromoendoscopy is to delineate or demarcate the lesion?
Or we evaluate more gross appearance. So maybe slide, you can really evaluate the shape of depression better than just conventional white light. So maybe I should say that the speculation, speculation of the depressed area is one of the characteristic findings. So this depression can be a little bit speculated from here and from here and from here like this. Compared to that finding, maybe this is really just central scarring, no clear demarcation line. So this is benign. Yes. Okay, so I take biopsy.
That's a fantastic demonstration, I think. I mean,
Yeah.
the eyes can only see what your mind was saying. Fantastic. We can move to the next one.
Now we are requesting Dr. Nitin Jagtap to speak about the endobariatrics current challenges and in India. Speaker view, please.
Thank you. Thank you, Girish sir. I'd like to thank Dr. Ashutosh and Sonmun for giving me this opportunity to talk about this topic, endobariatrics in India, what are opportunities and challenges. I'd like to say Happy Republic Day to all and thank you all for being on Sunday here. That time usually we reserve for our family. Sorry. So my talk is basically in 3 headings: opportunity, challenges and future directives, and this news cutout will highlight what are opportunities and what are challenges. We as a doctor ourselves are 20% obese, 53% diabetes and 24% hypertensive, and this is the current scenario of our own population. Another study from South India, from Kerala, obesity in healthcare provider of 250 healthcare providers. You see the rate of obesity and overweight is above 50%. I want to highlight one more factor, which is here. You can see the presence of nuclear family and the presence of obesity in parents is one of the positive predictor factor for being obesity. So if you are obese and raising a kid, that is the biggest sin you are doing to your kids or the humanity and all. So what are stages of obesity? Obesity, first stage is usually denial. Second is acceptance. It may be associated with action or without action. And third stage, which is something like, tera baap ka khata hoon kya? So we need to have a approach where we convert those people who are at a denial and who are at acceptance without action and convert them into take action for their own health. So this is the trend of obesity and undernourishment in India, starting from higher nourishment to the lower risk of obesity, and this is almost now crossed by the obesity prevalence, that undernourishment is decreased and overnourishment has increased. So what are benefits of endobariatrics? Is minimally invasive, quicker recovery, fewer complication, reversible, and there are newer and newer innovations coming up in this field. But how this compare with the currently available drugs? So this is the study in JAMA Open Access, which studied the semaglutide and endoscopic sleeve gastroplasty for weight loss. And at the end, what it's conclude on the price threshold analysis, there should be at least 3-fold decrease in the price of semaglutide needed to achieve non-dominance or endoscopic sleeve gastroplasty. So ESG or endobariatrics is more cost effective compared to drug therapy available. What are further opportunities available with us? There are now, because of social media, there are various obesity awareness programs now being conducted all over the world. As of in the endobariatrics, there are various newer technological advances are coming up. These are gastric interventions, these are small bowel intervention. Few of the interventions such as Aspiracet is now not in the market because of various other reasons. So there are new things coming up. Those who are not performing well are going out also. Previously, DMR used to done by using hot air balloon to get a diabetes under control. There are usually 1 to 2% of HbA1c drop with duodenal mucosal resurfacing. And now there are newer technologies available which are laser, RFA, electroporation, steam, vapor and cryoablation to achieve the similar effect as up to DMR, and that may be lasting more than what DMR offers. Another opportunity for endobariatrics is having a collaboration. This is our AIG training module where we taught people endoscopic sleeve gastroplasty using Apollo overstitch. This is Dr. From Bangalore, who is very good friend of mine. And then in the next few months after, I went to his center and did ESG there. And after that, he is now independently performing ESG and is one of the highest who has done ESG in the Bangalore. What are further challenges with the endobariatrics are, this is 2020 paper from American Journal of Preventive Medicine, which stated less than 1% of obese patients who are actually candidate for any therapy either received prescription or underwent bariatric surgery. So that's been, in obesity as it now is underdiagnosed and also undertreated, and there is still limited awareness of available endobariatric procedures. And why this is occurring? Because of various barriers. The most common barrier is high initial cost. If you want to perform endoscopic sleeve gastroplasty, you require a double channel scope, which usually require higher cost than other procedures which can be done with the single channel scope, and majority of us are not having a double channel scope, and there is actually no other indication to use double channel scope also. Another part is lack of institutional support, inability to establish cash pay model, and difficult in establishing ambulatory or surgical and endoscope hospital to perform ESG. So what are evidence available? This is the MERIT trial, which is randomized control trial, multi-center in US, which has shown that ESG and after crossover, after 2 years, the weight loss with the ESG can be maintained. Another study, which is recently published in CGH, which is studying at 18 months, ESG versus lifestyle modification and sham procedure. At 18 months, they did liver biopsy, paired liver biopsy, and showed there is significant weight loss of around 15 to 20% and also resolution of NASH with no worsening of liver fibrosis. This is with the paired biopsy. There are another device which is called POSE. It does similar type of sleeve gastroplasty. This is initial study which is called Essential. The weight loss was on the lower side as compared to the sham group, but when the procedure is modified, the total body weight loss is around 15% and excess weight loss is around 45 to 50%. Third endoscopic sleeve gastroplasty instrument is Endomina. This is again a randomized control trial published in Gut, which has shown that after crossover, those who are in the sham arm also achieve a significant weight loss at 12 months and 24 months. What are more challenges with us is a stringent device approval process, and majority of us don't have that knowledge about this regulation. For example, we were trying for this electroporation generator for doing duodenal mucosal resurfacing, and we almost lost 12 to 15 months for getting this approval. Another part which is about training, this type of conferences and hands-on training can help newer people to adapt these procedures. We as a gastroenterological endoscopist in India, we have excellence in various procedures which include endoscopic, higher endoscopic procedures such as EUS-GJ, and many we are seeing from the morning third space endoscopy procedure, and this is one of the new endoscopic bariatric therapy which is called bariatric endoscopic antral myotomy, where you just perform antral myotomy, leave the pylorus as it is, just similar to G-POEM except not cutting the pyloric muscle, and close this lumen with a clip or suture. This is the initial study of 6 patients which achieved more than 12 to 25% of weight loss at 6 months and 12 months. What are another challenge with endobariatrics is the follow-up care. And We all know that obesity is chronic relapsing disease and the long-term success depends on the patient's dietary habits, behavioral changes, lifestyle modification in the follow-up. And majority of time in the newer setups, this is not achieved. And this is one of the app which is called Janani Mitra app, which AIG is developing with the ISB and IIT Hyderabad, is basically currently started for the pregnant women to monitor their nutrition intake and other things. This type of AI-based app is now in the beta version for monitoring patients with obesity and fatty liver. One of the most important part is the cultural factor with us. And when someone try to lose weight and achieve the weight loss, either with the therapy or lifestyle or the surgery. Suppose I lost 10 kg of weight loss. The first question from mother or relative comes with mother. Are you sick? Are you working very hard? Any stress? All okay? But the person who is losing weight for obesity should have a courage to say thank you for these responses rather than starting overeating again. What are future directives? We need to have a more awareness campaign among the physicians, among the patients. These procedures should be covered under insurance. There are further new research and data should be available. We at AIG doing these 5 studies for various indications with obesity and comorbidities include MASH, obesity, uncontrolled diabetes, obstructive sleep apnea, etc. As of now, the obesity management is multidisciplinary approach. Cannot be treated by single person or single doctor. It needs a multimodalary or multidisciplinary approach. And the robust training programs such we have available for the US and also the third space we should have in the endobariatrics also. I like to thank you again for your patience hearing.
Thank you for a marvelous presentation. So my concern is whether this, you have told semaglutide and versus, and whether there is any comparative approach like in surgical versus endoscopic approach.
The surgery versus endoscopic approach, surgery is definitely giving more total body weight loss, is in tune of 35 to 50% as compared to the endoscopy, which is reaching around 20%. But with the surgery, the rate of complication is between 1 to 3%, where the endoscopic procedure, a major complication is not there. So there are faster recovery, endoscopic procedure are reversible or partially reversible, and the cost is usually comparable.
Balloon placement, usually the balloon placement now is not going to be acknowledged a lot.
No, balloon itself has its own indication. So balloon can also give rise to around 15% of total body weight loss.
So, sir.
Nitin, nice presentation as always. Suppose the cost of the new drug called tirzepatide, which is a triple agonist, you have GIP, GLP-1 and glucagon. Suppose that is available, dual and triple agonist. If the cost is, say, Indian companies make the generic versions, then you think endobariatric will be out?
Sir, as of now, these drugs are costly. They will be in the patent period for next 10 to 15 years, and that's very long period. Another part is about the drug-related adverse events, which is present somewhere between 10 to 30% in the published studies. And also we need to remember, whatever study as a researcher I am doing or anyone in the world is doing is much more inferior as compared to the evolution that has done scientific research over a period of thousands of years. So there must be some reason for this, all these molecules act in a portal circulation, not in a systemic circulation. And now we are twisting that evolutionary fact to work these drugs in the systemic circulation and decrease the weight. So we don't know what are long-term effects of this drug, and majority of these hormones are tropic hormones. Tropic means they generate tissue at somewhere else, at some point, and that may lead to some hypertrophy, dysplasia, metaplasia, anything.
But you know, you have these drugs and these so-called trophic agent also have pleiotropic effects, especially on the liver as well as on the control of the diabetes and dyslipidemia. So they have added advantage also. Now with the newer preparation which may need to be given, so those containing amylin analogs and cabrilnitide, etc., may have to be given, say, once in 3 months or depot preparation. Do you think that will be the future?
Yes, the drugs will be there, endobariatrics will be there, and surgery will be there. There will be a patient who is having particular indication, there will be a patient who is having particular Y indication.
This drug is given in that case also.
Yes, yes.
And that have major effect to the insulin resistance and indirectly affect to the decreasing weight, so that you are getting in bariatric person.
Yes.
Okay. Thank you.
Thank you, sir. So now we conclude the session.
Thank you.
Thank you, chairpersons and the speakers. We'll be moving to the next session, which is on the art of the manometry interpretation. To chair the session, I would like to invite Dr. Sanatan Behra and Dr. Manjit Kanungo. So we'll be moving to the live demonstration for a couple of minutes, then it will be followed by the lecture.
Can you see us?
Hello?
Can you see us?
Yes, sir. You are visual and audible also.
So this patient has a sigmoid esophagus. So first we are doing endoscopy with a lot of food inside, and we can see mucosa also, lot of food is there. So first I think we have to intubate the patient, then we have to clean the mucosa, we have to make an assessment about the mucosa. So in the presence of long stasis, there can be significant submucosal fibrosis. So here we have two options. Either we place a nasal tube and feed her for 2-3 weeks, then do the reassessment, or we clean the esophagus and reassess the mucosa today only. If we get a good mucosa rate, then we may be able to do well. But right now I think there is a lot of food inside which has to be clean, mucosa has to be clean. So what's your opinion in this? So we want to
Louder.
this case,
Your voice is not that much clear. Can you be a little bit louder, sir?
So me and Sunil are discussing regarding how to proceed in this case. So here you can see the mucosa. Sunil, can you appreciate this mucosa appears shiny mucosa? So maybe once we clean the food, so we may get a window to enter inside the to make a tunnel. So I think we should intubate the patient, clean the esophagus, and Actually, prior to endoscopy, we always clean the esophagus, otherwise there is risk of aspiration. So in the atresia patient, when we intubate, there is risk of aspiration of food. So always under moderate sedation, we do endoscopy prior to intubation, we clean the esophagus, then we intubate. So here we have removed the liquid part. Now I think we can do a rapid sequence intubation and then reassess. I think you can, meanwhile you can switch to other room.
I think we can switch over to our next talk. I want to call up on the stage Dr. Jubin Sharma for the next talk on interpretation of esophageal manometry for achalasia. Thank you, sir.
Thank you so much, chairpersons. And at the outset, I want to thank Dr. Ashutosh, Dr. Sonman for having all of us here and talking about advanced endoscopy, talking about a lot of our advanced cases where we need some small nuances to deal with them better. So we just saw a case where we were planning to do a poem and there was a lot of food residue. So I think it's apt that we start with our talk on motility, and predominantly I'll talk mainly on achalasia. So if you see of Chicago classification, it divides all esophageal issues into two broad categories, that is disorders of the EJG outflow obstruction and disorders of peristalsis. So my whole talk would be focused today only on achalasia and how we can use manometry as a tool to really identify where we can do better things than just a diagnosis. So the baseline is that you need to have a high IRP to diagnose EJG outflow obstruction, and whereas all the disorders of peristalsis by definition should have a normal IRP, and that is the basic that all the guidelines say. But as we delve deep into it, you will find a few areas where these lines may get a bit blurred, and you may still have to pick up the diagnosis and not just follow the standard guidelines. So achalasia, so wherever I go and whenever I meet for a lot of these manometry talks, achalasia is something that comes up very frequently, and that's why I call it as a first disorder. But for manometry, I think anybody who's starting manometry, the first thing they want to pick up and diagnose is achalasia cardia. And if we really want to end this talk right now, this is what we need to learn. This is what is in the criteria. And if we can learn this, that there are three types of achalasia, manometry-wise achalasia. One is a long-standing one where there is absent contractility, no peristalsis, with some raised IRP. Type 2 will have a PEP or pan-esophageal pressurization, raised IRP, and type 3 will have a compartmental pressurization with raised IRP. So this talk can end here, but then is it something more than what we can do here? Is because diagnosis for achalasia is not really a problem. The moment you put in a catheter inside, you will pick up that yes, this is achalasia. But there is definitely something more that you can see. Now coming on to the first one, we talk of the type 1 achalasia, the classical long-standing one. And let me tell you, both these images are type 1 achalasia, but there is a huge difference between them. Because this is one achalasia where you will still be confused with IRP. You can because IRP even in a type 1 may not be very high, may not be in the range of 24, 25, it may be somewhere around 12, 13, 14, and they may still be achalasia. And this is where there are other disorders which may come into the place and confuse us. For example, something like this. The first image is an achalasia, and the second image is a systemic sclerosis. So both the images will have almost similar findings, except for one, that in systemic sclerosis, the LES will not be hypertensive, it will be hypotensive, and the IRP would be normal. But then again, as I said, in type 1 achalasia, there can be cases where the IRP is not very, very high. Now, if case you have a patient where IRP is normal, do you still treat them? We usually get asked these questions that, okay, LES is not an issue, so why should we do a myotomy in them? Why should we do a Botox in them? So achalasia diagnosed despite a normal IRP is still responds favorable to therapy, because ultimately we still induce some amount of emptying in a better way, and that helps these patients who are really refluxing a lot. And this was also proven in this particular study where almost all interventions, whether do a balloon dilatation or a POEM or a Botox or a Hellers, it actually worked well for patients with a normal IRP. Now, whenever you see these patients who have a normal or a low IRP, always look at how the esophagus is responding. In the first image on the left side, with a normal IRP, esophagus is not responding very well. It's almost having no peristalsis. This patient may not do very well, where the second patient, even with a normal IRP, may still respond well. If you still have a problem and we are not able to pick them up, challenge the esophagus. You can do things like a multiple rapid swallowing. You give them 2 mL, but in a very fast sequence, or you give them a higher volume challenge. You give them a rapid drinking challenge. You give them a 200 ml of water to be taken with a straw or directly by the patient. Now, these kind of images will come up. If you can see in this first image, once you challenge, the LES starts to give out that higher IRP values or a hypertensive response, whereas in the normal swallows, it was not that high. And if you do a rapid drink challenge in the same patient, you will really bring out that spastic disorder that we want to find out and diagnose in them. Now, whenever you see type 1 eclasia, particularly in northern part of our country, please ask and dig out the history of opioids. We have seen patients who classically behaved as a type 1 eclasia. They came to us with dysphagia, endoscopy shows peristalsis defect, food residue, manometry showed eclasia. But then we pick them up and you see that these patients were on opioids, whether pharmaceutical drugs for different indications or even for recreational use. And once you stop them, around 4 to 6 months, the peristalsis starts to come back to almost normal. Type 2 eclasia, I think PEP is something which is a constant that we all want to see. It's very easy to diagnose. You can see PEP as well as high IRP. One variant that has recently been described is the second image, where in the distal esophagus you will see a focal elevated pressures just above the LES. Now, this is a slightly different variant than the classical type 2 eclasia, although it still will respond equally well to a POEM. You might have to do a bit longer myotomy in them than the classical short myotomy described for type 2 eclasia. Coming on to myotomy, I think we have to also understand not all LES is the same. On manometry, you can tell how much into the stomach you want to go in. It's not all cases should not be only 2.5 centimeters. It will vary on the thickness of the LES or the high pressure zone that you see on a manometry. So decide how much you want to cut on the manometry itself. We did the same study and we published also in gut in the form of an abstract at IDDF. Coming on to type 3, I think it's very important to know the length that you have, how much you want to cut. This is the classical case where you really want your manometry to tell you that how much length you need to cut. In the first case, it's almost close to 14 centimeters. So you're going to do a very long myotomy in them. And in case you do a short myotomy in them, it will not work out very well, as I will show in one of the cases. Sometimes it may be challenged to actually, diagnose these because it's easy to see on those images, but imagine this manometry playing in front of you and you are trying to identify the LES, which is because of the longitudinal contraction of the muscle, the whole LES shifts up and you will not be able to actually measure the IRP very well because on a machine the line is straight, whereas in this video you can see LES is going up and it's kind of coming down. So it's not very easy. You can also pick up an anticipated difficult myotomy. This was the case I was doing and there was a lot of thick muscle there. I could hardly get any space even while tunneling. And as you can see in this video, I am actually first performing the myotomy before I even do a finished tunneling. And because on manometry, we anticipated that this patient would have a thick muscle close to 4 centimeter on the manometry and very high pressures at the level of LES. Now, finally, you're done your POEM. How do you assess the successful response to it? I think there's a concept we gave 2 years back in ISDCon of delta IRP. It's not just reduction to less than 15 IRP, it's how much percentage-wise you are reducing from the baseline. And if you can achieve a 50% response on IRP values, which is falling down, you have a good response to POEM. And presence of contractility after the poem also tells you that patients will have a better or a lower Eckhart score. This was an article on the same for both poem and lab fellows, that if you have some residual peristalsis coming back in a patient of eclasia, the emptying is better and they start feeling better. And finally, if you have a failed poem, how do you again plan? You again come back to your manometry and you can identify which patients I want to redo and which patients I will send for surgery. So manometry is not just diagnosis. You are going in from anticipating all the issues, you are planning your myotomy, you are assessing your patients, and you are also evaluating your failures. Now the case I showed you, the type 3 eclasia, if you don't do a complete myotomy, you will have something like this, where you will have a remnant muscle in the mid-esophagus, and these patients will respond. How do you confirm? You give them nitrates or PDE5 inhibitors, and you see whether these patients are responding, and finally you can do a redo poem. Also, there are various syndromes like AAA syndromes, where these patients may have varied, patterns on the manometry itself. These patients, try to treat them almost as a type 3 eclasia. If you see these kind of patterns, don't just do a short myotomy in them. They will not respond very, very well. So I think Chicago 4 is a starting point where you will just identify how to diagnose the textbook cases. But unfortunately, patients don't come back to us by reading our textbooks. So we have to really know that there can be varied patterns. Apart from diagnosis, manometry will give you more information, that is for planning, for anticipating difficult poems, for monitoring the progress of a disease, for assessing failures. So it's a tool to assess a chronic illness. Eclasia is a chronic illness. It's not just that you do myotomy and your disease is gone. You are just taking care of a resistance. The disease is still progressive. Your patients will come back to you with newer problems, and we have to come back to manometry to solve that. So thank you very much. Please, sir.
Just a basic science question. Where does the problem lie in eclasia? Where does it begin? Where does it end?
So you will know much more about that than me, but yes, I'll try to answer that question. So we recently wrote a review article for an API monologue on pathophysiology of eclasia. And we, while reading it through, we saw that there are at least 5 or 8 different mechanisms described, starting from viral infections, which obviously was the original explanation to it. But in the end, I think it has come down to hormonal imbalances between those relaxation hormones, the nitrates ones, versus the excitogenic hormones, and how do they respond in this disease. I think that's the basic, till now, the most accepted definition, or the reason behind somebody developing eclasia. What we are doing is just a mechanical work, just cutting through the muscle. I think somewhere down the line we might develop some medical therapy which is better than today.
And are they separate entities, type 1, type 2, type 3, or do they progress from one to another?
As per currently, well, but type 3 is slightly different. It behaves, the hormone changes are different in that. If we go down to the pathophysiology, type 2 and type 1 are more of a continuum. Type 3 and EJG may respond.
Type 2 will switch to type 1.
Type 2 will eventually switch to type 1. That's the usual story.
Same thing, type 3 should also switch to type 2, because what is happening in type 3 is that you have an excitatory neuron which are causing premature contraction. Yes. With passage of time, they may die down. Yes. Ultimately, you come down to type 2. So is it not a continuing 3 to 2 to 1?
So yes, sir, that was also one of the proposed theory, that type 3 comes to type 2 and type 1. But there have been a lot of cases where they have seen that type 3 it still remains as it is for many, many years. Somehow the hormones are still there, but the neurons are not dying down. I have seen patients who are around 50s but still type 3, they are not coming back to type 2, where I have seen type 2 happening in a very young patients also. So when this switch happens, and whether it will happen in every patient, that we don't know, sir.
And why this hormonal imbalance only at a localized lower GE junction? You have the whole body for imbalance.
So most of it, sir, it's the switch. There are two levels of it. One thing is that when the skeletal in the upper part, when the skeletal the muscle changes to the smooth in the mid esophagus, and at the lower end there is a physiological change. The structural change in the upper esophagus. The physiological change is the lower end because as they approach the LES, the peristalsis has to slow down. This slowdown needs a mechanism of a hormonal change. And that is where the abnormality starts developing in the beginning. So that's why it narrows down only in the lower esophagus rather than the upper one.
One question to you. It is, lower part is a smooth muscle.
Yeah.
It is affected only mostly the lower part. Upper part
Yes.
is not affected.
Yes.
For comparing poem and surgery, what is the current scenario of reflux status?
So if you talk of reflux disease, post-poem that is, so the data says that it's somewhere around 20 to 25% for poem and around 5 to 10% for surgery if they include a wrap around along with the poem. The issue is that this 25% is diagnosed based on two different studies. One is only on the history, that is a GERD questionnaire, and some of them, when we actually do a 24-hour PS study in them, they will say it's around 15%, but the answer to that usual query is that in patient of eclasia, there is a lot of stagnant food in the lower end even after a poem or even after a lap pallors. So that pH values may be falsely low to diagnose that condition. So as of today, whether we truly are seeing 25% or it is just around 10%, we are not sure. But to the patient, at least we say that yes, poem currently has higher reflux rates than lap pallors.
Another question, post-poem, reflux, failed. I don't have any experience. How many of them converted to surgery?
So if you have a post-poem failure in terms of higher Eckhart score, that can be managed by a redo poem also, because you have done a posterior poem, you can do an anterior poem. It's the same vice versa also. A previous lap pallors, if it's failing because of higher Eckhart score, you can do a posterior poem in them again, because lap pallors is usually in the anterior part. So you can switch between surgery and poem depending on what has been done first, and sometimes even redo poem after a previous poem has been done.
Exact pathophysiology is still not known. You have given one explanation.
So
that
we
is
are
the last.
we are still not treating the underlying
Exact pathology not known.
No,
Exact
what-
pathology not known.
No, not known. The only accepted today is the
Is
hormonal
a-
disturbances.
right.
How do we treat them? We are not that sure.
Okay, thank you. Very good talk.
Thank you.
Thank you, sir. Our next speaker is Dr. Sujit Chaudhary. His talk will be on interpretation of esophageal manometry for non-achalasia patient.
Good afternoon. I must thank to Dr. Mohapatra for inviting me for this meeting. And so my please excuse me if there will be some overlap of the, because Jubin has covered though only achalasia, but mainly I want to highlight that non-achalasia patients, what are the manometric, non-achalasia disorders, the manometric evidences, interpretation of esophageal manometry parameters. So you know that the Chicago classification has been fast. The version was published in 2009, and then 3 was published in 2015, and the latest version, that is version 4, what we all the gastroenterologists are practicing, that is called Chicago 4, and there is a consensus about how the esophageal manometry study has to be done and how it should be interpreted. This has been covered that the esophageal motility according by manometry, there are 2 disorders. One is EGJ outflow obstruction, and on the right hand side the disorders of peristalsis. The achalasia is the main part of the EGJ outflow obstruction. Other than achalasia, the another entity is called EGJ outflow obstruction non-achalasia. I will describe that. And the disorder of peristalsis, that can be absent contractility, distal esophageal spasm, hypercontractile esophagus, and ineffective esophageal motility. So the protocol for manometry you should follow, everybody should know. I don't know whether who are the, now mostly it is available in most of the centers, manometry. But the protocol according to the Chicago 4, the 10 liquid swallow, 5 ml water, followed by multiple rapid swallows, and then upright at least 5 swallows, and then some challenges, rapid drink challenges of 200 ml water in sitting position. The study should begin its supine position, and then along with the baseline recording, then the wet swallows, then change the position to upright, and this should be followed. If there is no, if you are suspecting, there is no major disorders are found by manometry, then there is a possibility of missing. Then there is a question for challenges. Either this is, you can do the rapid drink challenge, the challenges with multiple swallows, and then challenges with solid meals. These are the metrics that are usually required for analysis of the esophageal manometry, that is IRP, that is integrated relaxation pressure, and the standard, if it is in the supine, if it is more than 15, it is abnormal. In the upright, more than 12, according to the Medtronics. And the other metrics are most important is the DCI, that is distal contractile integral, and that normal is 450 to 3000. If it is less than 450, it is weak peristalsis. And if it is less than 100, it is failed peristalsis. If it is more than 8000 millimeter mercury per centimeter, then it is hypercontractile. And this is called the hypercontractile. And the latency is important, the distal latency, whether it is premature or if it is less than 4.5 seconds, then it is premature. This is the study protocol in supine, and then initially there should be an adaptation, then baseline recording, then multiple, these 10 wet swallows, and then the study in sitting position. The normal, this is a recording of the manometry is that it's topographically depicting the pressure of the esophagus pressure in different segments according to the time, so that you can have an idea of the body motility and the function of the sphincters. This is the normal healthy subject. When you are giving multiple rapid swallows, that augments the pressure, but not to have. Now this is normal, multiple rapid swallows. But when you are giving solid swallows, the IRP becomes high, the peristalsis is augmented, but if it is more abnormal, then you can be elicited, particularly EGJ obstruction, that by giving more solid swallow, the IRP will be very high. The normal healthy solid test on the right and rapid drink challenge test, these are the tests which we usually done. So the most important entity other than achalasia is the EGJ outflow obstruction. About 10% of the patients undergoing manometry can have this abnormality. But what is the implication of it? It may be most important if the patient is having the symptoms of chest pain or dysphagia, then it should be considered this is significant, and follow up that 1/3 of the case can be just some of the cases it may be a variant of achalasia, later progress to achalasia, or others may be some other benign disorders, but there may be some, it may be opioid use, it may be mechanical obstruction can produce. So you have to exclude the mechanical obstruction before diagnosing EGJ obstruction. So this is EGJ obstruction on the left hand side, the hypercontractile feature. But EGJ obstruction without disorder of peristalsis, only the IRP is high, in the middle panel, and sometimes artifactually IRP can be high and the DCI is normal. So this is EGJ obstruction with hypercontractile, disorder of peristalsis, or artificial rise of IRP. But esophageal manometry, when it is artifactual, then if it is high, if you give upright position, change of position, the IRP becomes normal. So that is very important, the reason for changing repeating the manometry by changing the position. But when there is this is on the recording of type 1 achalasia, the IRP is high, not significantly high. But rapid drink challenge, there is somewhat elevation, but there is no augmentation of peristaltic activity. By then, you should, before diagnosing these achalasia, the timed barium esophagus or functional lumen imaging probe has to be done for confirming the diagnosis. The clinical relevance, as I mentioned, that it can be artifactual or sometimes it can proceed to achalasia, but many of these patients are having the problem of persistent dysphagia or non-cardiac chest pain, and there may not be, either then you have to think of medical therapy, or rarely sometimes you have to think of POEM. Now the disorder of peristalsis, there may be absent contraction. When the DCI is very low, it is the median IRP is normal, but the DCI is very low. But in distal esophageal spasm, there is another motility and disorder of entity. Then there is the DCI is high, and the 20%, at least 20% of the contractions, the DCI is high, but the contractions are premature. The latency is less than 4.5 seconds. And the other is hypercontractile esophagus. This is also this variety initially called jackhammers, or when it is very high. So these hypercontractile esophagus can be a spastic, lower esophagus, or very high IRP, that is called jackhammers, or single peak hypercontractile esophagus. So hypercontractile can be different types, but one variety is called jackhammer esophagus. But among the disorder of the low contraction of the esophagus, called ineffective esophageal motility, the diagnosis required at least 70% are ineffective, or at least 50% are failed peristalsis. So ineffective peristalsis means weak peristalsis, the DCI is more than 100 but less than 450, failed, that is less than 100. So, but supportive evidence, there is lack of contraction, or when you are doing multiple rapid swallows. So this is the picture of the different varieties of reduced contractile vigor, absent contractility, ineffective peristalsis, inactive peristalsis, fragmented peristalsis, and contractile augmentation by rapid drink challenge. There is some augmentation, but the DCI is low. This is the we are doing manometry for a long time in our center, and this is data showing that most important is achalasia, about 43%, but other motor disorders are 5%, about 83 patients. Among these, the type 2 achalasia is the most common, and followed by type 1, and type 3 is less, 4%. Among the other motor disorders in our hospital data, that distal esophageal spasm was 35%, EGJ obstruction was 31%, ineffective esophageal motility disorder was 19%, jackhammer was 15%. These are some of the recording of manometry. This is a type 2 achalasia. This is also it is type 1 achalasia. The IRP is high, but there is no pan-acinar pressurization. This is jackhammer's esophagus, that is hypercontractile, and this is of ineffective esophageal motility disorders. So the take-home points for that, Chicago version 4 is the standard protocol for classifying these. esophageal motility disorder. Everybody should follow the procedures. The provocative test and supplemental test are necessary when there is inconclusive diagnosis. Other than achalasia, the EGJ obstruction, hypercontractile esophagus, and distal esophageal spasms are the manometric pattern that requires the presence of dysphagia and or non-cardiac chest pain to be clinically relevant. Thank you. Thank you for listening.
Thank you, sir. Thank you for the excellent talk. My question to you is, sir, how will you approach a case of ineffective esophageal motility?
The most important that I have described the criteria for defining the most important thing that you have to differentiate that whether it is ineffective esophageal motility disorder by manometry or it is a type 1 achalasia. That is very important. So if you do the challenges by rapid drink challenge, multiple rapid swallows, then if there is augmentation of contraction, that suggests ineffective esophageal motility. And in case of type 1 achalasia, usually IRP should be high, but sometimes really IRP may not be so high, significantly high. So this is the most important challenge for diagnosing ineffective esophageal motility. And ineffective esophageal motility can be by the different other causes. You should exclude the different infiltrative disorders of the esophagus, particularly scleroderma, systemic sclerosis, other infiltrative disorders. And the other thing that organic, so sometimes even the patients of eosinophilic esophagitis can have these manometric pictures like of ineffective esophageal. The esophageal biopsy is required when you are doing endoscopy. So,
thank you, sir.
Thank you, very good presentation. That is a infiltrative collagen vascular disease, that is a dysmotility. Okay. I want to learn from you. Suppose patient have a dementia or Parkinsonism, that is a dysphagia. Can you give your manometric finding for which suggestive of central cause?
Yeah. So manometrically, usually we are assessing according to that esophageal body contraction, that is peristaltic activity, and the lower esophageal. But definitely by manometry, both the high resolution and initially what we used to do, upper esophageal sphincter function can be assessed. And in my experience, I have diagnosed even the rare, that is called pharyngeal myasthenia. I have diagnosed only because when the neurologist referred the patient of the dysphagia, and then it was provoked by the hydrophonium test that the pressure was high. So you can assess by manometry the upper esophageal. Many of the patients of this neurogenic dysphagia, there is problem of upper, that is skeletal part. And then by that there is, usually these patients have a normal peristaltic activity and normal IRP, but the upper sphincter pressure is low and the relaxation is less.
Okay, thank you. A very good presentation.
I think we'll switch over to for the live case demonstration. I think we can switch over for the live case demonstration, that is the POEM procedure.
Incision, and we can see thick fibrotic margins. I must accept it's a difficult case. Thanks to guidance with Dr. Rahul, we were able to enter inside the tunnel. So when we have such case, there are 3 or 4 challenges. One is the lifting the mucosa. We couldn't get a good lift here, but with the more injection and slight cutting, we were able to enter. The second challenge, second concern is the bleeding. When there is significant submucosal fibrosis, normally we see larger vessels who tend to bleed. Luckily till now there is no significant bleed. And third is the navigation towards the G junction. I will show you, this is a dilated esophagus, grossly dilated esophagus. So sometimes it's difficult to direct your scopes towards the G junction. in that case, either you can put a guide wire in the esophageal lumen and do the fluoroscopy, and with the fluoroscopy guidance, you can go towards the G junction. And another trick is you go at 90 degree to the circular muscle fibers. So we have gone for, I think, 3 to 4 centimeter in the esophageal tunnel, and you can have, so it's a yeah. So we have to be very careful here, otherwise we can injure the mucosa. So options in this case were either putting the rice tube or the nasogastric tube and wait for 3 to 4 weeks and then retry the poem. So in this case, we look for the window in the esophageal mucosa. So at one place near the G junction, a knife inside, and now you inject. Yes, yes, you can please.
Yeah, Dr. Rahul, can you hear us from the hall?
Yes, we can hear you.
Yeah, problem this esophagus is still full of liquid material, semi-solid food material.
Yeah.
Now you are creating a tunnel. How are you sure it will not lead to mediastinitis because of the spillover? I'm sure there may be some inadvertent injury.
So before we come out, we clean out, we have really clean esophagus.
But during the procedure, you see it is going to take at least half an hour. So you're not worried. Was there any urgency of starting poem?
Sir, in sigmoid we tend to do in the same session. So what I will do, I will clean the whole esophagus before I come out in this case.
So that much of the dirty stuff is not a problem?
Pardon, sir?
What I'm saying is that collected food material, stagnant food material is not a problem.
No. It's in the upper part of esophagus, and before removing my scope, I will clean the esophagus again, and we will ensure a very tight closure. I am not worried about the, and we will clean it. Before we come out, we will clean it. And the fluid is accumulated in the proximal esophagus, and we turn it into a distal esophagus.
And did you do an anterior or a posterior?
Posterior, sir. So we go to window in the posterior part, and we enter through the posterior part.
Hello, so we will come back to room number 2. Meanwhile, we'll quickly shift to room number 3 for a demonstration of side wing endoscopy by Dr. Malay Sharma. So we have a 55-year male with ampullary adenoma. Just for the side wing endoscopy, over to Dr. Malay Sharma in room number 3.
Yes, yes. That's a challenge in the sigmoid actually. The usual challenge in that. It's an extremely difficult case.
Dr. Malay, can you hear us?
Okay. So I will start the case. So since there are some PGs also, I will take few minutes how to do side view endoscopy. I particularly stand in this position when the patient is semi-prone, put the scope here, and I will try to simplify it doing 5 movements, 5 motions. Number 1, when I am the pharyngo-esophageal junction, I call it the ziggling movement. I will jiggle, push, and lift up. So this is first movement, ziggling movement. Then I will advance in the esophagus, not by just pushing. I will call it more slowly rotating, maybe upward movement, till I reach the AD junction. At this particular place, I will move down and to left, down and to the left, and inflate, and then just wait for 30 seconds. So now, third movement is down, left. How much down? Not one down. Just half down, half left, hyperextend the scope, and inflate. This is the 3 step. Number 4 step is now, 4 step is now push, rotate, and move it up. This movement should push, rotate, and move it up, should bring it close to the papilla. This case, the shoulder is not lifted, to lift the shoulder so that it becomes convenient to bring it close to the papilla. So, this movement lifts the shoulder because otherwise you can get it. So, three things: push, rotate, and move it up. So, this is for bringing it close to the antrum. Once you come close to the antrum,
And Dr. Malay, entry in a left lateral position will be easier than supine?
left lateral. Now coming to the antrum, here is where I decide to call it a panther movement, that I am rotating my body left and right, adjusting the axis as I am advancing towards the pylorus, and even then I will not move the right and left now. I will going, even if the pylorus is moving, I will move my scope accordingly to enter. Now comes the crucial movement, is I will just rotate and I will try to go beyond the critical angle. What is critical angle is D1, D2 junction. Just keep on rotating, keep on rotating, keep on rotating, keep on rotating. And then move right and left now to right. Now the question at this stage I have to ask me, will I want I? Will I want I means, if I now shorten, will I advance or will I not advance? In this case, I know I will advance. Suppose my critical angle was this, I may not advance. This is 50-50. If my critical angle is like this, if I move to this right, chances of advancement are negligible. So, once I push it here, you can push it too much, but if you have a silken touch in anteduodenum, you ask yourself, will I, don't I? So now this is the place where I ask myself, will I? Yes. I rotate the whole scope, I push it up, I move this up knob up, and I pull it back. Pulling back can be done by 3 ways. One of the ways is making a U of the square like this, that I am doing, and then, so in this way, I am controlling 3 things at a time, right and left, up and pulling back. Once I come to this, can I have some water? The question is to do or not to do ampulectomy. So, in this case, there is some blood coming here, because Dr. Sanjay Rajput was seeing it, and he was thinking whether to do or not to do. But we will clean the ampulla, and I will not decide the cannula to clean this. But in this case, I personally believe that this ampulla, adenoma even if it has been found, this ampulla requires no intervention in my opinion. Now, sir, last thing that I will do, I am not throwing it in such a good position, so I will just push it by stroking and try to see if I can reach this in a semi-long loop. From now I am able to see it better. This is water, again water, and analyze the surface characteristics of this ampulla.
Hello, hello. Sir, can you hear me? Hello?
Yes. Yes.
Can you hear me? Can you apply NBI here to demonstrate how ampullary adenoma looks?
So
Please apply.
biopsy has come as adenoma, but can you give me a biopsy process? I can understand that the biopsy has come back, give me a biopsy process. I will just open up and see and show you that this adenoma is in this part. Because, give me a cannula, just I will not touch it. Because in this, in my opinion, if I touch it with a cannula, I can cause more pancreatitis. So, in this case, this is the papilla here, and this is the ampullary adenoma. So maybe this is also part of papilla, yes. This part of papilla, or I think this is the part.
Sir, from white light examination, how can you tell this is ampullary adenoma? How to diagnose ampullary adenoma by just seeing on the endoscopy?
I didn't get the question.
The question is, Dr. Malay, how do you know this is ampullary adenoma? Number one. Number two, how do you know whether to leave it alone or remove it? If you have diagnosed, why not remove it?
Alone because the risk of ampullectomy followed by pancreatitis versus risk of leaving it alone. So I think this is a
Sir, this is what Subrata Acharya sir told just now. Don't do ampulectomy here because the risk is more than, yes, I agree with you, sir. Sir, but kindly put NBI, sir, hello.
Yes, yes.
Dr. Malay, Dr. Ashutosh wants just show an NBI picture of how to look, identify adenoma.
Now I will give you a possibility again. Push it here.
Sir.
Again, down and left. Push, rotate.
तो मैं तो वही बोल रहा था सर show the NBI picture, then you can see, or you put just upper J endoscope.
Yeah, I'm just going. Yes.
NBI है आपके?
Sir, but this is I think 190 series scope. Sir, can you use 1200 scope upper GI?
Dr. Malay, do you have NBI in this side wing scope?
So I am not so familiar with NBI imaging, but I will just put it now. Okay. So come back to the papilla. And now, okay.
Dr. Malay, if
Yes, go from the please show from the normal area to abnormal.
Okay. So what is the consensus? Leave it alone?
But following the biopsy, you don't.
I am going to leave it alone. I am going to leave this picture on.
This is clear-cut adenoma, sir. You just look at the normal mucosa outside,
okay,
and that mucosa is completely abnormal.
You can shift now to other room.
Okay.
So we will be shifting to room number 1. So we have a 52-year male with no comorbidities. He presented with intermittent bleeding PR of 3-month duration. On colonoscopy, we found multiple polyps, 3 Paris 01S sessile polyps, ranging from 10 to 12 millimeters in ascending colon, 2 polyps in the sigmoid colon, and 2 polyps in the rectum. So plan is colonoscopy and polypectomy. It will be performed by Dr. Lutra. So over to room number 1.
Hello, I'm Noria. I'm now doing colonoscopy. And then now, this is an ileocecal valve. So now we are already reached to the cecum, inserted to the cecum. And then now I just apply some crystal violet, so it looks a little bit violet. But anyway, this is ileocecal valve. And then when we withdraw the scope, like a circumferential manner. Now, this is a polyp. So it looks, polypoid region. So maybe we remove it by endoscopic resection. But before that, I just want to demonstrate how to evaluate. So now we switch to NBI. So NBI classification for colorectal cancer has several classification, but this is the most popular one, nice classification. And in Japan, we use magnification, so we use JNet. But according to nice classification, non-magnification, this is nice type 2.
Type 2A.
JNet? Salman, what is this JNet classification? Tell us about JNet.
Okay. But it's nice. And then when we switch to and when we apply magnification, now we can evaluate this cell under surface structure. And
Dr. Sanmun, is there a one polyp or two polyps, or is it bilobe polyp?
surface pattern is regular. And the vessel is tortuous, but every vessel is situated. Okay, I will perform underwater observation.
Yes, Dr. Noria, can you describe it? Vessels.
So, vessel little bit tortuous, but every vessel is situated inside the well-defined marginal crypt epithelium. So I think we classify this as JNet 2A.
Okay.
Browner than the surrounding mucosa, but the surface structure and the vessel is
Sanmunu agrees with Dr. Noria or you differ? Is it Janet 2A?
This is 2A only.
2A, and then here is 2A as well. And then, but when we see, yeah, maybe can you recognize complete? Yeah. Now you can see that the base near the skull, the structure is a little bit smaller than the head part. Yeah.
One thing that's very important with this type is nice classification. It does not require the magnification. Whereas the genetic classification, it requires magnification. So after applying the blue magnification, you can say whether it's genet 2A versus 2B.
And genet 2B refers to intramucosal cancer or high-grade dysplasia. And probably nice classification just differentiate type 1 benign hyperplastic versus adenomatous or intramucosal nice 2, and then invasive cancer type 3. Probably all treatment indication for nice 2 is endoscopy detection, so they don't distinguish. But the Japanese doctor want to differentiate nice type 2 into intramucosal cancer or adenomatous lesion. Because adenomatous lesion can be managed by EMR, but high-grade dysplasia is better to be removed by unblock with ESD. So that is why Japanese doctor use DNA classification. And then
The top area appearing as page B, irregular vascular.
Yes. And especially it is located near the skull, I think it's better to completely remove. And then, unblock. And just want to demonstrate how crystal violet works. So, please. Slowly. It's okay. Stop.
So we're spraying crystal violet stain.
Again, little bit more.
It will define the surface pattern even better. And after this application, you can apply the
Sanmun, you are inaudible, completely inaudible to the audience here.
So, okay. Little bit more. Actually, concentration, I don't know where I use it. Okay. So now, actually, crystal violet is staying in the epithelium. So, the pit is enhanced as a non-stained area.
So do you apply crystal violet like whenever you have any doubts whether there is any high grade or
Invasive cancer, yes.
Sanmun, your audio is very bad.
not so good staining, sorry, because probably the mucus preparation was not that good enough. But anyway, you can understand how you can evaluate the pit pattern or epithelial staining. That is a really example of yeah, chronic glucosa. You can see the pit, regular chronic pit, like this. But anyway, this is the treatment. So, when we perform.
So now we are going to perform the underwater EMR to remove this polyp and block. So that's he's going to demonstrate now.
And we are really a big supporter of underwater resection. We published that for size 11 to 20 millimeter, according to landmark trial, underwater EMRs achieve better umbilical resection rate or alveolar resection rate compared to conventional injection EMR. So in the air, it looks like really attaching to the chronic wall. So it looks difficult to smearing. But if we, and also the tip of underwater EMR is before infusing the water, it's better to completely collapse the lumen. Otherwise, we have to, if there is air and water cause many bubbles, so initially completely collapse the lumen and then inject the water, fill the lumen with the water. So now you can see that the polyp is floating up into the lumen.
So Mr. Kunala pointed out that
Yes.
So that specific area, it's not staining well. So does that signify anything?
I don't think just maybe mucosal preparation, mucus preparation is not so good. But now you can really see the regular chronic like ampute regularly. And then now you can see the regular difference of this little bit more regular part and little bit regular head part.
I think this polyp is a classic example of where you need to get an adequate margin at the bottom of the stop and it's flopping onto the fecal side. So the water really helps there, right?
Yes. And then basically, underwater EMR does not require injection. So very easy, just infuse the water and then open. I think it's okay. I usually don't ask the open. Smear is a little bit bended. But anyway, at that time, don't force, don't push the smear much. Just
The
control.
polyp is coming nicely
Yes,
into the
yes, yes,
snare.
yes.
So we're basically welcoming the polyp into the snare.
And then, most important point is locate that we don't stop to the channel side, working channel side. And then go slowly. And this time as well, don't push much. Close. Close. Already close.
Already closed.
Ah, yeah.
We just have to make sure that the adequate margins are.
I think there is a small margin there. Okay, so cut. Okay. Close. Okay, enough. Ah. Okay. now, yeah, take the
Very
section
nicely
margin,
done.
and then we confirm there is no rigidity inside. Surrounding dissection margin, it consists of the very regular normal pit. So in this is complete dissection.
Yeah. Thank you so much, Dr. Riedel, for showing this. And this patient has actually multiple adenomas, so we're removing all those today. But at the same time, we have the presentation here by Dr. Precaution going on, so we'll switch there.
Yes. Thank you. Please. Yeah. Do you use a good grip? I don't know. Just, okay, grip. So I put the grip to here, so too short. This is also short. They have colonoscopy. They want to come here. Quick back, for ASIA. Gastroscopy.
Can you see us? So, nice. So we have done the tunneling till the G junction. Now we are in the most difficult part, that is the G junction, going across the G junction. The main challenge we are facing is because of significant fibrosis. And second, the angulation. So here we have to be very careful. There is a risk of injury to both the deeper muscle layer and the mucosal layer. So here we have to be very careful. Here. So we have to protect both the mucosal layer and the muscle layer. Sometimes there can be injury to the muscle layer and we can enter in the wrong plane. So here it's essential to keep an eye on the right plane. We have to just our line of dissection should be on the top of circular muscle. And you can appreciate both the mucosa and muscle are very close here. So it should be very gentle dissection fiber by fiber. So this is the right plane, this is the circular muscle and this is the right plane. If we enter inside this muscle, below this muscle, sometimes we can go into intermuscular plane. So one can end up doing a partial myotomy in that. So these are tiny vessels, such vessels may be coagulated with the coagulation current only. A vessel larger in size, they will require the choreographer and the force coagulation. I think this vessel we can tackle with the inject. Give me choreographer. So the key here is to go very slow. So patience is the main key. So there are two ways of using the coil grasper. Either you can grasp vessel, catch vessel between the two arms, or so either out, don't open, yes. So even the tip also we can coagulate vessel. Can you change to source? Change, okay. Okay. Push it to find here. Okay. So push it to exposure. So we will be using a force coagulation, a soft coagulation. So this is tiny vessel, so yeah, and you can see vessel has become whitish. So now you can see the space has become really narrowed. So one challenging mainly a bend there because of sigmoid nature. My scope is already in 90 degree. So we have to negotiate so this is the right direction. This is the, don't keep the knife in, yeah. So this is the right direction. You have to go here in this plane and then you have to go across into the stomach. Inject. So first I will dissect fibers on this side. So this will give me some space. So any opinion from the hall? Dr. Arora is there, Dr. Jubin is there, they are doing a lot of poem. So any suggestions? Inject. Out. So we have to dissect these fibers also on the right inject. So I will hook my knife there, then pull back and dissect. Force नहीं करना, force करो यार. हाँ ठीक है. Out, in करो, inject. Knife out. So I'm just pulling it back away from the mucosa and doing dissection. Maybe this inject. So I have to separate this fiber from the mucosal layer. So what I am doing it, I am hooking it and pulling it towards me so that there is no mucosal injury. Inject. Out. So I will hook it here and now I will pull the scope. So the whole purpose is to direct the current away from the mucosal layer. Again, so out, knife out. I am hooking it and pulling it. Yes. I think now we have some space to go inside. Inject. Yes. So yes, now we are getting
more space. Inject. Yes. So again, this is, so now we can see tunnel is opening up. I think we have crossed the narrowest part. Inject. Out. Yes. Inject again. Inject. So with me is Prakash, who is also very patient, and there should be a very good coordination between the endoscopist and the endoscopy technician. Inject. So we should keep on checking for the air in the neck, subcutaneous tissues and peritoneal cavity. So till now there is no distension, airway pressures are okay. So if there is significant leak, the CO2 will increase, the airway pressure will increase. Inject. So any suggestion or any opinion from the whole? So these fibers we have to clear. So hook and pull back as a knife or scope. So at G junction one should inject more and dissect less. Inject out, knife out, knife out. So again, hook and sometimes there is significant narrowing and a single stroke of the knife opens up a lot of space. Inject. Inject. So, so if the tunnel gets narrow, one should dissect on the margins of the tunnel. Okay. Inject. Maybe we can dissect this fiber. Inject. Inject. I think we have entered inside the stomach. There is change in the vascularity. Inject. 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 Out. Inject. Out. So you can see we are dissecting very slowly and steadily and trying to make a move. Now inject. Give me a knife. Give me a cold duster. So now we can see that vessel have become larger in size, and this indicates we are going across G junction. इसको soft कर दो, soft. Open. Open. करो, section करो. ठीक है, ठीक है. So we have to use soft coagulation till the vessel open. So now close, close, close. So we have to make sure that whole vessel has become whitened, and then we can use the, yes, vessel is cut. Yeah. So I think these are the perforating vessels, large vessels.
Are
So
these
perforated
perforators, Vikas?
Sir.
Are these perforators?
Yes, sir. I think we are the larger vessel at G junction, likely perforators. So
But the type of fat which you are seeing below the perforator looks like a gastric fat already. I think you're almost.
maybe, sir. Yes. So once we cut the muscle fiber, we should be able to appreciate perigastric fat also.
Well, the color of the fat is more yellowish than the one on the left
Yeah,
side.
yeah. Inject. Yeah, there is sudden change in appearance of cervicosa, and you can see the vessel also becoming spindle shaped. So what's your suggestion regarding the negotiating the tight G junction? So whenever you use inject, any special trick you use, Dr. Arora?
Yeah. I think because the peristalsis is less, so that means you have to really open up the G junction well, because the propulsive capacity of the esophagus is quite downtrodden. So
Yes.
you have to do a liberal,
I
I
think-
think, a dissection across G junction.
I think the float goes down by gravity only. So there are no effective contraction left in the esophagus. So here the only way the float will go down is the gravity. So patient has to be upright.
So these are the palisade vessels you are cutting now.
Palisading is on the esophageal side. So I think the nature of vessel had changed. Now you can see the more spindle shaped vessel, like the gastric vessels.
Sir, can you show us the sling fiber while coming out?
I think when we cut it, we can see. Right now, we cannot see any oblique fibers.
So typically, once you are doing myotomy, the fibers on the left of the perforator will be sling, which you tend to preserve.
Yes. Yes, sir. So here we cannot see, and mostly slings are oblique in direction as compared to the the transverse muscle. The slim fibers are oblique in nature. Indeed. It's very difficult to control direction actually because of the sigmoid nature of the esophagus.
Yeah, maybe I think you can, because you can extend by another centimeter or two.
Maybe we can come outside and see
Yeah.
from the. So this is the tight area actually. So this must be the tight area.
You can pull back in the lumen and then go in again.
Yes, sir. So you can see vessels, sir. Now they have changed. This is here a gastric vessel.
One on the right side is the elephantine vessel.
That should be left. So Ashutosh has selected a very special case for the last. So maybe we can go inside.
This muck on the mucosa, is it stuck up or is it lying loose in the lumen?
Sir, we could clear it with the flushing. We could clear the muck, and then we could identify a place where we could see good vascularity. So we can see some blanching there, sir.
Yeah.
So I think we can start myotomy.
Is maybe small myotomy be sufficient because this muscle
Yes,
in
sir.
any case dead. So it's unlike
Yes, sir.
type 3,
Only-
this is a classical type 1
Yes, sir.
in which you hardly have any strength in the muscle. It's like try to
Yes, sir.
flog a tired horse.
Yes, sir. So that's entry side. Yeah. I think we can start from here.
4 centimeters.
We have to avoid this vessel.
Now you can see beautifully the different type of fat in the perigastric area. Do you need to handle this big vessel, Vikas?
No, sir, no. As I think, in my opinion, unnecessary compilation of such vessel may lead to even necrosis of the esophageal mucosa later on.
But
So until unless,
would you anticipate problem during myotomy if you incidentally bump across it?
yes, sir. The myotomy and the G junction always is very tricky, especially if it's a thicker vasculature, and there can be torrential bleeding also. I'll give me precise only. Precise, same. So I will make around 3-4 centimeter myotomy on the esophageal side. 2.5 change So first we will dig the circular muscle.
In the initial attempt, Vikas, do you tend to do it fiber by fiber or you want to take
Yes, sir.
circular muscle
Sir,
into
fiber by fiber. No, sir. If it's uncontrolled, it can injure the deeper tissue also. So the main goal is to go slow and identify the circular muscle. If you go deeper than that, at the G junction you may encounter diaphragm also. So it's always advisable to stay just below the. Now you can appreciate.
Yeah.
So this is a
Longitudinal
circular and
can see.
both longitudinal, both you can appreciate. So we can enter in this plane and do only the circular myotomy.
So first cut has to
Sometime
be
I said-
superficial.
Yes, sir. It's very, very careful, sir. In poem, we are not worried about the time actually, it's a safety. Sometimes there can be very serious complications. So one has to be very gentle, careful. So the muscle is very thin actually in this patient. Sometimes in the young patient, even in the elderly patient, we see a very thick muscular band.
Surprisingly,
most-
yeah, circular muscle is also pretty thinned out, stretched out.
Thinned out, sir.
Yeah. In fact, 9 out of the 10 times, even if you attempt doing a incomplete, the longitudinal muscle incidentally gets split, irrespective of what you
Yes,
do.
sir. It's a very thin muscle. It's separated by itself.
So, you know,
You have
if you
to try
keep
to
on going
preserve-
down from here, the longitudinal muscle, even if you leave it intact, it will keep on splitting, where it's thin and friable.
Yes, sir.
Try to preserve it, but at the end of the day, it doesn't get preserved.
So the main goal is if you go below the longitudinal, there are vagal fiber lying. So if you injure the vagal fibers, sometimes patient can develop gastroparesis. So, so just try to be below either circular or longitudinal. Don't go deep into the adventitia. So in that place, the vagal fibers may be there. And patient may complain of vomiting later on because of gastroparesis.
Surprisingly, there is hardly any circular muscle at lower end. I think it is all, it's so thinned out. That is the reason there was complete stasis.
You try to go on the left side. You don't see much fat also. The patient is lean and thin patient. So if in the beginning of your if a learning poem and in the beginning of such cases, I think better to avoid poem in such cases. Technically,
Is this the time when you can say, are you avoiding sling fibers? Is there a clue to where you are going now?
I'm not seeing here any oblique fibers, sir. And the reflex is similar actually. Whether you do anterior poem, posterior poem, the reflex that is similar. Maybe this. And I think even the closure will be very challenging in this patient. He has thick margins. I thought. Perimeter margins, yes. So actually you couldn't see. I just want to make sure that you have cut all the circular fibers. Now there is a risk of pneumoperitoneum. Once you, yes. Doctor, now you can see the perigastric fat. Sir, can you see that? Now we can see perigastric fat below the muscle, longitudinal muscle layer. This is the perigastric fat below the muscle layer around the stomach. I think that completes the myotomy. We have dissected. We have completed myotomy and yes, I think that's enough for this. I hope patient will get some benefit with the myotomy. So we have done around 3 centimeter esophageal myotomy and 2 centimeter gastric myotomy in this case. We need larger clips, adjustable clip, yeah. Medulla or portion, whatever. So we'll check for hemostasis, there is no bleed, so we can take our scope out. So do you think we should do more myotomy or is it enough? I think we have cut enough. Yes, so this much should be enough. And we can see this is the tight area. This one is the tight area, and we have started proximal to that. This must be G junction, and that's a proximal to G junction. Yeah. Now we can start with the closure. So the first clip we should try to apply on the distal to incision. And open, 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 rotate, सीधा कर दो, घुमा लो, सीधा कर दो, और घुमाओ, घुमा लो इसको, rotate. So the clip should be in the alignment with the incision. घुमाओ उसको वहाँ देखो. We should try to take both the margins together. Close करो, फायर नहीं करना, close करो सिर्फ, close करो. I think we have taken both the margins. Yeah, fire. Fire करो. Yes. नहीं बैठा था मुझे. लोग बैठा था उसमें, मैं बैठा बोस्टन कुछ भी दे दो. So when we close it, both the margins should be inverted. Open? Yes. Rotate. Rotate करो. Wait. Close करो, फायर नहीं करना. Close करो. हाँ, फायर करो. Yes.
Vikas, Dr. Vikas, can you hear me? Dr.
Yes,
Vikas,
sir.
Subrat sir is waiting for last 15 minutes. I didn't tell you because you will feel nervous. No, sir, just joking, sir.
Oh, okay.
Joking.
No, I think we can start the.
Can we start panel discussion now? And once your clipping is over, you can show us. You have done
Yes,
very
sir, sure.
beautifully. You saved us.
Thank you.
We gave you a difficult case, knowingly.
I know that.
Yes, because you are very competent, that's why we gave it to you. Sir.
Rotate, rotate.
Okay. I would like
Conclude the
to
session.
call to the stage. 5 minutes, okay? Okay. Dr. Vikas is Subrat sir, student in AIMS.
Yes. कर दो. Ashutosh, can you see that how we applied the last clip?
Yes, yes. We are
So
not
this
start. We are
eventually-
because we are not starting any session. Once you finish, we'll start.
No,
So go
it is
slow.
finished now. I need just 2-3 minutes more.
No, you take your time.
Rotate, thank you. Rotate. Rotate. So we applied the proximal clip first, that led to erosion of both the margins. Right? Open. Partially close करो, थोड़ा close करो, थोड़ा close करो. अभी rotate करो. थोड़ा rotate करो. Yes, very good. Prakash is excellent technician. Excellent. Yeah, close, please. Yeah, close. Yeah. I think that should be, and maybe we can apply one more clip there. Huh? No, ये दो मेरे. Dr. Anil sir, are you happy with the closure? मेरे को 2 क्लिप हो देना, ठीक? आई के यहाँ लगाते पीछे लगाते. Open. Go. Good job. Fire. Very good. Fire. Yes. Ashuta, I have to use extra clips because it's a thick mucosa. Otherwise, you could have closed in 4 clips, but to be on the safer side. So you can see that proximal part of incision is lifted, so fluid cannot enter inside. Open करो. Rotate करो. Rotate करो. Rotate. और rotate करो. करो. Fire. Yes. So that is the last clip. So that finishes the procedure, and we can see we have completely closed the incision. So the vitals are within normal limits, no increase in pressure, no emphysema, no abdominal distension. I think we don't anticipate any complication. We will deflate stomach and take our scope out.
Can I invite Professor Subrat Acharya sir to the stage for an exciting panel discussion for Odisha audience? And Subrat sir needs no introduction. No, sir. Subrat sir hates introduction. He told me bluntly, don't talk much about me. But for Dr. Rahul Panala, he is the professor and head of AIMS 6-7 years back. He is now retired, but he is fully active. He is the most knowledgeable gastroenterologist in India, and he is a world-renowned hepatologist. So, we call upon the stage Professor Noria Yodo for the panel discussion, A.C. Anand sir, Dr. Rahul Panala, and very young gastroenterologist, Nitin Jagtap. Srihari, where is Srihari? Okay. I'm jealous of you because you will be sitting near the sir. Okay. Mic लो, start करो.
Thank you, Dr. Asutosh Mahapatra, for inviting me, and it's a great pleasure to be here. And I saw some exciting real-life endoscopic interventional procedures by real experts. And those were more exciting than what we are going to discuss. And what I see, hardly there is any audience, and mostly postgraduate student completing DM and MD should have been there, because this is a panel discussion on choosing career plans after completing your gastroenterology fellowship, which in India is called DM or DNB, Diplomat National Board, or Doctorate in Medicine, which is done after MD. Many of you, Dr. Rohit from Mayo and Dr. Sabis from Japan, they don't know our system. But these are people who have been gone through MBBS. There's basic graduate training. Then they've done their specialization in general medicine. After they branch out to cardiology, neurology, nephrology, gastroenterology, hematology, or other disciplines, right? So by the time they complete their DM, they have completed almost 12 years of medical training. And they are invariably adults by that, and have a brain very well exposed by that time, and they know exactly what they are pursuing. However, having said that, I probably joined gastroenterology in the way back in 1980 in this country at AIMS, which is over 45 years back. And that was, at that time, growing. And I've seen how it is growing. General Anand, when I was a lecturer there, faculty joined as a training gastroenterology fellow. But during last 4 decades, it has grown tremendously. And all of you are aware that basically people divide gastroenterology as a subject to various disciplines. Now I can see gastroenterology is no more confined to one discipline. And people don't practice gastroenterology in that fashion. Now, just like MBBS, you are trained in starting from anatomy to medicine or preventive medicines, gastroenterology forms a base. Gastroenterology training, particularly DM and DNB in this country, where you exposed to various areas, hepatology, endoscopy, luminal gastroenterology, pancreatology, preventive or inflammatory bowel disease, then infective gastroenterology, gastrointestinal oncology, and preventive gastroenterology, or community gastroenterology. Now you are given exposure to each of this discipline. After that, depending upon the interest and lucre. Lucre has many meanings, right? People try to choose career. The most lucrative is advanced endoscopy or endoscopic interventions. If you find in my country, most young people are going into advanced endoscopy because that gives you tremendous satisfaction, as well as the first one is creative satisfaction. You have done something. Gratifying result, immediate gratifying. You have done an eclampsia, you have done a myotomy, poem, and it swallows. Right, you don't have a stagnant barrier anymore, right? And this also give you popularity. You are an interventionist. It's like a surgeon, right? And it gives you finance, right? You become rich. So you become rich, you become popular, you become creative satisfaction. So that gives a tremendous satisfaction to people. That's what I see. And the second area, I will ask you each of question, which is very attractive to these people, is a transplant hepatology. is very challenging, difficult. In my country, it is not DDLT, it is mostly LDLT. And gradually, the number of LDLT in this country is increasing. It has become second largest country doing transplant in the world. And LDLT is challenging because two people, two surgeries, right? Post-transplant problems, immunosuppression, rejection, infection, balancing, things like that. That itself is a third area which people get interested is inflammatory bowel disease. Because incidence of inflammatory bowel disease in this country is in rise. I remember I hardly saw ulcerative colitis as a resident or a Crohn's disease as a resident. Now you see it every day, right? And many of our former students are describing their prevalence and incidence, including population-based study by Dr. Sudhin Gatt, long back, household survey of prevalence of ulcerative colitis, about 4 per 1,000 population, which is very high. So why inflammatory disease is very important? Because of number of molecules, monoclonals, right, and complicacy thereof, and managing more and more difficult cases. And they're not curable. Whatever drugs you have not been able to cure. All these monoclonals, right, starting from inflixi, ardali, right, class changes to interleukin, like Stelara or ustekinumab or risankizumab, or even recently tofacitinib, udapacitinib, all these drugs which you have heard. Now they are becoming game changers with complications. So this is a third area, very important area which is coming, right. The other area is luminal gastroenterology, right, which itself is also challenging, which also consists of interventionalists, because advanced endoscopy, if you ask, I see many of you are there. Now you cannot do a double balloon simultaneously with POEM, expertise, right, doing a US guided liver biopsy or putting a stent. Each need is expertise. So you see how the discipline is becoming. And in Japan, I'm sure, Dr. Noria will say, they fundamentally believe in growing in one area and picking up one area to become expert and get recognized. Having said that, I will invite my co-panelist and chairperson to provide their comment, because it's time for a fellow, after completing his DM, depending upon his passion, to choose many, right, one of these many, if he wants to be recognized, having everything in his pocket. That's the game. So can I ask you to, well, I will ask Dr. Noria to respond, followed by Dr. Anand and Dr. Roy.
Difficult, probably the situation is quite difficult, different from Japan and India. But actually, when I always say a fellow after finishing training or a PhD in my hospital, I always say sometimes our young doctor really want to become a very big person, advanced endoscopist, or instantly, immediately. But everything is almost like a kind of accumulation of the small step. So don't expect big thing from the first time. So I always say just something you have to do, like seeing patient very kindly, and then basic endoscopy, just do every day accurately, honestly, and then after accumulation of such kind of step, eventually we can get a big achievement. But young doctor really want to get such kind of position immediately. So I always say important to have a very big object or like aim in the future, but the most important thing is to do daily work or your duty, honestly, and accurately. That is
what Dr. Noria is saying. Don't get immediately impatient to be very famous, right? Have patience. Do your work regularly, right? Choose a particular discipline and continue to excel, right? The success will come. This is the message you want to deliver to you.
Yes.
General Anand?
In India, the situation is a little different. We have very good government institutes where you can get employed as a faculty, but the number of such institutes is small. In any case, the overall healthcare scenario, if you look at, 80% of beds, they are in the private hospitals. So majority of people who go out, they have very little choice. Even if they want to follow academic medicine, they have to wait for a long time to get positions in the government hospitals. So what they do is they go for a private hospital. Everybody has their own situation. Some people have their parents who are already running clinics, so they join them. And some people would start afresh. If people are really bold, they will probably take loan of, say, a few crore rupees and start a new clinic. And many people will look for a job in a corporate hospital. So this is the scenario that I have looked at in last few years. Now, question is, what is it that he wants from inside? That has to be curbed, and he has to make adjustment with whatever situation he is getting. That is how usually most of the people begin. But very soon they can follow the line that they want. Ideally, I would say that a person should be with an academic institute, whether government or a private, for initial 7 to 10 years, definitely, before taking up a totally private job. Because initial 10 years are the formative years when he can have his protocols firmed up. He knows that in this situation, this is how I'm going to react. And in private, because he has to work as a solo specialist, generally it is not as a team that most people work. And therefore, once he is very sure about what he's going to do, then he can start his career in the private hospital. This is what I have been seeing all around me for last few years. When I was a student, I was already employed in armed forces, and I had very little choice. I had to go back and work in the armed forces.
General Anand is emphasizing a very important concept. No more today you can work alone. You cannot do the clinics, you cannot push in the colonoscopic screening, you cannot do a ERCP, you cannot do a POEM, you cannot do a double balloon, you cannot control a bleed, right? You cannot do everything. And sometimes you need a team. And the team should have an interventional radiologist. That's what he's trying to see. Because that is very important today in gastrointestinal management. He also say that you should have in a team excellent pathologist, right? And third thing, you should have always surgical backup, a good gastrointestinal surgical backup. Essentially, this 4 or 5 P team and their ancillary things should be there. But this is from the day one, if you start your own, it will be very difficult. So that's what his advice is, to start this, if possible, in academic institution and generate the team spirit, team work together, understand that, because that is a great input to work outside and grow further, right? And Dr. Asutosh just now informed how he created a team. His technician today was a fellow who was serving tea, how he trained him for endoscopy. There are many, many things are required. So that's what Dr. Anand. Dr. Rohit, will you comment something?
Yeah, no, I think it's very interesting. I think my initial comment is that, for anybody who's graduating, I think the core principles are the same across whether it's India, America, or Japan. I think that in the US, the structure is we do 3 years of, after MD or MBBS, 3 years of internal medicine, 3 years of gastroenterology, and then you choose whether you want to do an extra year of advanced endoscopy, extra year of IBD, extra year of esophageal. So they're structured fellowships. I think that's the one difference that we see. Now the pressures when people come out and graduate are the same. They've spent about 10 to 12 years, and so they have, they're coming out, like you said very nicely, as adults, and they have responsibilities and that. So some of that decision goes into decision making. I think practical considerations are very important when you choose a career at that juncture. So in at least what happens, right now medicine has become so complicated. I call that medicine in general, but endoscopy or gastroenterology is a team sport. And I think finding the right team setting where you'd be happy to do what you need to do. I think if you want to do advanced endoscopy, you need to be at centers that have the entire structure in place. What is happening in the US right now is the advanced endoscopy slots are fairly saturated. So we are training multiple fellows every year, 70 to 80 fellows every year, but they're having a hard time finding academic spots. So there is a little bit of blending going on, and there's a lot of discussion going on from a national society level of what's the right number to train. So there's some of those pressures. I think a lot of, one of the other things that is there, which is very unique to the US, is the amount of medical, how much education costs. So a lot of our graduates come out with a lot of debt. So that goes into a lot of the decision making. But so our basic pathways are the same. A lot of people go into clinical medicine. When they go into academic, it's a combination of clinical plus research or clinical plus education or all three. So those are the pathways that are there.
Thank you. That's, of course, you see the similar pattern. And I have colleagues on both of my side who like to, they're young people. And they might have different thoughts. Then probably General Anand, me are probably the oldest, and followed by Dr. Rahul and Noria. And these two are very young. Let us hear them.
Yeah. So I really have a slightly different take on this. So I speak as a young gastroenterologist who was not as senior as the people around, and speaking of the Indian context. So I think usually people are driven by passion, of what they want to choose as a part of their career. And passions are also often driven by the glamour that is involved in that branch, more often than not. It is not their inner calling, but it is the glamour that they see, that they become passionate that I want to be a good endoscopist. But many times, especially in the Indian context, in the way that we work, I think you also have to think about where you are working, where do you eventually plan to work, and is there need for that specialty? Is there actually another person working in your team who's already doing that? I don't think there's any harm in exploring other areas as well. As sir pointed out, IBD has such a lot of scope. Everybody here wants to do endoscopy, but what is the harm in exploring IBD? What is the harm in exploring motility as a branch? And eventually you might find your true calling later on. So like Dr. Ashutosh here, he started getting into finding early gastric cancers 20 years into his career, if I'm not wrong. And so now that has become his passion. So I think subspecializing immediately at a very early stage might not always be possible, and I don't think it is always right to do that. I think there's no harm in exploring the less explored areas. They are also very good. They also give you a lot of accomplishments. But I think whatever is to be done has to be done with all sincerity. Only then that will take you places rather than just focusing on what others are doing, what looks glamorous. I think you should have a more broad-minded view for that.
That's right. That's what you're absolutely right. I remember maybe 2 decades back or 25 years back when I was the program director of Gastroenterology Fellowship at All India Institute, I realized this. And since it was a medical institution of training, I thought we should excel in each area. And there, General Anand will know now, there are stalwarts in one area, say somebody who is working on inflammatory bowel disease alone, Professor Vinit Ahuja, whom you know very well. He's a young gastroenterology doing endoscopy, luminal, everything. Now there is, you know, Dr. Garg doing pancreatic work fantastically, right? And you know, I developed hepatology at that time, nobody. And Professor Mukherjee, I started asking him to do work on celiac disease, and now he's a world famous man. That is feasible in an institutional structure where we have a team, we have a department, we have multiple residents, labs, all interventions, while you have to provide service in this particular area, where everybody of them will do the outpatients, inpatients, ICU management, emergency intervention. But their special area is that. Right, that's the way an academic institution work, but that's why General Anand told that you should work in that fashion. But while today, and Anand pointed out, that is very difficult to get in an academic position, right? And second thing, people are not preferring academic position because academic positions gives you very little money. Asutosh came to me when I retired and joined here in the KIMS Institute. I told him, we cannot pay you 10 lakhs. Will you join us? No, I'll not. Because this is a medical institute. You have to train, you have to teach, but we will pay you less. He flatly refused. No, I need money. Right, I'm getting 10 lakhs. Right. You understand, right? So you see, this is the situation. While what others are telling, the practicality of situation is this. Now this young man will be making 20 lakhs per month, right? Now ask him to come to academic institution today at All India Institute of Medical Sciences, joins as assistant professor for 1.25 lakhs starting salary. I'm the president of All India Institute. I was appointing the selection committee of Jodhpur AIMS, right? Will you join? No. They will not join. Now, that's why, before I go to all of you, how to solve this problem for a career option what Asutosh raised, and this is a practical thing I asked, and the organizer of the meeting themselves, right here in front of me, whom I offered a job, he refused, right? What do you think under the circumstances? And I was in an academic institution, and that was the academic institution where General Anand is the head now, right? This is a practical situation. So, what do you respond to this?
I'll talk few things. So, as Sri Hari said, what you want to choose depends on passion and the glamour associated with it. But another part is always think in a larger view. So, see what we required as a country, we required as a community. So, do you require advanced endoscopist as of now? Do you require a person who diagnosed gastric cancer at early stage rather than doing procedure USGJ at stage 4 disease where he only lose the money? There is nothing else. And you get some gratification. So there is a good study done in Stanford, I think. It's called Marshmallow Experiment, which talks about delayed gratification. I believe if you see your patient alive 5 years after the treatment, that should give you much more gratification than doing that USGJ and seeing that blue color coming into stomach. Another part that will guide your decision to choose any career path is your financial condition. So to improve your own financial condition, don't take unnecessary loan, particularly a loan which can't increase your asset. So if you want to do your own practice, make sure you are choosing the right place, and the services which you are going to offer should be important for that particular community. So if you are going in some second tier, third tier city, and you directly said, I'll do this high advanced endoscopy, it won't work. If you are going at a particular state, you are specialist in celiac and you want to settle down in Bangalore, Hyderabad, it won't work. So you have to think about these parts also. Additionally, pay attention to research. Japanese are working since 1950s, 60s to diagnose early gastric cancer or any early malignancies, and we're not doing it now. There are few people, just handpicked people who are doing. So think about research as whatever you are doing, one particular part, you should work on that.
That's a very good point, what he said. I was just talking to us, those. And I asked, he just asked me, sir, ampullary adenoma, they are thinking this, why they are not doing ampulectomy? I just asked him this question. How many ampullary adenoma becomes malignant on long term? How many ampullary adenoma you see in between age 20 to 40, between 50 to 60, between 60 to 80? With the approach will be same. Do you have a cohort, long-term follow-up? He said, I don't know, sir. Okay, then you have a hammer and you find nail everywhere. That's exactly what he was trying to say. And say ampullary carcinoma, in 10 years down the line, you have a 2% or 3% cancer rate. You do ampulectomy, you say 3% severe bleeding or perforation or morbidity or 1% mortality, the risk benefit. That's what he was trying to say. Technology is fine. Advancement of technology is fine. 10 years down the line, you will be using AI and machine learning integrated into this, which will guide you. But the aim is to provide benefit to the larger section of the people for whom you exist, your existence. For the larger section of people who come to you with a trust that you will do right. To do that, what we call as evidence-based medicine, General Anand teaches me, and I argues with him what is evidence-based medicine, because it shifts, right? The evidence always shifts. So today what is evidence, tomorrow it is not, right? But despite that, each of us has learned while doing things by doing research. Research improves your knowledge, improves your, so whatever you're doing, whatever your passion, wherever you work, you can work in academics, as Anand told, for some years. You may not get it, you may work in a corporate sector, right? Preferably academic, if you don't see another corporate sector. Third thing which came out, built up a team. And fourth thing, tell you your finances, your own family, there is a balance. And fifth thing is said, came out that, well, whatever you do, try to keep a record, try to learn, and that's why we call a research. Okay? Having said that, I will invite the audience, because each of the speaker, participant has done it. I will ask with Vikas. Vikas was one of my students long back, right? He has been trained by us, but he diverted to another disease. I will tell you a very interesting story. I never knew that he was very interested in interventional endoscopy. He never told me, right? Am I right, Vikas? I used to call him to my liver clinic and make him sit in front of me, right? Thinking that I will train him in liver disease, because liver disease, right, I needed people. He quietly worked, but once he's finished a fellowship, he's just shifted to endoscopy. Another example. Tell clearly, right, your guide that, look, sir, I don't want to do this. Right. They can.
No, we can.
They can. They know that they can. That's the discussion. They should. They should. Look, you should tell me, look, Professor Charya, I'm fine. You are asking me to do this, but I'm not. And there are many examples. For example, if you remember, you know Sorokadia in inflammatory bowel disease? Now, I was instrumental to bring him back from a private practice to institution with the intent that he should do in liver disease. He came to me. No, sir, I don't want to work in liver disease. I want to work in inflammatory bowel disease. Perfectly fine. He had his passion. So he should say, what do you say?
Yes, sir. I think one should be very clear regarding what you want to do in future. But I think sometimes we are also confused also, sir, when we are doing DM. So we get also, we even don't know what lies in the future for us.
For the audience, how did you make your mind that I will learn intervention?
So
you are exposed to everything.
Yes, sir.
I remember you are doing EUS. Yes. Even I was sometimes with you, right? That's a different old thing. But how did you become interested? That's the message you should give.
So I used to get, sir, I used to get thrilled in endoscopy room, sir. So whenever I used to see blood spurting from the varix or the ulcer, and you get the control of the varix, you have to get a rush, sir. So you get excited. So
see, that's what I told you, gratify.
So
it's a creative gratification.
So
that's right.
So
that attracts many people. Exactly.
Sir, when you are learning colonoscopy, you fix the targets, you are happy reaching cecum, that gives you thrill.
Okay.
So I think that's a...
Fine, that's perfect. But sometimes it happens by default also, by doing things also, and by also lucre. I will ask Asutosh, how did you get interested to go to Japan, learn early gastro? Even you were doing everything. You are doing, you are a clinician, you are a popular clinician, you had seeing clinical, you are doing all intervention gastroenterology, and suddenly you wanted to go to Japan and learn about early gastric cancer and do it. How did you do it? What is that?
So I got fed up with this doing endoscopy and colonoscopy. I got fed up because I was doing nothing, like there is no research paper. I was feeling very low. Though I was earning at that time in 2016, they were giving me 10 lakh per month. I was not satisfied. That money, I love money. There is no doubt about it. Now I love more money than anything else. So, but...
Who doesn't love money in this house? Raise your hands. See, everybody loves.
But what happened, sir? I was I worked with Dr. Goenka, who is one of the ERCP master. Then I went to Dr. Malay Sharma to learn US ERCP. But somehow, I told you, I believe in something called destiny. When I went to Dr. Nauria, and I saw he demonstrated early gastric cancer to me very easily. Then I thought we are missing a lot of early gastric cancer. Then I thought, my state, I'm seeing at least 5 advanced cancer in my clinic per month. So Dr. Nauria told, if you see 5 advanced cancer in your clinic, then you must be missing 10 early gastric cancer. That's the ratio, he told. Then I thought of buying endocytoscope at that time in 2018, Zoom scope. So I think it is the, I don't know, but I got attracted to it. So then I became passionate. But you should be aware of passion and obsession. These two words you should measure. Because once you obsessed, then everything is gone. So then I brought 1200 scope, X1 scope. Now it is an addiction now.
We got your point.
Yes.
Sir. You see, what he is trying to Asutosh is a burnt out phenomenon. And I will tell that is happening in the US. I will ask you, Rohit ji, from on this point, a very important concept which Asutosh has burnt out very clearly, right? Getting bored what you do, right? And the passion on another aspect. You'll be surprised, ask Rohit, is it true today that in the US, there is a huge burnt out phenomenon amongst medicos, and they are in trouble. They are shifting, they are becoming nurses. They're going to other professions. and they are living medical profession. Sir.
Yeah, no, that is very, very perceptive. The statistics are shocking. About 40 to 50% of US physicians are burnt out. The rate of suicide is the highest among physicians. And the reason is we have a lot of pressures, just like anybody else, but we also have a lot of electronic medical record, patient replying to patient. So a lot of those other pressures and system pressures. So burnout is a very, very key issue. I think just over the past few years, we've learned to talk openly about it. Before that, there was this culture of if you complain, if you don't talk about it, if you talk about it, you're considered weak. So that has shifted, and people are much more open to talking about burnout. So it goes back to what you were saying before. It is choosing wisely, choosing and balancing, all your responsibilities outside of work, knowing what your limitations are, knowing what you're aiming for in life, and what I call define your trajectory. There's a trajectory for everyone, and there's and which trajectory you want to choose, which trajectory you end up in practically, and where and how you define that trajectory and being content with that trajectory of life is very, very important. And I think one of the other refreshing things that you are talking about is I think there's always an intersection of money and medicine, and it's important to talk about that in a very transparent manner.
Yeah.
So I really appreciate that.
Is there any burnout in Japan?
Yes. Yes, I think
This is a global phenomenon, General Anand.
Same situation.
It's a global phenomenon, including your own country. Relax, you will see it more and more. Because we have till now. Dr. Bhushan Pandit want to make a comment. Dr. Pandit, please.
Hi, I am from Mumbai, so the city which never sleeps kind of a thing. I will touch on 3 points. Each individual is a makeup of his own samskaras, with what he saw in his parents, what he saw in his surrounding, what his family gave value to, and I think that is what will reflect in his choices of future. So somebody might be attracted to more money, somebody might be attracted to lesser money, but more satisfaction, gratification of treating more patients maybe at a charitable rate. So we cannot fit one formula for all. I think this is the baseline dictum. Second point which I wanted to touch here was burnout syndrome. I think my father was a great physician, but worked tremendously hard, but eventually burnt out. And I understood that it is some other hobbies which are required, because in Mumbai, everybody talks about, I did 100 ERCPs, I did 500 procedures of this, I did that mucosa, I did that poem. I said, who's writing poem? Have you written any poem? Are you citing any poem? So people will laugh at me, but believe me, the balance of work, art, money, definitely we want money. Who doesn't like money? Every hand was in the pocket actually. So everybody loves money, but each person's desire, hunger is different, and burnout can be managed by allied things like, having hobbies, having a group. If there is a good group working together in endoscopy department, there is a light music going on in the background, I think you will not burn out in that department, because Vikas will take up a poem case. I might do a simple colonic polypectomy, or I'll do a ESD and I'll be happy. I think this was the second point. And third most important point with that junior guy who's the last person sitting
Not
here.
junior.
No, he's a big man from AIG now. He's a big man. So don't tell my age. So Acharya sir is one legend here. Anand sir we have been always looking up to. But as juniors, I always feel, I think we were discussing informally, this was not part of this discussion. He's from Solapur. And I asked him, are you going to go back to Solapur? Nahi. वहाँ पे खेती चल रही है, पापा मम्मी settled है. I am in AI, he is working in AIG, and I am happy there on a salary basis. I don't want to discuss those financial aspects, but I think that is what summed it up for me, that my family life, my wife is a radiologist who's taking care of kids, doing her practice. I have a set life. I'm happy in that domain. And I think that happiness, each person has to find out. I think the juniors here, mark my words, wherever you are working, please have a good team. It's a good team which is very important. I remember meeting Ashutosh in one of the Delhi conferences. 1 hour he was talking about early gastric cancer. And I told my wife, Bapre, aadmi na, thoda sa, towards the level of extreme hai, but I think this is something interesting. And today I am here in this conference for the first time in Bhubaneswar. So I think this is how life can come out of a burnout. You can come to Bhubaneswar, enjoy this meeting, and go back to Bombay and start practice again. And write a poem of life.
So thank you, Dr. Bhushan Pandit. What he is trying to tell you, besides all these points which you discussed, you must have a work-life balance and should not get burnt out and be happy essentially. And practically, I think, Astos, we have covered almost your 40 minutes. Have we? No. Another 5 minutes, I will like to listen to other people. Come out. This is nothing, this is not rocket science, your mind. Come out. Sunman, you are the famous lady of this state.
Well, so this is actually a very difficult question for me, and that's why I was not coming out from the audience. So basically, I don't know, probably I'm more passionate to what, I never complained that I burnt out, honestly.
You are very young today.
Yeah, maybe that's why. And one thing I would like to emphasize is which field you want to go into after you finish your GI fellowship. That's one of the questions that most of the fellows in the US, they kind of ask. But what exactly attracted me is my research from my GI fellowship and during my residency time. During my residency time, I worked with Dr. Suresh Chari. He's a very famous pancreatologist and very close to Dr. Acharya sir. So then I got attracted to pancreatobiliary because you get that mentorship, and when you read more about it, and research is the only way you kind of dive more deeper into one of the subject. And that's how you get attracted to that area. And then I had the opportunity to work with another lady. Her name is Dr. Namring Fong, and she is at Hopkins. And she is mainly, that time, was establishing her practice in ESD. And I got some research at Hopkins, and that's how I got attracted to those fields. And then I chose to go for interventional endoscopy field. So that's what I want to say, that choose a very good mentor who can guide you, like exactly which field you want to go into. And again, it all depends on your priority. There are many people whose priority is family, and that's fine. And there are many people who really love to work, so that's okay. So it all depends what you really want to do.
That's what Rohit and Dr. Bhushan Pandit trying to find out your priority and try to balance. And there are many other people. Dr. Panigra is a very senior gastroenterologist here. I think I can see Dr. Pati, I can see Preetham there, I can see many other people. So why don't you give your comments and thinking? You have spent sufficient time.
I'm feeling giddiness, so I'm sitting and telling, so I can't stand, so giddiness.
It's all right. Why you are getting dizzy?
I think so. AC is not working, maybe.
Okay.
So I am a general practitioner from gastroenterology point of view. I have not done excel in any field, neither in endoscopy, neither in IVD. But I am taking.
I think you are an excellent gastroenterologist. I have seen your work.
And at this age, I will not try to be excellent anyway. My family is important. My health is important. I do exercise for 1 hour or more every day. I give time for family, and I give time for the patients also. So after some patient reaching house, they may not able to read the medicine. They will send me. So I have to answer 10, 12 patients by either by WhatsApp or by direct doing phone, all those things. And that gives me satisfaction. Sometimes what happens, I was doing colonoscopy in the initial year. I had a perforation in the sigmoid. immediately, and they are not prepared. So I admitted the patient in a private hospital. I gave all my money. I called the surgeon. I gave my own blood for transfusion. I was sitting throughout the night near the patient, and he survived. He's still having good relations with me. So I think this is the most important is we should think patients as if our own relations. That is very, very important. And many times, so patient has come for some investigations, it is not done. By the time they get reports, it's night 7 o'clock. So after they'll tell us, you are not in the if they have paid in KIMS, they should not paid in clinic. Similar, somebody is soon in the morning in the clinic. If the report is over 2 o'clock, well, I'll come back 6 p.m. They want to go home, they can come to KIMS. I see there freely, and they'll go. So this should be relations like this. And once also one patient came with abdominal pain, and he's known to me. I was examining before finding the cause of pain. Within 1 hour, there was hypotension. He went to shock. He was put in ICU. He was not having, he told, I don't have money, what to do? So I gave my own pocket. He survived. 2.5 lakhs was spent from my own pocket. Till now, he has not given a single person to me. So that doesn't matter. That is very satisfying.
That's excellent. What Professor Dr. Panigra is bringing about, empathy, which is a general concept in medicine in general, empathy. And that's a human touch, which goes without fail. I agree with you. That is general across the discipline. The empathy is a very important concept which is being debated today, and ethics of medicine, which are different subject today, is very important. Communication, empathy, and ethics, 3 pillars of any discipline of any medicine today is extremely important.
Thank you, sir.
No doubt about Dr. Panigra, which you brought about. Right, that's fine. And I have very young gastroenterologists who are going to train hundreds and hundreds in future. We will be dead by then. What is your thought?
Sir, I would agree with most of our panelists, especially my contemporary Dr. Srihari and Nitin, that we should choose our priority. And definitely empathy should be a part, and I think in the long run, you should decide the priority, whether your career is your priority or your family is your priority. That is important. So that is where your family or your friends, they will prevent you from burnout. So
but why both cannot be priority? Why you are mutually exclusive?
Sir, what
they
I'm
can be
trying to
both
tell is
balanced.
both should
That's
be
what
the
everyone is
priority.
trying.
Your career should not be your only priority. That is a part of your life. That is not the whole entire life, whole life.
That's fine. But life in general is like that. थोड़ा यहाँ से, थोड़ा यहाँ से, थोड़ा यहाँ से मिलके ही जिंदगी बनती है प्यारे.
Yes, sir.
हाँ, ठीक है. Thank you. I think we should wind up. We have spoken a lot. I don't think you must be getting bored. So essentially, what all these wise gentlemen spoke to us, and I also learned that...
Sir, before you conclude, would you like to tell them about Kapil Dev's concept of work stress?
Why don't you tell yourself?
आप बताइए, sir.
Many of you have heard that interview. Isn't it Kapil Dev's interview? You see, playing cricket and winning test matches or T20 matches are exciting, but those who are playing under tremendous pressure, it is told. So they sometimes falter and do badly, excellent people. So in a television, Kapil Dev was asked this question, that what do you think about this tremendous stress and good player who is failing? So he couldn't understand. And this was repeated by Saurav Ganguly in a school interview. And I will tell both the person. He told, what is that stress in cricket? I played cricket because it was such a pleasure. Whether it is test or no test. When it is a pleasure, where is the stress? I just don't understand this. So don't ask me this question. And the same thing, Saurav Ganguly in a school was asked how to get away from the stress of the examination. He said, I will cite Kapil Dev's examination. If study is fun, right, examination is fun force multiplier. You get more pleasure, right? There should not be any stress. So that's why Professor Anand wanted me to narrate that if you have chosen a profession, it should give you pleasure. You should not get burnt out, what Rohit told. You should not get unhappy because neglecting your why. It should give you a pleasure, right? And pleasure comes from what Sarath told, empathy. Giving actually, right, smile to your patient. And while you excel in the area, right, that is the essence which Dr. Pandit wanted to bring out, that your life should be balanced, you should be happy, the patient should be happy, you should have money in your pocket, and you should have empathy, and technically you should be advanced. Right. That's what all of you are trying to suggest to these young people. A very difficult challenge, sir. Right. And that's why somebody told it has to be a personal. One size doesn't fit all. Thank you, ladies and gentlemen. You have heard very wise people. I have also heard and learned from that at this stage. But one thing I learned at the end of the day, enjoy your profession, be happy, and make your patients happy, whatever career you choose. Thank you. Thank you, Astos. Thank you, Dr. Noria. Thank you very much. Pleasure.
See, I'm the youngest, I can sit like this.
Hi.
We are the hosts and you are the hosts. Please.
विकास को छुपाओ मत, ये
अरे विकास सर, मैं विकास को यहाँ से
आदमी है।
वो पोएम करता है, मैं पोएम लिखता हूँ सर।
Thank you.
Thank you. Thank you.
Thank you so much, Subrat sir, Anil sir, for being with us and moderating this session. It was really insightful discussions. At the end, so as we conclude, we would like to take a moment to express my heartfelt gratitude to everyone who made this symposium a grand success. So, first and foremost, our sincere thanks to all our eminent speakers, moderators, chairpersons, and all our delegates as well for sharing their knowledge, expertise, and valuable time with us. Your contributions have truly enriched this symposium. I would like to thank all our staff from Sai Institute of Gastroenterology and Liver Sciences and all our technicians, even the technicians from our outside hospitals. And I would like to name a few of them. So Prakash, Sudhir, Kishore, Deepu, Premansu, Rahul, and Ganesh. Thank you so much. Without all of you, this wouldn't have been possible. Then a big, big thank you to our esteemed colleagues. So Jimmy sir, Preetam sir, Pratap sir, Bipat sir, and Sambit and Guru, Anurag, so for their support and involvement in making this event possible. Now, special appreciation, it goes to Aditi and her team for their immense effort in coordinating this event seamlessly, and Vishal Bhatt and his team for their creativity and hard work in designing the brochure. So we are also deeply grateful to our AV team led by Mr. Raju Babu and also Mr. Saroj Malia here, ensuring everything ran smoothly. A big shout out to our team from Olympus, so Santosh Babu, Siddharth, and Soumya, Bibhu, and Kamal from flying from Delhi and helping us here, and for providing us with their necessary equipments and for their exceptional assistance with the hands-on workshop. A heartfelt thank you to Boston Scientific and Cook and also Medora for their valuable presence and participation. A special mention goes to Kautuk and his team for their fantastic support in live streaming the event and ensuring our sessions reached a wider audience. So last but not the least, we extend our gratitude to our sponsors, Sun Pharma, Torrent, Dr. Reddy, Abbott, Cipla, and Ferring Pharmaceuticals for their generous contributions, which played a crucial role in the success of this conference. It's just very hard for me to name each and every one of you, but really, really thank you for all your help in making this event successful. This event wouldn't have been possible without the collective effort of each of you. So thank you for your dedication, collaboration, and support. We hope you found this symposium enriching and look forward to seeing you next year. Thank you so much. Thank you. Thank you for being here.